Here are a few pictures of the, during clinical examination we did. It's a slit lamp examination. And left eye shows diffuse rusty deposit in corneal stroma and without taking fluorescent stain. Shiny reflective structure in anterior part of vitreous can be seen just behind the posterior capsule and PCL of left eye. X-ray skull shows tiny radio-opaque foreign body in left orbit superiorly around 12 o'clock position. When we sent for CT scan, there was hyperdense content showing minimal hardening artifact in anterior segment of the left eyeball, suggestive of foreign body. We did B scan also. There's small echogenic lesion about 1.5 mm seen abutting posterior capsule of lens of left eye, likely foreign body echogenicity seen in posterior chamber, suggestive of vitreous degeneration or hemorrhage. This is a fundal photograph, and on OCT we can see the degeneration of photoreceptor layer. Result, a clinical presentation along with ultrasound, B scan, X-ray, CT scan confirmed the diagnosis of a metallic intraocular foreign body. Retina was attached, retina was normal, neuroretinal rim normal, and foveal reflex was dull. Patient underwent intraocular foreign body removal via pars plana vitrectomy. After 6 months, his best corrected visual acuity improved to 6/12 partial in left eye, and photophobia reduced, although clinical status of corneal stroma remains same. My conclusion of the case is that the traumatic cataract need detailed eye examination from anterior to posterior segment and need further investigations like ultrasound B scan in case of non-visualization of posterior segment so as not to miss treatable visual threatening pathology like intraocular foreign body or retinal detachment, and to plan proper treatment strategy to prevent further visual loss. And in case of doubt, further investigation like X-ray and CT scan is needed to confirm intraocular foreign body. Even after cataract surgery, patient history, complaint, and detailed examination can help in identifying further visual threatening pathology which can be missed at initial stages. And it is very crucial to identify and remove metallic foreign body as early as possible to prevent the risk of visual loss or phthisis bulbi. Thank you.
Good morning.
Good morning, sir.
It's a nice presentation.
Thank you, sir.
My question is, it is a case presentation.
Yes, sir.
Have you any experience before this case also?
So, usually this type of case is rarely seen as it is being missed by an ophthalmologist who has operated for cataract surgery. So already patient thought he has been treated for the disease what he got at the initial stages. But after 5-6 months he started feeling that photophobia is there, and the vision was not so crisp what he was expected after a cataract surgery. So he started visiting different ophthalmologists, and we somehow find the pathology just behind the lens.
How many cases you have encountered before this type of case?
So this type of case we have seen first time in our setting.
Okay.
Actually, it was a nice presentation, but thing is that it is the investigations, yes. Investicon. So how your investigations has surpassed your clinical examinations and the history, because the history is very important over here, and somehow rather it was ignored because there was a history of trauma, but we are now banking upon total on this investigation. So what is your take?
So investigation in these cases are very important, as in today's time we are facing the Consumer Protection Act and everything. So investigation gives us the clue that we can have it as a proof with us, because somehow one ophthalmologist has operated, and if he has operated and he hasn't done anything for behind, that means he was telling it's normal, and we are telling there's a pathology behind. So we need a proper proof also for what we are diagnosing, and in this case these investigations gave us the edge.
Thank you.
Thank you, sir.
Thank you, Dr. Sharath. I would like to invite the second speaker, Dr. Surbhi Gupta, to present the topic, Role of Autoacoustic Emissions in Universal Infant Hearing Screening, a Prospective Analytic Study.
नीचे होगा ना, आपने नीचे करा है, सेव करा है ना बाहर फोल्डर में, चेंज कर दिया क्या? पक्का बी वाला है ना? Good morning everyone, I am Dr. Surbhi Gupta, here to present a paper on role of autoacoustic emission in universal infant hearing screening. It is a prospective analytical study. Introduction. Speech and language development depends on the normal hearing. Hearing loss initial signs are very subtle, and routine neonatal hearing screening is a most effective tool for early detection. Early diagnosis and immediate intervention play crucial role in the development of the prognosis of child with hearing disabilities and lower the impact of the condition on the child's social, emotional, intellectual, and language development. OE, autoacoustic emission, are the sounds which originate in the cochlea. They can be easily recorded by a special microphone plugged in the EAC. OE sounds are produced by the movement of the cochlea sensory hair cells as they energetically respond to auditory stimulus. OE provides a simple, efficient, and non-invasive objective indicator of healthy cochlear function. OE screening is widely used in the universal newborn hearing screening program. Aims and objective. The study aimed to assess the incidence of the hearing impairment in the standardized population of infant, comparing the efficacy of the screening protocol by OE and the confirmation by the BERA, and explore the association of the epidemiological and risk factor with infant hearing loss. Materials and methods. It is a prospective analytical study. Duration is December 2022 to May 2024. Child aged 36 are to 1 year of age were categorized into at-risk and no-risk group. Inclusion criteria were infant without gender bias, born in or attending the hospital. Exclusion criteria, middle ear pathology, meatal atresia, and parental refusal. Subjects underwent screening when transient evoked OAE and re-screening by the distortion product OAE and BERA for the confirmation. Materials and methods. The test equipment is micro impedance meter Aeroscan TM. Initial screening was with transient evoked OAE was done for both at-risk and not-risk infant. Re-screening with the distortion product OAE for those who failed with the TEOE test was done after 1 month of the test. Confirmation of the hearing loss with BERA for those who failed with DPOE test was done. All these are the risk patient. At-risk group. This is the result we can see in the pie chart. Males are the slightly higher affected than the female. Incidence of the hearing impairment. Among the 100 infants screened, the incidence of the hearing impairment was observed in 2 cases. Specifically, 1 case was identified in the group of 80 infants, classified as the no risk, and another case was detected in the subgroup of 20 infants, categorized as the at risk. Consequently, the incidence of the hearing loss was higher in the at risk group compared to no risk group. In the at-risk group, 90 newborn were admitted for the neonatal intensive care unit. Among these, 1 newborn was confirmed to have the hearing loss. The major risk factor identified in this case was severe birth asphyxia. Result of the initial TEOA screening in the no-risk group, 10% of infants in the no-risk group were referred for the further evaluation following in the initial TEOA screening. Fallout rate for the re-screening in the no-risk group. Upon the re-screening, there was the fallout rate of the 37.5 in the no-risk group, indicating a notable proportion of the infant not returning for the follow-up. Result of the initial TEOE in the at-risk group, 15% of the infant in the at-risk group were referred for the further evaluation following the initial TEOE screening. Fallout rate for the re-screening in the at-risk group was the 0%. Fallout rate is less in the at-risk patient. This is the flow chart we can see. Conclusion. On conclusion, the study advocate for the universal infant hearing screening, emphasizing the necessity of the screen, rescreen, and confirmation protocol using OE and the BERA. Recommendation includes screening within the first 4 weeks, rescreening within the immunization within 1 month, and initiation of the appropriate intervention within 6 months. The study underscores the importance of the considering both risk and at-risk or the no-risk population in the infant hearing screening program. The study reveals risk factor birth asphyxia associated with the neonatal hearing loss. Thank you. All these are the references.
Thank you, Survi, for your excellent presentation. But as a NICU in charge, I just want to know how many premature infants have undergone from this hospital for that autoacoustic emission test? How many premature babies from our NICU has visited your department for the OAE?
Sir, 20.
20?
Yes, sir. Sir, in my duration study period.
Yeah, your duration only. And how many patients you have seen with the child, babies presenting with connectors, faulty OAE?
Sir, connectors, we see the at-risk patient according to referred by your department, and see the if its APGAR score is less than 5, then we will consider at the at-risk patient.
So you are just doing only on the babies who have suffered from hypoxic ischemic encephalopathy, not connectors, not premature.
No, sir, we will consider the premature baby.
So your inclusion criteria, can you show me the inclusion criteria? Inclusion criteria, yeah. The infants without gender bias born in attending, so you were doing all the babies?
All the child, yes, sir.
All the babies,
Yes, sir, all
not
the
only the premature or the at risk.
No, sir, it is the screening.
But
for
I am
all
very
the-
unfortunate fellow. The heading that department, I have never seen a single baby undergoing OAE.
Sir, we got referred patient because we are getting patient. We have.
That you have not sensitized. I just appeal to your department to sensitize our PGTs to send the patient or the babies to your department, so that we are just
Yes, sir.
wondering how can I send the patients and where. In fact, a 60-gram baby was discharged a week back.
Yes, sir, we
And
are
it
getting-
was the baby delivered by Chandni ma'am. So we have to send somewhere else.
Yes. Sir, actually we are getting patient and we have file. We are asked to junior resident to send us patient more so we can.
Okay, nice presentation. It was also my question, so it's all over.
Thank you very much, Dr. Surbi. Now, I would like to invite on stage Dr. Hemant Reddy to present on the topic, role of MRI in evaluation of compressive myopathy. Dr. Hemant Reddy, are you here?
Sorry, Dr. Hemant Reddy is not here. We'll proceed our program to the next speaker. I would like to invite on stage Dr. Shubham Dwivedi to present the topic, role of MRI in the evaluation of primary bone tumors.
A very good morning to all of you. I'll be presenting my paper on role of MRI in the evaluation of primary bone tumors. Bone neoplasms can be broadly classified as benign and malignant. Most of the malignant neoplasms are metastatic in nature, primary being only 30%. Bone tumors and tumor-like conditions encompass a complex and variegated group of disorders requiring the combined efforts of these orthopedic surgeon, radiologist, pathologist for appropriate management and staging. Current study was designed to assess the accuracy of MRI in local staging of primary bone tumors, and also to study the signal characteristics of primary bone tumor and correlate with surgical and pathological findings. The aim and objective of the study was to see the role of MRI in the finding of the primary bone tumor and to help differentiate between benign and malignant tumors. Material and methods. Study was done in the Department of Radiodiagnosis in KMC, Bihar, Katihar. All patients presenting to the orthopedics department with a clinical suspicion of bone neoplasm were first evaluated with plain radiographs taken in at least 2 different projections. After clinico-radiological analysis of the plain radiographs, patients with a high suspicion of primary bone neoplasm or conditions mimicking them were referred to the radiology department for further evaluation with MRI. 41 consecutive patients were enrolled for the study during the duration period of 1 year. The exclusion criteria was patients lacking a histopathological diagnosis, patients unfit for MRI, or patients who were unwilling for follow-up. The MRI images were evaluated on the following lines: location, signal characteristics, margin, edema, contrast enhancement, intramedullary tumor length, and neuromuscular involvement. MRI was performed with a 1.5 Tesla MR imaging system. Patient was positioned head first and supine into the gantry. Initially, T1 weighted imaging was obtained in 3 planes. T1 spin echo images were obtained in region of interest in the coronal and sagittal planes to delineate the lesion. This was followed by sagittal and coronal stir sequences and axial T1 and T2 weighted images. T2 gradient echo images were also taken if hemorrhage was suspected. Large field of view T1 or stir image including the entire bone in the coronal or sagittal plane was also taken to identify any skip lesions. Post-contrast weighted images were obtained in all 3 planes. Results: 41 patients were enrolled during the study. 18 patients had primary bone malignancies, out of which 2 were in the spine, plasmacytoma and chordoma. 10 patients had metastatic disease including systemic lymphomas and secondary bone involvement. 11 patients had benign bone lesions and 2 patients had osteomyelitis. 9 lesions were located in the axial skeleton, out of which 5 were in the spine. 16 lesions were in the appendicular skeleton, with the lesions around the knee joint being the commonest. Osteosarcoma was the most common primary malignant bone tumor, and giant cell tumor was the most common benign bone tumor in our study. This is the number of patients diagnosed with various bone tumors and their mean year of age while diagnosis. The most common being osteosarcoma and metastatic including secondary lymphoma. This again shows the frequency of various bone tumors, with osteosarcoma and metastasis being the more predominant ones. Here is an image in coronal and sagittal section, which shows a large metaphyseal bone tumor involving the proximal and mid tibia with bony destruction, with a large soft tissue component and aggressive periosteal reaction. The following DDs were made: osteosarcoma and Ewing's sarcoma. This is a bone tumor-like lesion, like reduced vertebral body height of C4 and C5 with the altered marrow signal intensity of C3 to C6 vertebral body involving the disc with the reduced disc space. The epidural collection was seen compressing the spinal cord at these levels, which appears homogeneously hyperintense on T2 weighted imaging, which was suggestive of pot spine. This is another example where there was collapse of C4 vertebral body with altered marrow signal intensity of the body and posterior elements on the left side appearing hypointense on T1, heterogeneously hypointense on T2, and another small altered signal intensity lesion with heterogeneous enhancement involving anterior part of C7 vertebral body with multiple and large lymph nodes, which was suggestive of metastasis. There's another one. This is a lobulated soft tissue subarticular lesion of altered signal intensity in the flexor aspect of distal forearm, which was iso-intense on T1 and hyper-intense on T2. On post-contrast, a strong inhomogeneous enhancement of the mass seen, which was likely a reoccurrence of giant cell tumor. To conclude, MRI is a very accurate tool for staging the primary bone malignancies and should be obtained wherever possible. In case of a suspected primary bone malignancy for accurate annealing staging, STIR and T1 weightage images are equally efficacious for measuring the intramedullary and extraosseous tumor length, and either of one can be used for the same. And though MRI does not allow a specific diagnosis, but it can be advantageous in surgical staging, and in a few cases, it does contribute to vital new diagnostic information. Thank you.
Thank you, Dr. Shubham. So I just want to know, in your study group, you have shown 2 patients as osteomyelitis.
Yes.
How the bone tumors and osteomyelitis has been put into that facet?
So it was like bone tumor-like lesions to separate, to differentiate
So
between.
your study group was bone tumor-like lesions?
Yeah, to differentiate between bone tumor and tumor-like conditions, like benign conditions also, like osteo.
Just tell me, which, I am giving you the choice, which one is more specific of diagnostic at the earliest, the osteomyelitis? Chest X-ray, USG, CT and MRI. You can pick up at the earliest which modalities of investigation.
Sir, chest X-ray, sir. X-ray, sir.
X-ray, no, it will take at least 2 weeks. It is ultrasonogram.
Okay.
It is ultrasonogram. We can see the vacuoles in the marrow, bone marrow.
Dr. Shubham,
Yes, sir.
have you given your references?
Sir, I had references, but since the requirement was only 12 slides, so I excluded them.
And the technique of MRI was lengthy. You can cut short there.
Yes.
There is no need of technique of MRI in this presentation.
Sorry, sir, I'll keep in mind the next time. I'll present.
Any histopathological correlation?
Yes, sir, all these cases were sent for histopathological analysis, and only after the confirmation were they followed up. Those which were not, did not have histopathological analysis, they were not taken up for the studies.
You have not given any slide on this histopathological correlation. In what percentage of cases you have confirmed your result with histopathology correlation? No confirmation in histopathology.
Sorry, sir, because of the limited number of slides, I had to.
Okay, okay, thank you.
Okay, thank you, sir.
Thank you, Dr. Subal. Next, I would like to invite on stage Dr. Pooja Kumari to present on the topic reversible posterior leukoencephalopathy syndrome.
Good morning to all respected delegates. Myself, Dr. Pooja Kumari, Junior Resident of Department of Radio Diagnosis from the Katihar Medical College. Hereby stand you before all to represent my oral presentation on reversible posterior leukoencephalopathy syndrome. A journey through MRI in pre-eclampsia and eclampsia females. Introduction. Reversible posterior leukoencephalopathy syndrome was described for the first time as a distinct entity in 1996 by American neurologist Judith Hinche. The hallmark feature involves inability of the posterior circulation to auto-regulate in response to acute changes in blood pressure. Hypoperfusion with resultant disruption of the blood-brain barrier results in bilateral vasogenic edema, usually without infarction, primarily affecting parieto-occipital regions. It can be found in a non-posterior distribution, mainly in watershed areas, including within the frontal, inferior temporal, cerebellar, and brainstem regions. Both cortical and subcortical locations are affected. Uncommon patterns in less than 5% includes purely unilateral, central, brainstem, or basal ganglia with or without cortical or subcortical involvement, spinal cord involvement. Etiologies are severe hypertension, which includes postpartum pre-eclampsia, eclampsia, acute glomerulonephritis, hemolytic uremic syndrome, thrombocytopenic thrombotic purpura, systemic lupus erythematosus, drug toxicity, bone marrow or stem cell transplantations, sepsis or sickle cell anemia, and ventriculoperitoneal shunt insertion or over shunting. Clinical features are headache, seizure, encephalopathy, acute confusion or altered mental status, or decreased level of consciousness, visual disturbances including reversible cortical blindness. Pathologies, 3 main precipitation theories have been proposed. First one, high blood pressure breakthrough theory leads to loss of self-regulation, hyperperfusion with endothelial damage and vasogenic edema. Second, vasospasm theory results in local ischemia and hypoperfusion. Third, endothelial dysfunction secondary to circulating endogenous or exogenous toxins. Aims and objective to evaluate the MRI characteristics, investigate and present the distinctive MRI findings of RPLS in females with eclampsia and preeclampsia, to enhance diagnostic precision, explore how MRI contributes to the accurate and timely diagnosis of RPLS in eclampsia and preeclampsia. Materials, the observational study was performed in Katihar Medical College, Department of Radiodiagnosis from October 2023 to June 2024 on 75 females. All were evaluated with clinical history. MRI of brain on 1.5 Tesla GE Brevo MR355 was performed in the postpartum period within 48 hours of delivery. Methods, after obtaining approval from the Institutional Ethics Review Committee, a hospital-based cross-sectional study was conducted. The study groups consist of 75 female patients who presented to the Department of Obstetrics and Gynecology and Radiology for the assessment of RPLS syndrome within 48 hours of delivery. We included both inpatient and outpatient with eclampsia and preeclampsia with or without neurological symptoms. Informed consent taken from the patients before undergoing MRI scans. Medical records of all patients were retrospectively evaluated. All patients underwent MRI scans with a phased array surface coil, obtaining T1 weighted, T2 weighted, and fat suppressed T2 weighted images in all the 3 planes. Gradient recoiled echo, diffusion weighted images, and 3D space sequences were also acquired. The first picture describes a 25-year-old female with history of severe hypertension during pregnancy. MRI shows few foci of T2 weighted or flare hyperintensity in bilateral parietal lobe and left frontal lobe. The second picture describes a 20-year-old female with history of headache and hypertension during pregnancy. MRI shows patchy areas of hyperintensity in bilateral cerebral hemisphere. The third picture describes a 27-year-old female with history of eclampsia. MRI shows patchy areas of hyperintensity in right frontal and left parietal lobe. Results. This study assessed MRI findings in 75 females, 30 of them with cerebral symptoms, that is headache, visual disturbances and altered mental status, 30% of severe preeclampsia who were neurologically asymptomatic, and 15 of eclampsia patients. RPLS was identified in 86.7% of patients in the eclampsia group, also in 20% and 26% symptomatic and asymptomatic severe preeclampsia. Conclusion. Our exploration of reversible posterior leukoencephalopathy syndrome within the framework of preeclampsia and eclampsia underscores the critical role of MRI imaging in early identification and management. The integration of MRI findings not only aids in diagnosing RPLS but also provides invaluable insights into the neurological alterations occurring in this unique obstetric population. Timely recognition of RPLS syndrome through MRI facilitates prompt intervention, potentially averting severe neurological complications. Summary. This presentation aims to underscore the crucial role of MRI-based assessment in optimizing patient outcomes and mitigating the neurological risk associated with RPLS in pregnant individuals affected by preeclampsia and eclampsia. Thank you.
It was Pooja. Pooja, you have given in your study group that 86% of your study group with the preeclampsia has got this RPLS. So what, is there any reference or any other study group that supports your finding? Because I think this number is too high. In preeclampsia, we have seen preeclampsia a lot of time, but how many patients? 86 means Out of every 10 patients, we are getting 8 patients with these features in MRI.
No, sir, out of 10,
Can you cite me any study that has that will second you?
Yes, sir. Retrospective study was done, and there was finding of in any eclampsia patient, it is the finding of the result. Not in every obstetric population. This is the findings.
Dr. Pooja,
Yes, sir.
nice presentation,
Thank you, sir.
but I think where is your inclusion, exclusion criteria and references?
Sir, the same, because of 20 slides limited, so I have excluded this.
But both are important, na? Inclusion,
Yes, sir.
exclusion criteria in your this paper presentation.
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you very much, Dr. Pooja. Now I would like to invite Dr. Hemant Reddy to present on the topic role of MRI in evaluation of compressive myelopathy.
Good morning, everyone. Myself, Dr. Hemant, a junior resident from the Department of Radio Diagnosis, Katihar, Medical College, Katihar. And my topic for today is the role of MRI in the evaluation of compressive myelopathies. Aim and objective of the study is to evaluate various cases of compressive myelopathy and to accurately localize them as extradural, intradural, extramedullary, intramedullary by the uses of MRI. Material and methods. The study was conducted in the Department of Radio Diagnosis at Katihar Medical College, Katihar, over a period of 1 year, and 30 patients were taken for study. And this study excludes those patients with compressive myelopathy because of degenerative changes of the disc. Inclusion criteria: all age groups, both the sexes, all cases of compressive myelopathy, and exclusion criteria is cases of non-compressive myelopathy and degenerative disc herniation cases. Protocols: MRI performed using GE 1.5 Tesla, which was available over there, using standard surface coils and body coils were used for cervical, thoracic and lumbar spine for acquisition of images. And all the possible sequence in axial and SAG required sequences of T1 weighted, T2 weighted, FLAIR and STIR were taken. And wherever required, Omniscan or Magnavist contrast was used. The results: the most common cause for spinal cord compression turned out to be spinal trauma with 43.3% cases, and a spinal infection was the second cause of compressive myelopathy, and in that TB was the major cause, together 23.3%. Out of 30 cases, 25 were when they were localized, 25 were extradural compressive lesions, out of which 13 were from spinal injury, 7 infectious spondylitis, and 1 is epidural abscess, and 5 were intradural extramedullary lesions. And the causes of compressive myelopathy include traumatic myelopathy. Out of 30 cases, 13 were from traumatic myelopathy, constituted about 43.3%, and infection stood second with 7 out of the 30 cases, 23.3%, and primary neoplasm and followed by metastasis, 5 and 5, 16.7%. Location of the pathology. MRI was a very useful technique for locating where the pathology lies, and out of the 30 cases, extradural was 25 cases, which turned out to be 83.3, and intradural extramedullary was 5, 16.7. Causes according to various compartments. Spinal injury is in 13 patients out of the 30, that constituted 43.3%. Infective, in which TB was the major cause, was around 7 cases, 23.3%. And primary neoplasm or METs turned out to be 16.7%. And secondary neoplasm or METs, another 5 cases, which is 16.7% again. And spinal epidural abscess, there was one single case, which constituted 3.3%. The site of metastasis, cervical, thoracic and lumbar, when they are localized. There was one case of metastasis in cervical spine, and in the thoracic, upper thoracic there are 2, lower thoracic there are 2, and in the lumbar there was one case of metastasis. And also there was analysis on the distribution in age, gender and compartments. And a few of the cases that were very interesting were a 24-year female presented with lower back pain and a weakness of right lower limb. And it turned out to be an intradural extramedullary cause of compressive myelopathy, and that's schwannoma. Another case was a 60-year-old male patient presented with severe back pain and lower limb weakness. It turned out to be an extradural lymphoma. Another case was 75-year male patient, a known case of carcinoma prostate. In these cases of carcinoma prostate, the usual site of metastasis is vertebral. So in this case, there is sclerotic metastasis that is seen. And another was a 69-year-old male patient present with fever, back pain and difficulty in walking and bilateral lower limb weakness. And it turned out to be a tuberculosis of spine. Another was a 19-year-old male presented with fever with back pain and sudden onset of weakness in both lower limbs. And that turned out to be an epidural abscess. Another was a 50-year-old male patient present with weakness of bilateral lower limbs with old history of trauma. This is a picture of traumatic myelopathy with the retropulsar fracture fragment. And the discussion is the ability of MRI is to show the spine and spinal cord with greater sensitivity and specificity than myelography and CT. And most common cause for spinal cord compression is spinal trauma, 43.3%, and spinal infection, 23.3%. And out of 30 cases, 25 were extradural compression lesions, and 5 were intradural extramedullary lesions. In our study, the level of injuries among the 13 patients were in the thoracic level for 53.8%, and in the cervical level 46%, and lumbar 15.4%. This is comparable to the study conducted by Kerslake at 25. The spinal cord abnormalities demonstrated by MR imaging were cord compression and abnormal signal intensities within the spinal cord. Spinal cord compression was observed in all the 13 cases. Abnormal signal intensities from spinal cord were observed in 12 of the 13 patients. On one patient has got no cord changes. 12 patients showed hypointensity on T1 and hyperintensity on T2 on FLAIR images, suggestive of cord edema. These signal changes are consistent with studies done previously. And when the gadolinium was used in 3 out of 5 patients which showed mild homotoheterogeneous enhancement, observation has shown that post-contrast MR does not improve the detection of extradural spinal metastasis, even though it has great value in intradural disease. And we had 5 cases of primary intradural extramedullary neoplasms, among which 2 were neurofibromas and 3 were meningiomas. All the 5 cases showed spinal cord compression. Of the 3 cases of neurofibromas, MR diagnosed 2 cases as neurofibroma. And in one case, MR could not differentiate between meningioma and neurofibroma. Neurofibromas were iso-to-hypo on T1 and hyper on T2 and showed intense enhancement and post-contrast. One case showed extension to the neural foramina. On MRI, conclusion, MRI is a definite modality in assessing soft tissue of the spine and spinal cord abnormalities. It's the best modality of evaluate cord edema. And it's very sensitive and considered the imaging modality of choice to detect and characterize the spinal tumors and spinal infections. And it could successfully characterize the spinal tumor based on location into extradural and intradural and assess the integrity of the spinal cord. Thank you.
Dr. Hemant, it was a nice journey to see your MRI cases. But I'll just give you one advice, that make your presentation very lucid and very eye-friendly. The background that I've used, that is doing some illusion. So I'll just make a very simple slide, so that it can be very pleasant to the eyes, and too much of lines, not more than 6 lines in single. The slides were very busy. Your content was excellent, but the thing is that you have make all your slides very busy, so nobody will be able to read it. You can just pick up some of the points and you can explain, you can tell.
Yes.
But not everything should be written over there. And what is your study time, duration?
It was for 1 year.
So where have you written?
Sorry, sir?
Where have you written? Where study period, एक study period होता है ना? So
Yes, sir, it was mentioned in the presentation for 12 months.
Show me, please, the time frame.
This here, sir. Study participant.
Study design. Study
In the
design.
last line, Department already organized at Katihar Medical College for a
From
period of time.
which period? From which? No, no, कब थे? From which time? Say,
Sir, during my first year period, it was between.
I don't know, because I
Yes, sir.
don't know.
Sorry.
I'm not familiar. So it might be a case of June 23 to May 24.
No, sir, it was actually from Jan to December of
So
2023.
you should have written
Yes,
that.
sir, I should have.
You should have written that.
Yes, sir.
So that is my request, because you will be presenting in more places also. So
Yes, sir,
this
sure.
is just for your correction.
Sure, sir. Thank you, sir.
So one point was slide quality that is already discussed.
I'm going to correct that,
And,
sir.
and from pathology side, have you confirmed your cases of second most common causes, that is infections or TB?
Yes, sir.
How you have confirmed?
No, sir, I have done just a cross-sectional study, and
You
I
have
limited
done-
my study only for the radiology department. I have not followed them up.
Not followed.
Not followed them up.
Okay. Okay. Good. Yes, yes.
So see, both the judges have already commented on it. You are a budding radiologist, so I don't know how much possibility there is that you will become a medical teacher. But then, since sir mentioned about your busy slides, there is a dictum that you can only use 6 sentences in one slide, and each sentence should comprise of 6 words, not more than 6 words. So otherwise your slides become busy. And if at all you are having to use more than 6 sentences or more than 6 words in a sentence, it is advisable that you use animation in your sentence, so that one sentence comes after another, not all sentences together. So if all sentences come together, it becomes very crowded. And one more thing is, see, you have used all caps in the sentence, and that is the reason that duration was not, it did not come to our eyes. So if you use all caps in your sentence, that also becomes, it illusions your eyes. That becomes a little bit of a problem to the eyes to catch that thing. So you should not use all caps in a sentence. So these are some, because see, you have given a nice presentation, you will be presenting in different platforms. So these are some tips to remember for your next presentation.
Sure, sir, I'll
Okay?
keep them in mind.
Yeah, thank you.
Thanks for the inputs.
Thank you, Dr. Hemant. Now I would like to call upon next speaker, Dr. Rima Saxena, to present the topic posterior segment optical coherence tomography for the diagnosis and management of ocular pathology.
रीमा सिन्हा पॉइंटर चाहिए होगा Good morning, everyone. This is Dr. Rima, Junior Resident, Second Year, Department of Ophthalmology, MGM Medical College. I'm presenting my paper on posterior segment optical coherence tomography for the diagnosis and management of ocular pathology. Optical coherence tomography is an in vivo diagnostic imaging which is non-contact, non-invasive and enables cross-sectional study of layers of the retina in micron resolution and correlates very well with retinal histology. It utilizes a concept known as low coherence interferometry to create a cross-sectional map of the retinal layers that is accurate to within at least 5 to 8 microns, which allows imaging of the neurosensory retina, retinal pigment epithelium and the choriocapillaries. The first OCT image was demonstrated by David Wang in 1991. This is the principle of interferometry, where a light source creates two rays which are perpendicular to each other. This is the tissue light which is reflected and the reflected light from the reference mirror. Both has to be in the same phase and the same wavelength to form constructive interference, which is then detected by the photo detector, and the depth and the reflectivity of the tissue is measured. Types of OCT are time domain OCT, spectral domain OCT and swept source OCT. This is the normal OCT finding of the retina, where this is the fovea and this is the rest of the retinal layers. The objective of my study is to explore the principles and the technology of the posterior segment OCT, to discuss the clinical applications of the OCT in various ocular disorders, to evaluate the role of OCT in enhancing diagnostic accuracy and guiding management decisions, to highlight the challenges and future prospects of posterior segment OCT in ophthalmology. The methodology used is a meticulous history and baseline information of the participants about the symptoms, ongoing medications, surgical procedure, trauma, smoking, alcohol consumption, etc. Torchlight examination for pupillary reflex followed by slit lamp examination to rule out any anterior segment abnormalities. Patient is dilated with dilating drop consisting of 0.8% tropicamide and 5% phenylephrine for adult and 0.5% tropicamide and 2.5% phenylephrine in children below 4 years. Slit lamp examination of posterior segment with 90D lens or indirect ophthalmoscope examination with 20D lens is done. OCT for posterior segment imaging is then done. These are the results. The first case is full thickness macular hole. There is a full thickness loss of the retinal tissue throughout the holes with sharp edges perpendicular to the retinal pigment epithelium. The edges are round, thickened, and there is area of no optical reflectivity. Complete posterior detachment is present. The presence of intraretinal and subretinal fluid is also present. The patient presented with visual symptoms of central metamorphopsia and loss of visual acuity in the range of 6/18 to 6/60. Pars plana vitrectomy with tamponade was planned. The second case is of the optic disc, where this is the normal optic disc containing the retina and the choroid, and here the condition is papilledema, where the retinal nerve fiber layer opacification can be seen along with the elevation of the disc margins and hyperemia and obliteration of the cup. Peripapillary total retinal thickness. Patient came with complaints of intense headache which aggravated with change in posture. The third case demonstrates cystoid macular edema and diabetic retinopathy. Diffuse retinal thickening of greater than 650 micrometer with cystic area of low reflectivity, honeycomb appearance, more prominent in the luminal nuclear and the outer plexiform layers of the retina. The flame-shaped hemorrhages were present superior and inferior to the disc. Patient came with complaints of blurring or distorted vision with defect in color sensitivity. Treatment was done intravitreal triamcinolone along with IOP lowering agents. Stimulol 0.5% was given. Age-related macular degeneration non-executive, the areas of hypopigmented retinal epithelium patches. These are called drusen's, which are accumulation of proteins, lipids or mucopolysaccharides between the Bruch's membrane and the retinal pigment epithelium. RPE deformity is seen and there is undulations. Subretinal fibrosis can also be seen. Patient presents with minimal visual loss with central shadowing. Posterior segment OCT represents a transformative advancement in the field of ophthalmology, particularly in the early detection, management, and the follow of the prognosis of the clinical pathologies. It is a revolutionary diagnostic tool in the era of modern retinal treatment. It predicts the visual outcome, the diagnosis and the follow-up of the optic nerve disease, and monitor the treatment of macular and optic nerve disorders. Thank you.
It was excellent presentation, and
Thank you, sir.
visual pleasure is too much. But you have not done any study, no?
Sir?
Yeah, how many cases you have done? This is a case presentation.
Yes, sir.
Okay. So this was a single patient that you have seen.
Yes, sir. I have taken one cases of each retinal finding, and I have shown the importance of OCT in diagnosis of those findings.
Yeah, I got it. But in demyelinating macular degeneration, what is the treatment of choice?
Sir, normally non-executive phase, there is no treatment is required. We send the patient for lipid profile, and we see the lipid profile report of the patient, and we treat accordingly. Well, in executive phase, we do laser, sir.
So what is the role of the superoxidants in the DMD?
Sir, superoxidase is an
Lutein, xanthine,
Yes,
and
sir.
this superoxidase molecule has got some role in the DMD?
Sir, pardon, sir?
In demyelinating macular degenerations,
Yes, sir.
what is the role of the superoxidant?
Sir, the retinal tissues are very degenerated because of the iron releasing because of superior oxide dismutase.
So you want to
Radical.
just see periodically that OCT and see how much it is progressing or whether it is arrested, and
Yes,
there
sir.
is some dubious role in it, because I am the patient of that.
Okay, sir.
Okay, nice case presentation, in fact, not
you,
case study. What is the role of OCT in CRVO?
Sir, central retinal vein occlusion, sir, in the OCT actually tells us the presence of hemorrhages, which is mainly present in the inner nuclear layer and the outer plexiform layer. And it also helps in the management. We treat the patient accordingly, and then we call the patient for every 3-month follow-up to see the progression of the diseases.
And what is the recent management of CRVO?
Sir, laser, sir. Laser.
For complication purpose or for
No, sir, for treatment purpose only.
treatment
Yes, sir.
purpose? Okay, thank you.
Thank you, sir.
Thank you, Dr. Rima. Now, I would like to call upon the next speaker, Dr. Fahad Rahman, to present on the topic Mullerian anomalies, spectrum of appearance in MRI.
Hello. Good morning, everyone. I am Dr. Fahad Rahman, second year PGT in the Department of Radio Diagnosis in KMCH, Katihar. I am here to present my poster on Mullerian anomalies, spectrum of MRI appearance in primary amenorrhea patient. Introduction. Mayer-Rokitansky Custer-Hauser syndrome, also known as Mullerian aplasia, is a congenital anomaly characterized by vaginal and uterine aplasia or agenesis. It is usually associated with a spectrum of genitourinary tract abnormalities. MRKS syndrome belongs to class 1 Mullerian duct anomalies. Two different forms are described. The typical form type A, characterized by congenital absence of uterus and upper 2/3 vagina with normal ovaries and fallopian tubes. The typical form type B, associated abnormalities of the ovaries and fallopian tubes and renal anomalies. This case research study explored the clinical presentation, diagnostic challenges, treatment option and psychological aspect of Mayer-Rokitansky Custer-Hauser syndrome through a comprehensive examination of individual cases. By analyzing real cases. This research aims to contribute to the broader understanding of MRKS syndrome and improve patient care. MRI is integral in diagnosis, planning, treatment, and offering psychological support for individuals with MRKS syndrome. Diagnosis confirmation. MRI is the primary tool to confirm MRKS syndrome diagnosis. Visualize uterine and vaginal abnormalities. It accurately shows absence or hypoplasia of the uterus and upper vaginal canal. Differentiate MRKS types. Help distinguish between type 1 and type 2 MRKS syndrome. Assess associated anomalies. Evaluates other congenital anomalies like renal abnormalities. Treatment planning. Aids in planning surgical intervention like neovaginoplasty. Monitor treatment outcome used to track neovaginal development and treatment success. Provide psychological support. Helps patient understand their condition visually. Support research and education. Primary images, MRI images contribute to medical research and education. Aims and objective. Aims: anatomical assessment, characterization of associated abnormalities, preoperative evaluation. Objective: visualization of uterine anomaly, identification of vaginal canal, renal assessment, skeletal evaluation, tumor or mass detection, assessment of post-surgical outcome, patient counseling. Materials. The observational study performed in Katihar Medical College Department of Radio Diagnosis on all female patients with primary amenorrhea from April 2022 to August 2023. All were evaluated with clinical history and initial USG abdomen. Subsequently, MRI of abdomen and pelvis on 1.5 TGE Bravo MR 355 was done. Method. After obtaining approval from the Institutional Ethics Review Committee, a hospital-based cross-sectional study was conducted. The study group consisted of 46 female patients who presented to the Department of Obstetrics and Gynecology and Radiology for the assessment of primary amenorrhea at a tertiary care center from April 2012 to August 2003. We included both outpatient and inpatient with primary amenorrhea and clinical suspicion of uterine anomalies. Informed consent was obtained from the patient, parents or guardian before undergoing MRI scan. Medical records of all patients were retrospectively evaluated. Initial ultrasound mode MRI scan. All patients underwent pelvic MRI scan with a phased array surface coil obtaining T1W1, T2W1 and fat suppressed T2W1 images in all three planes. Gradient recall echo, diffusion weighted imaging and 3D space sequences were also required. MRI of the abdomen and pelvis of 18-year-old female, axial section showing complete absence of uterus, cervix and vagina with normal ovaries and coronal section displaying single midline pelvic pancake kidney. 16-year-old female patient with primary infertility, T2 weighted and fat suppressed T2 weighted images showed absent uterus and proximal vagina and oval shaped rudimentary uterine births just infero-medial to ovaries. 25 years female patient with primary infertility, T2 weighted and T1 weighted images shows absent uterus and proximal 2/3 of vagina and an ectopic location of left ovary and rudimentary left uterine bud in left inguinal canal. 21-year-old female with primary amenorrhea had MRI which showed cross-fused ectopic kidney within the pelvic cavity with no uterus on sagittal, coronal and transverse section. True renal pelvis was found which was found to be type 2 MRKS syndrome. All patients were diagnosed as MRKS syndrome on basis of following features. Patient with primary amenorrhea, normal development of secondary sexual characteristics, normal female gonadotropin levels including follicular stimulating hormone and luteinizing hormone, MRI detection of an absent on vestigial uterus. Among 6 patients with MRKS syndrome, 72.74% had type 1 MRKH, 27.32% had type 2 MRKH. Out of the 6 patients, complete uterine and proximal vaginal agenesis was noted in 4 patients. Normally positioned small vestigial uterus was found in 2 patients, that is 33%. MRKH is a congenital malformation with variable degree uterovaginal agenesis with functional ovaries. MRKH alert to look for urinary, skeletal or cardiac anomalies. Psychological consideration is needed in MRKH patient and treated either creation of neovagina or attainment of reproduction with newer assisted reproduction technique. those MRK patient who has uterovaginal agenesis with rudimentary uterine bud, and those patient with vestigial uterus had different prognosis or outcome, even though also in type 1 and type 2 MRKH, where type 2 had poor prognosis. Adequate MRI assessment in 3 MRKH aid in counseling the patient parents, guardian in a better way pre-operatively. Hence, MRI can emerge as a major tool in diagnosis as well as the prognostic outcome in such MRK patient. Thank you.
Getting this Mullerian agenesis or anomaly, 6 patients in 1 year, I think is too much. Because we don't find in our institutions.
So 46 patients were taken, only 6 of them were.
Out of 46, 6. And in a 1 year, you have got 6 cases of Mullerian agenesis. There is a huge number in comparison to any study group. So have you thought of any other factors associated with it?
Sir, renal abnormalities.
Huh?
Sir, renal abnormalities.
No, there is the coexistence. You have shown that pancake type of kidney over there. But do you guess any other factors that can be either genetic or racial or anything? Because I don't think 6 in 1 year is a huge number. Mullerian agenesis, I don't know how many cases our Department of Radiology has seen. How many patients do you see? 3, 4. Okay. It's excellent. You were getting so much of cases.
A nice presentation.
Thank you, sir.
Any histopathological or biochemical correlation?
No, sir. I was just.
Okay. On MRI findings, you have done all these presentation.
Yes.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Fahad. I would like to invite on stage Dr. Padya Shubham Shankar to present the topic to study the relationship among intervertebral disc, vertical diameter, lateral foramen diameter, and nerve root impingement in lumbar vertebrae.
Hello, am I audible? The human back is a marvel of engineering and a source of endless mysteries and pain. Isn't it amazing how something so intricately designed can cause us so much trouble? Back pain is something most of us have experienced at some point, or even are experiencing as of now. It's almost like a rite of passage. Something like forgetting your keys whenever you are in a hurry. Good morning everyone, I am Dr. Shubham Upadhyay, a postgraduate trainee in the Department of Orthopedics, and today I will be presenting my research on the relationship between intervertebral disc dimensions and nerve root impingement in the lumbar vertebrae. So without any further ado, let's dive into it. We all know, slide is not moving. We all know low back pain is a common issue and quite literally a pain in the back. It affects almost 60 to 80% of the people at least once in their lifetime, making it one of the most prevalent medical problems. You might say it's a universal problem. This research addresses a common yet critical issue. As our intervertebral discs lose height over time, how does this affect the space through which our spinal nerves pass? Or how does a shrinking disc change the space for our nerves? Spoiler alert, it gets tight and not in a good way. But don't worry, I've got some insights to share. Our study aimed to explore how the reduction in disc height, known as disc vertical diameter, affects the size of the foraminal space, particularly the foraminal vertical diameter, and how this in turn impacts the nerve roots. Essentially, we're looking at the backbone of the problem, no pun intended. This is a cross-sectional study that involved analysis data from the MRI of lumbosacral spine. The subjects for this study were randomly chosen from those who had undergone MRI for low back pain between April 2022 and March 24. Patients with congenital spinal deformity, LSTV, primary tumor, metastasis, traumatic injury, and infections were excluded from the study. To set the stage, let's have a quick anatomy lesson. Here we have the lumbar spine, and these are the intervertebral discs. Think of them as jelly in your donut. When the jelly starts to shrink, the nerves passing through these neural foramen get squeezed, leading to potential pain and discomfort. We measured the disc vertical diameter, the foramen transverse diameter, the foramen vertical diameter, and the nerve root diameter. This is a glimpse of the measurements we took. These measurements help us understand how changes in disc height influence the space available for the nerve roots. Now on to the results. This graph shows a significant correlation between the DVD and FVD. Specifically, we found that a reduction in DVD strongly correlates with a decrease in FVD. For every 1 millimeter decrease in DVD, the FVD reduced by approximately 0.87 mm. Interestingly, we observed no significant correlation between DVD and FTD. Despite the reduction in disc height, the width of the foramen remains relatively unchanged. It's like having a doorway that only gets shorter but not narrower. Our regression analysis provides further insight. We discovered that a 1 millimeter reduction in DVD could lead up to a 3.3 millimeter reduction in DVD and FVD at certain lumbar levels. This means that as the disc loses height, the impact on the vertical space is quite substantial. To sum up, our study highlights that while shrinking discs do reduce the foraminal vertical space, the transverse space remains stable. Specifically, for every 1 millimeter decrease in DVD, there is an average reduction of 0.87 millimeter in FVD, but no significant change in foraminal transverse diameter. This new understanding can guide us more effective treatment strategies for spinal nerve compression. So not all hope is lost when our spinal jelly starts to dry up. So what does this mean for patients? The clinical implications are significant. Our findings suggest several key points. Understanding the reduction in foraminal vertical space helps in creating personalized treatment plans. Not every patient will need major surgery. Sometimes less invasive procedures like discectomy or laminotomy in the place of some major surgeries like posterolumbar intervertebral fusion or anterolumbar intervertebral fusion are sufficient enough to alleviate nerve root compression, which can reduce recovery time and improve outcomes. Educating patients on the importance of early detection and management of disc height reduction can help them make informed decisions about their true health. Lastly, our study underscores the need for further research into preserving foraminal space, which could lead to better preventive measures and treatments. Thank you, and for your attention. If you have any questions, feel free to ask.
So Shubham, Dr. Shubham, it was excellent presentations. So the animation, the formation of the slides, and your eloquency is really excellent. So I'm just mesmerized.
Very nice presentation. Thanks. All the best for your bright future.
Actually, I can't resist myself commenting because I think this is an ideal presentation which I was talking about, and I think all other PGTs should learn from this presentation how you should ideally present in a platform. I always keep on telling my PGTs, keep on blabbering that presentation should be like this, presentation should be like this, and but unfortunately everywhere my PGTs would vouch for this. Always my eyes go for spelling mistakes. The last slide, your references spelling is wrong. so everywhere. So it is a beautiful presentation, but keep in mind those small mistakes. Thank you.
Thank you, Dr. Subham, for excellent presentation. Next, I would like to call upon Dr. Harmandeep Kaur to present on the topic, Imaging of Head Trauma on Computed Tomography. Dr. Harmandeep Kaur. Do you need pointer?
Everyone, myself Dr. Harmandeep Kaur, PGT first year in Department of Radio Diagnosis. So today my topic is imaging of head trauma on CT scan. Introduction: head injury causes more deaths and disability than any other neurologic condition before the age of 50 and occurs in more than 70% of accidents, which are the leading cause of death in men and boys less than 35 years old. Death occurring within 24 hours of craniocerebral injury can be avoided by timely institution of diagnostic and therapeutic measures that could prevent secondary brain insults, like due to cerebral edema, or there could be herniations which can occur. Aims and objectives: the present study was to evaluate and assess the role of computed tomography in patients with craniocerebral injury and to study the various craniocerebral changes that occur in trauma to head with aid of CT. Material and methods: it is basically a retrospective study which has occurred in of the patients who have came to our department in last 7 to 8 months, and the study comprised of 50 patients with head injury. These patients were subjected to CT scanning of head using 16 slice G-revolution model, and the findings were compiled and studied. The results were: the study revealed that males were commonly affected, 82.6%. Most of the patients were in age group of 21 to 30 years, 33.3%. Road traffic accidents were found to be commonest mode of injury, 65.34%. Patients with severe head injury on GCS scoring formed the bulk of the study, 41.3%. Extradural hematoma was associated with fracture in most of the cases, 93.02%. Contusions were the most common intracranial lesion observed in 44% cases. Subdural hemorrhage is commonest of all intracranial hemorrhages noted, 38.6%. Intracerebral hemorrhage was the most common hemorrhage noted in patients who expired. Linear fractures were found to be the common type of skull fractures in 72.4%. So in the first picture, we can see acute extradural hemorrhage along the right frontotemporal convexity. In the second picture, we can see there is a linear fracture noted in right parietal bone crossing the squamosal suture extending into temporal bone. This is the acute SDH along left frontotemporal parietal convexity. In this picture, we can see subarachnoid hemorrhage along left frontotemporal parietal sulcus and Sylvian fissure. In this, we see multiple hemorrhagic contusion in bilateral temporoparietal lobes with midline shift, mass effect, and diffuse cerebral edema around it. In this, we can see there is intraventricular hemorrhage in right lateral ventricle. Conclusion: computed tomography is a simple, inexpensive, highly effective, and safe imaging modality and provides the ability to rapidly evaluate patients with acute craniocerebral injuries. CT aids in surgical planning, prognosticating outcome, and recovery time. CT is one of the most comprehensive diagnostic modality for acute localization of the site of injury in trauma to head. Thank you.
From the Department of Pediatrics, we often send the children with a head injury, but you have not included pediatric patient in your study population. Why this bias? No bias. So we have seen a lot of because they just chase about the car or the kite and they fall from the roof.
Yes,
And then they come with the fracture. Even the depressed fracture we have seen just a few days back. So you have not included that. Why?
Nice presentation. It's all right from me.
Thank you, Dr. Harmandeep. I would like to call upon next speaker, Dr. Gurpreet Singh, to present the topic cross-sectional study of prevalence and clinical features of LPRD at a tertiary care hospital in rural areas.
Good morning, everyone. I am Dr. Gurpreet Singh, presenting the case presentation on the topic prevalence and clinical features of laryngopharyngeal reflux disease at a tertiary care hospital in a rural area. It's a cross-sectional study. So while introducing my topic, the reflux is characterized by the return or regurgitation of fluid, consists of a gastroesophageal reflux disease, that is GERD, and laryngopharyngeal reflux disease, LPRD. Unlike GERD, LPRD involves the reflux of the stomach contents into the pharynx and the larynx, leading to the distinct symptoms. Despite being a distinct entity, LPRD often goes undiagnosed, requiring focused studies on its prevalence and diagnostic approaches. The aims and the objectives of my study, this cross-sectional study aims to assess the prevalence and clinical features of LPRD among the patients attending the ear, nose, and throat outpatient department at a tertiary care hospital. So methodology, the patient selection, the patient presenting with the throat and the voice symptoms lasting over a month were included from the period of the December 2022 to May 2024. The assessment tool, the reflux symptom index, it's developed by Blefasky et al. RSI was used to evaluate the reflux symptom, and reflux finding score that is employed during laryngoscopy. RFS assessed common laryngeal findings in LPRD patients. So this is the reflux symptoms index. It includes the questionnaire that is given to the patient, and the patient ticks from the parameters of 0 to 5 on the severity of 0 to 5. So that is the reflux symptom index questionnaire, and this is the reflux finding score. This is done by using the laryngoscopy. The subglottic edema, ventricular obliteration, arrhythmia, hyperemia, and various other laryngoscopic parameters are seen. So methodology, diagnostic criteria, a diagnosis of reflux was established if RSI score more than 13 is there and LPRD was confirmed with an RFS score more than 7. Patients with the RSI more than 13 underwent rigid laryngoscopy and their RFS was noted. Follow-up involved the monthly laryngoscopy for 3 months to monitor the treatment response. So various symptoms and findings were seen. Common symptoms were the sensation of the foreign body in throat, recurrent throat clearing, coughing after eating or lying down. And laryngoscopy findings were hyperemia or arrhythmia of the endolarynx, posterior commissure hypertrophy, and thick laryngeal mucus. So these are the various laryngoscopy pictures we have got from laryngoscopy findings. That is the ventricular obliteration. The second one is the subglottic edema. Third one is the posterior commissure hypertrophy, and fourth one is the vocal fold edema. So the results, a total of 160 patients participated with near equal gender distribution with 47.5% males and 52.5% females. The prevalence out of the participants, 70% exhibited an RSI score of more than 13. The fallout of 12.5% was seen among the participants. And among the remaining participations, the 94.8% had an RFS more than 7 on laryngoscopy. So the prevalence of LPRD was higher in males as compared to females, as we have shown in the pie chart. So 160 patients came to our OPD with the 76 males and 84 males with the more than 13 score of RSI. The 112 patients had more than 13 score of RSI. The 14 patients fall out. 98 patients the laryngoscopy investigation was done, and out of 98 patients, the RFS was more than 7 in 93 patients. That shows the excellent correlation between RSI and the RFS scoring, with the 61 males and the 32 females. So while concluding my presentation, I said that in a source limited setting, the symptoms of LPRD may be overlooked, necessitating increased awareness. Diagnosis and treatment protocols for LPRD required further standardization through the long-term studies. Future directions, the further research is warranted to establish comprehensive guidelines for the management of the LPRD. These are my references. Thank you.
What is your experience in pediatric age group?
Sir,
I'm interested because I am a pediatrician, and that's why I just want to ask you.
Sir, there are pediatric patients coming in our OPD, but they are also, sir, not the same kind of results we have gotten from the adult group and pediatric group.
And
in this area.
In fact, even in the NICU, we get this patient of the GERD.
Sir, but LPRD is a whole different entity. LPRD, we are seeing the larynx of the patient.
And out of 160, you got 93
yes,
having
sir.
it.
Yes, sir, that was because we have included the patients that are coming to our department with more than 1 month of complaint. Those are the patients we have included, we are seeing in the RS.
It signifies your strong clinical acumen.
Yes. It signifies my strong laryngoscopy findings and clinical findings are correlating.
Nice presentation.
Thank you, sir.
What are the management protocols in this case?
Sir, management protocols include the treatment of protein pump inhibitors for the 3 months, and also the lifestyle modifications. We did the lifestyle modifications. Then if the patient is not having the betterment with the treatment, then we can go for the protein pump inhibitors and the other relatives. Thank you, sir.
Thank you, Dr. Gurpreet. I would like to call upon the next speaker, Dr. Gursimrat Kaur, to present on the topic cross-sectional survey against medical pharmacy and nursing student on headphone use and its impact on hearing. Is it?
Good morning, everybody. I am Dr. Gursimrat Kaur. I am here to present on cross-sectional survey among the medical, pharmacy and nursing students on headphone use and its impact on hearing. Due to the paradigm shift to the online education, there has been a rise of personal audio device usage among students. There is a risk of noise-induced hearing loss when the sounds are heard at more than 85 decibels over a period of 8 hours a day. Lack of awareness among the students leads to this preventable hearing damage. Hearing impairment is the 4th leading cause of global disability as per WHO. Therefore, there is a need to promote good hearing health. The objectives of my study are to determine the usage of electroacoustic devices like earbuds and headphones, etc. among medical, pharmacy and nursing students, to detect the prevalence of hearing loss among these students, to determine frequency of hearing loss through pure tone audiometry, to detect the correlation between impact on hearing with duration and volume of headphone use. Methodology is, we included the students of first and second year MBBS, pharmacy and BSc nursing who aged between 18 to 24 years. Exclusion criteria was not the students who did not give the consent, who had active upper respiratory tract infections, had a history of ear surgery using the hearing aids or a family history of hearing loss. Students were invited to the ENT OPD for pure tone audiometry. Consents were obtained from each participant. Data collection was done through a structured performance which included socio-demographic information, electroacoustic device usage history, relevant medical and surgical history. Electroacoustic device data included type of device, per day duration of use, source connection and volume of usage. Pure tone audiometry was performed by trained audiologists in a soundproof booth. Air conduction was tested at octave frequencies, that is 250, 500, 1000, 2000, 4000 and 8000 Hz. To differentiate the type of hearing loss from conductive to sensorineural, bone conduction was assessed. Airborne gap of more than 15 decibel was considered significant. Findings of audiometry were generated on an audiogram. Out of total 250 participants, 238 fulfilled the inclusion criteria. Male to female ratio was 1:2. Mean age was 21 years. In our study, 91.56% of the students were regularly using electroacoustic devices, among which insert type devices were most commonly used. As you can see in this chart, the volume of the devices preferred by the students was 50 to 80% in 42% of the students, and 21% of the students preferred volume of more than 80%. The hours of usage among the students was mostly less than 4 hours a day. Upon audiometry, among the total students of 238, normal hearing was found in 225 students, sensorineural hearing loss was found in 9, and conductive hearing loss was found in 7 students. Therefore, 3.7% of the students were found to have mild sensorineural hearing loss. Other related complaints were tinnitus, headache, insomnia, and difficulty of speech understanding. Among these, headache was the most common complaint. Discussion. There is a high prevalence of 91.56% of electroacoustic device usage among medical students, which was found in our study. A similar study from Hamadan University of Medical Sciences, Iran, stated 91.2% prevalence of PLD use. This high prevalence of electroacoustic device use can be attributed to current educational practices followed by medical students. Participants of our study preferred insert type of earphones. The most widely used source was smartphone. Interestingly, we also noted that majority of the medical students who displayed hearing loss in pure tone audiometry were not experiencing tinnitus, even not aware of the declining hearing thresholds. In our study, we found mild sensorineural hearing loss in majority of the cases, and effect of this mild hearing loss is significantly larger on communication. This is a document which was released recently on 3rd June 2024 by the Government of India Ministry of Health and Family Welfare concerning the overlooked health issue of hearing loss associated with usage of earphones and headphones. They have provided some suggestions to help prevent hearing loss, such as the volumes of these devices should not exceed 50 decibels and the headphones should not be used for more than 2 hours a day. There should be reduce in the screen time for kids and decrease of the social media among the students. Conclusion, mild to moderate hearing loss was found in 6.3% of the personal listening device users who were unaware of or neglected of their symptoms. This hearing loss is irreversible once it occurs, but it can be entirely prevented. Timely audiometry tests can identify these cases early and preventive measures can be taken. These findings highlight the urgent need for awareness programs about the health effects of modern technology among students. These are my references. Thank you.
This is a very timely presentation. All of the students and even the faculties, they should be aware of that fact that we use these earbuds and the earphone and all that. So this is a very nice presentation, and MGM Medical College is doing that research. I'm very, very happy.
Nice presentation. It is a nice topic as well as burning topic also. I have read a message from Alka Yagnik. She suffered from sensorineural deafness, and she messaged that less use of these devices. So nice topic.
Thank you, Dr. Gursimrat. Now I would like to call upon Dr. Sweetie Kumari to present the topic Advanced Imaging Techniques in the Diagnosis and Management of Budd-Chiari Syndrome.
Do you want pointer? Pointer चाहिए आपको?
No. Up now. Good morning, everyone. Myself, Dr. Switi Kumari, second year postgraduate resident in the Department of Radio Diagnosis, Katihar Medical College, Katihar. Today, my topic of presentation is Advanced Imaging Technique in the Diagnosis and Management of Budd-Chiari Syndrome. Budd-Chiari syndrome is a rare but serious condition that occurs when the hepatic veins which drain blood from the liver become obstructed. This obstruction can lead to a buildup of pressure in the liver, which can damage the liver tissue and lead to complications such as ascites, portal hypertension, and liver failure. Early diagnosis and treatment are crucial to improving patients' outcome. Objectives: accurate diagnosis, characterize pathophysiology, guide therapeutic intervention, and monitor treatment response. Material and methods. Study design. This study employed a cross-sectional observational design to analyze data from a specific period. Patient selection. The study involved 5 patients who were referred to the Department of Radiodiagnosis at Katihar Medical College. Data collection. Data was collected over a period of 10 months, focusing on patients presenting with symptoms suggestive of Budd-Chiari syndrome. Imaging analysis. The collected data was then analyzed to evaluate the diagnostic accuracy and clinical utility of various advanced imaging techniques in the diagnosis and management of Budd-Chiari syndrome. Results. Recent advancements in radiological imaging have significantly enhanced the diagnostic accuracy and management of Budd-Chiari syndrome. Key findings. Doppler ultrasound. Doppler ultrasound remains the first-line imaging modality for Budd-Chiari syndrome. It can visualize hepatic vein occlusion, venous collaterals, and reversed blood flow. This information helps in the early diagnosis of Budd-Chiari syndrome and can be used to monitor disease progression. CT angiography. CT angiography is a valuable tool for visualizing the hepatic veins, inferior vena cava, and identifying possible causes of obstruction such as thrombosis or external compression. It can also reveal enlarged caudate lobes and heterogeneous liver enhancement, which are suggestive of Budd-Chiari syndrome. MR venography. MR venography is considered the gold standard for imaging Budd-Chiari syndrome. It provides excellent soft tissue contrast and detailed images of hepatic vasculatures without ionizing radiation. This technique can detect flow voids in hepatic veins, hyper-intense signals in the thrombi on T1 weighted images, and degenerative nodules, which are characteristic feature of Budd-Chiari syndrome. Doppler ultrasound. Hepatic vein occlusion. Doppler ultrasound can clearly visualize the obstruction of hepatic vein, a defining characteristic of Budd-Chiari syndrome. Venous collaterals. The technique can also detect the development of venous collaterals, which are alternative pathway for blood flow around the obstruction. This information provides valuable insight into the severity of the condition. Reversed blood flow. Doppler ultrasound allows the identification of reversed blood flow in the hepatic vein, a hallmark sign of Budd-Chiari syndrome. These are images of Budd-Chiari syndrome. Management strategy. Medical management, interventional radiology, and surgical management. In medical management, we use anticoagulation, diuretics, and thrombolytics. Interventional radiology, angioplasty and stenting, and tips. Surgical management, liver transplant. Conclusion. Advanced imaging, advanced radiological imaging technique have become essential tool for the diagnosis and management of Budd-Chiari syndrome. Early diagnosis, these techniques allow for earlier and more accurate diagnosis of Budd-Chiari syndrome, enabling timely interventions and improving patient outcome. Personalized treatment. Imaging plays a crucial role in guiding treatment decision, including the use of minimally invasive interventions like angioplasty, tips, or in severe cases, liver transplant. Improved patient care. The integration of advanced imaging technique have significantly enhanced our understanding of Budd-Chiari syndrome and contributed to improved patient care. Thank you.
Thank you, Dr. Switi. And in Budd-Chiari syndrome, Have you studied the hepatic vein wedge pressure?
Sorry, sir?
Hepatic vein wedge pressure, have you seen?
No, sir.
And how many patients you have got with a history of umbilical catheterizations?
Sir, out of 5, 3 patients.
And a history of umbilical catheterization?
Yes, sir.
So, have you seen any syndrome associated with the Budd-Chiari syndrome in your study group of 5 patients?
No, sir, only Budd-Chiari syndrome.
Can you name anyone, a syndrome with the Budd-Chiari syndrome?
No, sir, actually we got 2 patients which came in our department only for follow-up.
There is a Papillon-Levray syndrome.
Yes.
Papillon-Levray syndrome, the patient present with the Budd-Chiari syndrome,
Yes, sir.
along with the immune deficiency
Yes,
and
sir.
adonsia.
Yes.
Okay. Anyway, it's a very good presentation.
Thank you, sir.
Okay, nice presentation.
Thank you, sir.
Okay, thanks.
Thank you, Dr. Sweetie. Now, I would like to call upon the last speaker, Dr. Deepak Kumar, to present on the topic, reappraisal of quality indicators in the blood center of a tertiary care teaching.
Good morning, everyone. Myself, Dr. Deepak Kumar, resident from Pathology Department. I'm going to present a paper on the topic of reappraisal of quality indicators in the blood center of tertiary care teaching hospital. Are we ready for the accreditations? I would like to thank Professor Dr. Stavo Devroy sir for their guidance and guiding throughout this topic. So going with the introduction. In order to ensure that patients receive safe blood supplies, quality in transfusion services has become an essential part of the hospital quality. In doing so, a need was felt for the concrete proof to measure the quality of the transfusion services. This led to the introduction of the quality indicators in the blood banking system. Quality indicators are the performance measures designed to monitor and evaluate the quality of the transfusion process. 11 quality indicators have been defined by the National Accreditation Board for Hospital and Healthcare Provider for quality improvement in the blood transfusion services. Further, out of these 11, 5 quality indicators have been mandated for the accreditation of the blood bank to monitor and report quarterly to the NABH. Objective of studies, this study was conducted to evaluate the quality and performance of the blood center of our hospital by evaluating the 5 mandatory quality indicators put forward by the NABH and make recommendation, if any, for the improvement of the same. Methodology, this is a prospective observational study conducting in our hospital where the 5 quality indicators defined by NABH were observed and monitored monthly for a period from January 2024 to June 2024. Information was gathered in a structured manner, root causes for any deviation were analyzed, and specific corrective and preventive actions were taken. Continuing, first point, percentage of transfusion transmitted infection was derived by taking the combined TTI cases and dividing it by the total number of donors in that particular month and then taking its percentage by multiplying with 100. And this is the formula for the calculating the TTI percentage. Then the next quality indicator is the percentage of adverse transfusion reaction. The formula for that is the number of adverse transfusion reactions divided by the total number of blood or component units issued multiplied by 100. Third quality indicators is percentage of outdated whole blood or concentrated RBC, that is a wastage rate. So this wastage rate is calculated using the number of whole blood and concentrated RBC discarded due to the outdating divided by the total number of whole blood or concentrated RBC collected or prepared multiplied by 100. Then the next quality indicator is the turnaround time. It is calculated using the sum of the time taken divided by the total number of times the whole blood or RBC issued. So the time taken is calculated from the time the request is received in the blood bank for the issue of the blood till the blood was cross-matched or reserved and made available for the transfusion. Next quality indicator is the percentage of component quality control failure for each component. It is calculated by this formula. There is a number of particular component quality control failures divided by the total number of that component tested multiplied by the 100. So in our period of study, the main 5 quality indicators were observed and following results were calculated in the percentage form. So mean transmitted infection rate came out to be 1.82% and adverse transfusion reaction percentage was 0.30% and turnaround time for emergency cases was 8.5 minutes and for regular routine cases it was 141.38 minutes. Mean wastage rate of blood components came out to be 13.5% and there was no case of quality control failure during our tenure. So the conclusion from the study is that a few important recommendations we gave from our study. First is to reduce the TTI rate, a properly conducted donor interview by a trained personnel and notification of the permanently deferred donors will help in reducing the percentage of TTI reactive donor. Second, mandatory enrollment in the National Hemovigilance Program of India will help in proper documentation of the adverse transfusion reactions. And since whole blood has got only limited indication, the whole blood collection should be kept to a minimum to prevent expiry due to non-utilization. And also we can interlink with the other blood center and transport the blood component there for their uses. And next is adequate and properly trained manpower should be available to issue the blood and components by adhering to the transfusion policy as per the institution. Every hospital should have a hospital transfusion committee to monitor the rational use of the blood and blood components and review the blood management system and minimize the blood wastage rate. This study observed that by strictly following the quality parameters put forward by the NABH, processes can be controlled in a manner that errors are avoided or kept at the minimum. This in turn will help in attaining the higher level of performance of our blood bank. These are my references. Thank you.
Nice presentation.
Thank you, sir.
Are you doing ELISA for HIV, HbA/CG infection in blood center? Have you done ELISA test?
Their rapid screening, their kit only using directly antibody based.
But as you know, it is not advisable that we use rapid kit. We use ELISA based investigations. Okay?
Yes, sir.
And are you following these indicators on routine basis?
Yes, sir.
Good. Thank you.
Thanks.
Thank you, Dr. Deepak. Now I would like to invite on stage Dr. Ashiteva Devroy, sir, on stage to felicitate Dr. Swapan Kumar Ray. I would like to request our judge to come on the stage for felicitation.
सर इस पर?
पेनिकुलाइटिस, आई थिंक मैं सुन तो रहा होगा, पीछे सुन रहा है बिना माइक के? So paniculitis, one. Anything else? So I would just, an overview देने के लिए, I would just say that when you are classifying any lesion, irrespective of skin, you classify them as infective, non-infective, neoplastic, non-neoplastic. Life becomes a little easier. So first glance on a scanner view, you always give a scanner view. Histopathology or pathology cannot be complete without a scanner view. You just see the pattern. Everything is a pattern, right? If you have to recognize me from a distance, so you'll know, okay, this much tall, short hairs, whatever. So that's a gross pattern. So you should know the pattern, especially in skin, right? Besides that, otherwise also, in general, all histopathology or cytology is based on pattern, right? Of course, cytology में pattern नहीं देख सकते हो, but cell cytomorphology देखते हो, fine. So, fat is important when you are dealing with paniculitis 1. You are dealing with any erythematous lesions, induratum, nodosum, leprosum, SPTCL. What is SPTCL? What is SPTCL? Till we start the formal discussion, I thought I'll just give you an overview. नहीं तो सो जाओगे सब. SPTCL क्या होता है? Senior residents, junior residents को छोड़ देते हैं. शॉर्ट फॉर्म, सब शॉर्ट फॉर्म यूज करते हो ना आजकल. जब किसी को ओके भी लिखना होता है तो के लिख के भेजते हो. नो, एंड आई फाइंड इट वेरी अम्यूजिंग कि हाउ मच टाइम यू हैव सेव्ड, हाउ मेनी मिलीसेकंड्स यू हैव सेव्ड इन नॉट टाइपिंग दैट ओ. So SPTCL is subcutaneous paniculitis like T-cell lymphomas. Okay, so there it's very important. Even if you don't get the epidermis, but the paniculum has to be there. Right? So any erythematous reactions is very, very important. And all these lesions which I have just named, they present with bilateral painful nodules, mostly on the extremities. Remember that. So these are 5 differentials, mostly, commonly, of erythematous painful nodules over the skin. So there you have to have paniculum. If the paniculum is not included, call your dermatologist. Tell them that it's not adequate, or take multiple sections. Skin biopsy is never, you should never give a final diagnosis till such time you are not fully satisfied within yourself. Take multiple levels, because you don't need to store the tissue for further whatever, but the diagnosis given to the patient is very, very important. So take multiple serials. At least you should examine 10 to 15 serials before you say that the biopsy is not representative or it is inadequate. Fine. There's no harm in repeating a skin biopsy. You know, I would say least invasive procedure it is. And I don't think the patient also would mind getting a repeat biopsy if the diagnosis is being made. And remember one other point. If the person is coming to the clinic, the patient, for a skin biopsy, that means कि कुछ ना कुछ बहुत दिनों तक चल रहा है. Isn't it? I probably won't go. अगर एक छोटा lesion हुआ 2 हफ्ते, 3 हफ्ते, 4 हफ्ते में ठीक हो गया, I'll be happy. But if it is persisting for a long time, the patient is getting a biopsy done, please do not call non-specific changes. Please. It's a request from me. Right? Because you just imagine a person has got a biopsy done. So there has to be something. And sometimes we report non-specific changes and the skin has diffusely, lesions all over the body. Diffuse lesions. So you should always, the best part is, pick up your phone, call your dermatologist colleague. Always better. Nearly 50% of the skin lesions, you have to do CPC. What is CPC? Very good. So you have to do CPC, especially psoriasiform lesions, right? You have to do papillosquamous lesions. You have to do clinicopathological correlation. Otherwise, you cannot. Most of the times, why I chose this theme is, most of the times in these lesions, you are able to give a differential. Here also you have lots of problems because, as I said, the granulomatous dermatitis, it's a huge chapter. Infective, non-infective, even tumor-associated granulomas are known. So which are the common neoplastic lesions which are associated with granulomatous response? In skin. In skin. Anybody? Anybody now? Open to all. उसका नाम ही शुरू होता है granulomatous. Granulomatous slack skin. What is that? It's a type of cutaneous T-cell lymphoma, right? So uska naam hai granulomatous because it shows you giant cells, and slack skin because the skin starts sagging. The collagen degeneration takes place. So multiple layers बनते रहते हैं, right? So if clinically you have seen once in your lifetime one patient of granulomatous slack skin, आप जिंदगी भर नहीं भूलोगे. And if you see the biopsy, and most common erroneous diagnoses are made in these cases because it's diffuse lymphocytic infiltrate, mature, immature, all intermixed and intermixed with giant cells. And our first instinct is when we see giant cells, infection ढूंढो, no? कीड़ा ढूंढना है, कहीं तो मिलेगा, कुछ तो मिलेगा. पर ये भी याद रखना है कि ऐसा भी होता है, ज़रूरी नहीं है कि कीड़ा मिलेगा, ठीक है? But of course, in tropical countries and temperate climates, infections are much more common than the granulomatous slack skin. It's not very common otherwise also, okay? The other condition where you can see granulomas in skin is elastolytic giant cell granulomas, right? So elastolytic, the name says lytic, so there will be elastic fibers within the giant cells. So there also the skin will become loose, but it will not sag. And it may cause perforation. Sometimes you have transepidermal migration. So by transepidermal migration you mean that the things which are there in the dermis, they are traversing through the epidermis causing perforated lesions. So perforating collagenosis or elastolytic granulomatous lesions of the skin, they can cause perforating lesions, right? So actually अगर broad चीजें ऐसे याद रखोगे, ध्यान में रखोगे कि ये भी हो सकता है, वो भी हो सकता है, तो essentially 60 to 70% of the times आप ठीक होगे. 30% में तो वैसे ही CPC करनी है, right? At least in skin, and not in skin also, otherwise also, you know, even in tumors. If we say many a times it happens, liver biopsy, for example, going little off the track tangentially, you find granulomas in liver. That liver is a very tricky organ. Even if you find a small cluster of histiocytes in the portal tracts or in the parenchyma, the lobules, you call it a granuloma. You don't really have to look for lymphoid cells and proper epithelioid cell granulomas in liver. So उसमें एक छोटा collection भी you will call it as granulomas. And many a times, liver involvement in primary granulomatous disease is extremely rare. Extremely rare. Most of the times, if it is involved by the granulomatous inflammation, is disseminated, if it is infective. But hepatosplenic T-cell lymphomas can commonly will involve liver and spleen. And there you can find this granulomatous response. So again, you have to do CPC. You are seeing granulomas, you are not seeing enough number of atypical T cells. Then you have to say, talk to a clinician. I'm seeing this. And the clinician will give you the history that patient is deteriorating fast because these are very aggressive lymphomas. So subtle features which come with experience, and the more you see, the more you read, you'll get to know. But you have to pick up these small clues, okay? And I always say in skin, no, besides the main lesion, no, the side things, the accompaniments are very important. You know, we all look for accessories. जब तक accessory नहीं हुआ तो dress के मायने खत्म और खाने के मायने भी खत्म. आज हम लोगों ने South Indian breakfast किया ना, चटनी नहीं होती तो मज़ा नहीं आता. So that's what is called as accessories or accompaniments. So in skin particularly is very important. Besides the basic pattern, look for the accompaniments, always. So by accompaniments, I mean, for example, you have seen a lesion in the skin. Let's talk about granulomas. Epithelioid cell granulomas are seen. Now next thing, what do you want to look for? Anybody? Granulomas to dig gaye. Now you want to say it's TB, it's leprosy, it's fungal, it's leishmania. These are the main common diagnoses when you talk of infections, right? So what are the accompaniments you will see? For example, in leprosy, what do you want to see in leprosy? What all features, accompanying features? Histiocytes तो आएंगे, granuloma आ गया. Foamy macrophages, so that is, you will see in BL or LL, not in tuberculite. So if you are seeing in if you are not seeing foamy macrophages, you will go towards BT. There you will see a lot of lymphoid cells. Then next accompaniment, giant cells will not be seen in lepromatous leprosy, lepromatous spectrum. If you see giant cells, it goes towards tuberculite spectrum. Why it is so? ऐसा क्यों होता है? Why it is so? You don't see giant cells in lepromatous spectrum. Very good. It's an immune response, no? जितनी immunity अच्छी, उतने अच्छे granulomas. right? And giant cell reactions. And it is the indeterminate leprosy which poses most of the diagnostic problems, especially to clinicians as well as to pathologists. But if you get subtle inflammation here and there and positive lepra bacilli, it is indeterminate. So if the clinician is saying leprosy, please do a phyte stain or a lepra stain and do maybe more sections to look for these foam cells. If not seen, then of course you say that these are the features. So the patient will be kept on follow-up. He'll be put on follow-up. Otherwise, you'll just say non-specific changes, वो चला गया घर, वापस नहीं आएगा और वो 4 को और infect करके आएगा, no? Finally, community में जाएगा ना? So these are the things important. Okay, next thing, आपने बोला foam cells, lymphoid cells, giant cells. What other the accompaniments you look for? Very good. But are we done with the session? Everybody is back? Back? Good. So anyway, मैंने शुरू तो कर ही दिया था, but still. So any other accompaniment? Nerve bundles. Yes, nerve twigs, not nerve bundles. Skin में इतने bundles नहीं आ सकते. पतली सी skin है, तो nerve twigs. But most of the times you are not able to visualize the nerves. Why so? Is that the reason or something else the reason? So leprosy involves nerves, no? So they might be destroyed. But you have to mention about it in your report, whether nerve twigs are seen or not seen, whether they are destroyed or not destroyed. Next thing is adnexa. Always comment on your adnexa in the skin biopsy. Always. Whether it is granulomatous or non-granulomatous, and especially in leprosy because it will destroy the adnexa. No? It will. And then of course, neutrophils, edema, eosinophils, paniculitis. To rule out any reaction. Type 1 or type 2 or Lucio phenomena. What is Lucio phenomena? Why it is called Lucio phenomena? So what is type 1 reaction in leprosy? Upgrading or downgrading, right? And type 2 reaction is ENL, right? And ENL, the name says erythema nodosum leprosum. So erythematous nodular lesions while the patient is on treatment for leprosy, and they would be usually painful. Usually, as I said earlier also. So you look for neutrophils, eosinophils, edema, paniculitis, and sometimes vasculitis. So these are the accompaniments when you're looking for leprosy in reaction. Okay, so you want to say something now? It's been displayed, leave it. Padne ki zarurat nahi hai. I think everybody is read. Okay, she wants to say something. Okay, go ahead.
Okay, ma'am already has started our next discussion, that is live dermatopathology case discussion by Dr. Uma Nahar Sakya. Ma'am is
Sakya bol do.
Sakya. Uma Nahar Sakya. Ma'am is currently working as a professor in the Department of Histopathology, Postgraduate Institute of Medical Education and Research, Chandigarh. She has numerous publications, 49 in national and 310 in international journals, awarded fellowship in cardiovascular and dermatopathology. She has been secretary of Dermatopathology Society of India.
She wants to read full. I give credit to her. Okay. Thank you. So thanks for the warm welcome, the hospitality, and a very lovely cultural show put up by all the faculty members, students. We really thoroughly enjoyed. Thoroughly, we had a lovely, nice evening and a memorable evening. Okay. Now, as we were talking about, I'll give you a brief about the, okay, where is my presentation? It's on the desktop? Date 2, this is paper. Oh, okay, this one? Right, yeah, got it. Do you have a collar mic? Idhar hai. Thank you, I got it. I don't like standing behind the podium and talking. Am I audible? So am I audible now? Mic is working? Okay. Hello, mic testing, 1, 2, 3. Pointer? Okay. Yeah. So as I was talking about skin, so how do you interpret the skin biopsies? So you see the tissue reaction pattern, which could be epidermal, dermal, or in the paniculum, followed by the pattern of inflammation. Where is it located? What is the type of inflammation? And the accompaniments which I just talked about. Okay. Now, what is this? यार ये तो बता दो, कल बड़े दिल दिखाए इन्होंने पीछे बैकग्राउंड में. He is very innovative, I must say. Your sound system वाला जो भी है. So ये क्या है, क्या पैटर्न है? यार दिल तो सब बनाते रहते हो, ऐसे ही बनाते हो सब. दिल नहीं लग रहा. It's a blood vessel though. It's a dermal blood vessel, but it's in the shape of heart. So you are saying heart because you know the pattern, right? So this is what a pattern looks like. So if you remember patterns, you know eyes won't see what the brain doesn't know. So you know, okay, this is something like pan ka patta or heart shape, whatever you want to call it. So it's a pattern, okay, right. So what are the major tissue reaction patterns in skin? So most common being the lichenoid and psoriasiform, fine. And you know what happens in lichenoid? Basal cell damage and interface dermatitis. These are the two important features when you're talking of lichenoid pattern. Psoriasiform, as I say, right? There's something like fingers, you know, upar jayega, niche aayega, upar jayega. So papillomatosis will be there, papillomatosis, and usually you will have, it could be irregular or it could be regular acanthosis. Then you have spongotic. Spongotic dermatitis usually is accompanied by lichenoid, most of the times, but it may not be necessarily. So any spongotic, and it could be drug induced, it could be acute spongotic, it could be hypersensitive dermatitis, could be whatever, right? Then vesiculobullous, you are all aware, blistering disorders, depending on the level of the split, intraepidermal or subepidermal or suprabasal, whatever, right? Then for today's theme, I chose granulomatous. So chronic granulomatous inflammation pattern. It's a huge topic, but I just selected 15 slides so that you have an overview of it. And of course, then lastly, the vasculopathic or the vasculitides. So what's the difference between vasculopathy and vasculitis? Anybody? I would prefer the resident's answer is first. आपकी टर्न बाद में आएगी. अपना नंबर आएगा. Anybody? तनवीर. कल तुमने बहुत मजा लगाया, पर अब थोड़ा मजा आप भी लगाओ. So what is the major difference between vasculopathy and vasculitis? So itis means inflammation. Pathy means no inflammation. So if you do not, please sit down. Answer being seated only. So when you say pathy, that means there is no inflammation into the wall of the vessel. It could be perivascular but not into the wall. So there is no itis. Itis means it is traversing the wall of the vessel. Okay. So these are the dermis patterns, and when you talk about granulomatous dermatitis, it is mainly the dermal involvement, not the epidermal. But of course in tuberculosis, you will have epidermal changes also. In deep cutaneous fungus infections also, you will have epidermal changes also. So that's a soft clue. If you are finding epidermal changes, acanthotic I am talking of, it will be either tuberculosis or it could be deep cutaneous fungal infection. If it is atrophic, you think of leprosy, right? Then of course you see other things. Then one more important thing which I always talk about is necrobiasis. So blue granulomas or red granulomas. So blue granulomas are usually seen in, they could be seen in any type of necrobiasis. So blue granulomas are seen in granuloma annulare. That's why we ask for PS Alcian blue stain, because that collagen which has got degraded or got necrotic or altered collagen, we use the term altered collagen, it will take up mucin stain because there is deposition of mucopolysaccharide material into that collagen after the degradation. And red granulomas are seen in usually rheumatoid arthritis, rheumatoid nodules, okay. And then of course you have necrobiasis lipoidica. There you will not have any particularly red or blue granulomas, but they look again pale, and it's called as tired cake appearance, right? Normal dermis, collagen alteration, normal dermis, collagen alteration. So it's multiple layers, right? Like a wedding cake appearance, you call it as in necrobiasis lipoidica. Then of course vasculitis, I won't deal into that. No, because today's theme is on granuloma. So what are the basic type of granulomas? You all know. It could be sarcoidal or tuberculoid. where you have mostly compact granulomas, scanty lymphoid infiltrate in sarcoidosis or no lymphoid infiltrate, whereas in tuberculosis you will have lymphoid infiltrate, followed by suppurative. What do you understand by suppurative? Suppuration means what literally? Neutrophils in the center, and suppurative granulomas 90% of the times will be associated with deep cutaneous fungal infections. Anywhere, not only in skin, anywhere else also in the body, if you find suppurative granulomas, please look for fungus. Please ask for PA stain. Okay. Then you have xanthogranulomatous inflammation, right? There's a whole entity of cutaneous xanthogranulomatous lesions, right? You know the latest classification. पता है सबको LCMS? Lady Harding Medical College भी बोल सकते हो. That's the mnemonic. Learn it. Okay. Then of course you can have collagenolytic, where you have palisading granulomas. ये तो शायद दिखेगा नहीं वहाँ पे. I'll use the pointer there. So palisading granulomas you usually see in granuloma annulare. Okay. Okay. Yeah, this is what a palisading granulomas look like, and then of course you can have foreign body granulomas, where it could be due to a splinter or a tattoo reaction or a hair follicle, and then asteroid bodies if you see fine, but it's not specific. It's sensitive, but it's not specific for sarcoidal granulomas. Okay. You know the definition. I'm not going to go into that. So what are the classifications? So either etiology based or the pattern of infiltrate, we call it, right? If you do not find the etiology, you just say it as granulomatous dermatitis, give your possibilities, number 1, number 2, and advise the ancillary tests, whatever, and discuss it with your clinician. And etiology, as I told you, it could be infective, infection, sometimes malignancy or foreign bodies. Okay. You know all this. Theory, I am not going to delve into that. Now, tell me, what type of granuloma do you see on the picture? So, what are the, you start from the epidermis. So, what has happened to the epidermis? This is one of the case I have given here. Atrophic epidermis, and then you have a pandermal involvement, right? This is what is called as pandermal involvement. So, you have granuloma still here. So, you have little bit subcutaneous tissue and you have blue areas as well, right? So, this is the higher magnification. You see a well-formed granulomas surrounded by lymphoid infiltrates, some calcified structures and occasional giant cells. So, it is like a tuberculoid granuloma. Now, since you have atrophic epidermis, but there is no gran zone, so less likely it is leprosy. So, you will classify it as granulomatous dermatitis, possibly tuberculosis, right? Okay, यहाँ तो मैंने लिख दिया, I'm sorry. So, these are the compact naked granulomas, classical, but not necessarily that you will not find. Now, see this also. Sometimes sarcoidal granulomas can be like this, and sometimes sarcoidal granulomas can be just forming a nodule-like lesion, plaque-like lesion. Commonly, they present as plaque-like lesion. They can cause atrophy of the epidermis because of that plaque stage. Okay, so there you will not see infiltrate. It's only the active sarcoidal granulomas where you will see lymphoid infiltrates. Okay. Then of course, necrobiotic. Now, as I was trying to tell you, you see here, you have perivascular inflammation, normal dermal collagen, and then this is the area where you need to look at. You have some altered dermal collagen here, right? Again, you have normal collagen. So, this is what is called as wedding cake-like appearance or a layered appearance, right? And this is the palisading granuloma, which is seen in necrobiosis lipoidica, higher magnification, or actually granuloma annulare, and sometimes rheumatoid nodule as well. Okay. I told you about the suppurative granulomas. Now see here, this is your epidermis. So is it normal or abnormal? इतनी मोटी चमड़ी यार गेंडे की तो नहीं है, हमारी है. So it is acanthotic, right? Quite thick, and it is diffuse acanthosis. No papillomatosis seen in this picture. At least you may find papillomatosis in other pictures. And what you see here is center में क्या हो गया? सब टूटा फूटा हो गया. So whenever you see these broken down things, that means there is a suppuration going on. You know, it gets floated off while you process it. So it's a suppurative granuloma. Okay, and you have to rule out a fungal infection. And fortunately, we saw this. क्या है ये? This is the higher magnification of another one. You see, necrosis in the center, neutrophils surrounded by histiocytes, some lymphoid cells, plasma cells, and this. Very good, copper penny bodies. But this is a very difficult diagnosis because most of the times It's difficult to find them. So you have to take multiple sections. We could only find it in the third or fourth slide. We could not find it in the first one, right? Okay. So this is what you need to remember. First of all, is there a granuloma? What is the type of granuloma? Where is the location? Is it pandermal? Is it deep dermal? Or it is superficial? Is it showing central necrosis, which is caseating, necrobiotic, or fibrinous? And lastly, suppurative. Are giant cells accompanied with it or not? Is there any birefringent material? That means foreign body is there. Okay. Then any associated epidermal changes or dermal changes. That is very important. And of course, any associated vasculitis. Why do I say that? मैंने शुरू में बताया, vasculitis अगर होता है तो क्या सोचते हैं हम? Erythema induratum. The other name of erythema induratum is nodular vasculitis, and it's not actually arthritis, it is venulitis. Remember that. Mostly it involves veins, not the arteries. Okay. So these are the key messages from granulomatous dermatosis. So with this, I'll start with the slide discussion. Okay. This is just an overview so that you understand why I chose these slides. Sometimes it could be very, very tricky. You're debating between TB versus this thing, fungus, or leishmania, or histoplasma, whatever, and then you are not sure. So then you use ancillary techniques. And remember, in our setting, especially Indian setting, you always ask for AFB-PS, irrespective of the etiology. Till such time you rule out an infective etiology, only then you proceed to the further, unless until you are seeing specific features for specific entity. Abhi laga dijiye haan. Ye podium piche kar dijiye. Unfortunately, our scanner was not working in the department. Otherwise, I would have got these slides scanned and shared a link with you all. But our scanner just got conged off just 2 weeks back. So it would have been nice आप लोग online देख सकते थे. But I will try जाने के बाद, if I can do so. इसको पीछे कर दीजिए. So remember, I am not going to answer anything. I am going to ask each one of you, if whether you have seen the slides or not seen the slides. Residents, gear up, buckle up, tighten your seat belts. Especially PGTs, जिनको एग्जाम लेना है. कौन कौन है? ओके, सारे फ्रंट रो में ही बैठे हैं, आगे ही बैठे, बस गुड. हाँ, जो भी जहाँ बैठे, सो बकल अप. हाँ, ओके. हाँ, ठीक है, मैं शुरू करती हूँ. अगर कोई प्रॉब्लम हुआ तो आप हैं. मेरा टाइम कितने बजे तक है? 12 बजे तक? पौने 12 तक? पौने 12? So we'll finish on time. We will not exceed the time. That's my this thing principle. Should not exceed time. Okay. So Bikramjeet, tell me what is seen. ये तो मार्क हो गया. I'm sorry. पॉइंटर चाहिए मुझे सिर्फ. इसको अंडू करना पड़ेगा. Sorry. हाँ, पॉइंटर चाहिए बस. Okay. So Bikram, how is the epidermis looking like here? Is it normal or not normal? You want to know the history? Do you want to know the history? So this patient had little painful erythematous lesions over the legs. I gave you the clue now, right? So that's very important. In skin, history is very, very important. So epidermis looks normal or it is thinned out, and this is a biopsy from the leg. I'll tell you. You can even say that from where the biopsy has been taken. If you have to take it from extremities, there will be a lot of capillaries proliferation. If you take it from face also, you'll get to see a lot of capillaries, because face is another vascular organ, and you'll see a lot of adnexal structures on the face, sebaceous glands, right? A lot of sebaceous glands would be there. And of course, if you take it from scalp or hair bearing area, you'll see a lot of hair follicles, right? Pilosebaceous units or follicular units. So here the epidermis is Retapex, ठीक है? Flattened, good, okay. Then, so what happens here? Is this a, I'm pointing out at something, कुछ लग रहा है? Very good, grain zone. I'll go to the low part first. Okay, so next thing, is it a pandermal involvement or is it only dermal involvement? Sparing the fat or not sparing the fat? Not sparing the fat, so subtly it is reaching here, no? This is your subpaniculum, no? Subcutaneous fat, and you have some inflammatory reaction here. So you see it's a pandermal involvement, there is epidermal atrophy and you have a grain zone. So आधा diagnosis तो बन गया. What are we dealing with? Leprosy possible. So now what are the accompaniments you want to see? What type of granulomas you wish to see? You wish to see granulomas, right? So what do you want to see? So another pattern, it's like I will call it as C-wave appearance or curvilinear appearance. Why are they curvilinear or C-wave like? Are they? Can you see this? So the infiltrate starts from here like this, goes up, goes down and then comes back again. So it's like C-wave or curvilinear, like machli jal ki rani hai, no? Something like that. So why they are curvilinear? Anybody? ऐसा क्यों है? एडनेक्सा तो ऐसे ऐसे नहीं जाते, क्या जाता है ऐसे ऐसे बॉडी में? ओके गुड, और वेसल भी थोड़ा स्ट्रेट होती, नर्व्स, because they follow the nerve tracks, that's why they are curvilinear. Okay, that's very important feature of leprosy irrespective of the type. Okay, so you see here, this is very important feature. You see, यहाँ से शुरू हुआ, यहाँ आया, फिर यहाँ आया, right? So forming a wave like structure. And then next thing I told you is the accompaniment. So now what are the cell types? Are they well formed granulomas or they are ill formed granulomas or something else? Now you see it on closer look. So what do you see here? What is the structure? Very good. So this is a nerve bundle, nerve twig, and it is entrapped within this infiltrate. So is it a well formed granuloma? Okay. How many say yes and how many say no? Raise your hands. Voting. डरते डरते मत उठाओ. हाँ. Good. No. Yes कितने? एक. So I go with the majority. There is no well-formed granuloma. So where are the nice epithelioid cells and lymphocytic infiltrate? There is only sparse lymphocytic infiltrate, right? And there are these loose histiocytes, no? So it's a vague exactly. That's a vague epithelioid cell granulomas. It's not a well-formed. So next thing क्या देखना है? Nerve involvement हो गई, curvilinear हो गया, vague granulomas हो गया. अब next चीज क्या देखनी है? Paniculitis और यहाँ देखो यहाँ क्या दिख रहा है? What do you see here? Around the vessels. Next चीज क्या देखते हो लेप्रेसी में? अभी तो बोला था foamy macrophages, no? And you see them here, right? So you have all the features to suggest that this is a lepromatous leprosy. Next thing is, because the patient has little pain and there are nodular lesions, you have to look for neutrophils, edema, eosinophils or vasculitis. ये चार चीजें और देखनी है to say whether it is in reaction or not in reaction. So if you see paniculitis in a case of leprosy, it is in reaction. Okay, and here you did see some evidence of paniculitis. Okay, here, and there is some hemorrhage which is procedure related. So don't worry about this. Fine. So this is a case of lepromatous leprosy in reaction. So that means it was a case of BT. That's why you are still seeing vague granulomas. So it is downgrading. Type 1 reaction with downgrading. That's the bottom line. Okay. And next thing क्या करोगे फिर? करना क्या है? ये तो कर लिया. FB करोगे, कुछ और करोगे? लेप्रा स्टेन करोगे. क्या फर्क है FB और लेप्रा स्टेन में? फर्क क्या है दोनों में? क्यों करना है वो? FB से काम क्यों नहीं चल सकता? बताओ. क्या डिफरेंस है FB और लेप्रा स्टेन में और फाइट स्टेन में? I want to show you the fight stain. Or fight stain में foam cells were much more increased than the first section. So that's why serials are very important. So fight stain में percentage of alcohol कितना use करते हैं HCl? AFB में कितना यूज होता है? Right. So remember that. So the concentration of the acid is much less for fights or lepra stain, whereas in AFB Zeal-Nielsen stain, which is much higher for tubercular bacilli. Okay. I don't know, oil के अंदर बिना दिखेगा नहीं, but you see the number of foam cells I wanted to show you here, which the first section did not show you. So that's one clue. Even if you find some focal collection of foam cells, go for serials. It could be pure lepromatous leprosy. You don't know. Okay. So ill-formed granulomas and that pattern is leprosy. Okay. Let's go to the next case. So clear कि कोई क्वेश्चन बाकी है? लेप्रेसी का डायग्नोसिस बना लोगे इसके बाद ठीक से? वेरी गुड, आपका काम आसान हो गया. Okay, so next one. What's your name? Yes. Shruti. Let's start this one. Adequate skin biopsy or inadequate? First thing, no? So you start your description like skin biopsy is adequate, comprising of epidermis, dermis and paniculum. That's how you start your description. And then start epidermal atrophy, epidermal hypertrophy, acanthosis, interface, spongiosis, so on and so forth. Okay. So normal or not normal? So this is again upper limb lesion. It was like a, I would tell you, a ring shaped lesion. अब मैंने clue दे दिया, इससे ज़्यादा clue चाहिए नहीं. Ring shaped lesion है. So ring shaped lesions are seen in which diseases? One is fungal, good, और अब चलो ठीक है, because ये granulomatous की class है तो fungal सोचोगे. और कुछ? Erythema nodosum तो out हो गया ना. I showed you leprosy with in reaction. So I told you 5 differential diagnosis for painful erythematous nodular lesions, mostly on extremities. So erythema nodosum is one of them. Nodosum, induratum, SPTCL, erythema nodosum leprosum, and sometimes erythema multiforme. Okay, sometimes very extremely rare. Fine. PAN. PAN can be present, but mostly it presents also present as mononeuritis multiforme. What is PAN? Yes. So that can also present as nodular ulcerative lesions, but they are painless. क्यों painless? They are painless, mind you. ये पढ़ोगे जाके. अब यहाँ पे वापस आते हैं. हमारे पास सिर्फ आधा घंटा है. चलो बताओ श्रुति. Subcutaneous नहीं दिख रहा है. ठीक है, मान लिया. तो still it's a small punch. We'll say the skin biopsy is devoid of subcutaneous. Okay, epidermis normal, not normal. Upper limb है, so it is normal, है ना? There is no epidermal changes, right? No hyperkeratosis, and this is the normal keratin you see. Basket weave orthokeratosis. जैसे basket नहीं बुनते? Okay, so this is what is normal keratin, basket weave keratin. If you get compact hyperkeratosis, please do PA stain. If it gets compact, why so? The superficial dermatophytes, they get entrapped in those keratin, and it's called as sandwich sign. Okay, or spaghetti noodle sign. कौन कौन spaghetti खाया है यहाँ पे? हाथ raise करो. किस किसने spaghetti खाई है? Good. Spaghetti meatball sign, that is called as. So the dermatophytes are entrapped within the layers of keratin. So it's called as spaghetti noodle sign or a sandwich sign. It's sandwich between them. This is a normal keratin. So epidermis is normal. So where is the pathology? In dermis. So mostly mid dermis to deep dermis, right? And you again have a clear zone here, no? It's essentially. So what is the abnormality here? So let's trace the biopsy from this edge. And if you see, no, there is one lesion like here and there's another lesion like here, right? This one. And in between you have this lymphoid infiltrate which is perivascular in nature. Skin में होता क्या? Perivascular ही होना है और periadnexal ही होना है और तो कुछ है नहीं. तो वहीं आएगा infiltrate. Okay. So what is the reason why they get accumulated around the vessels? ये T lymphocytes को affinity क्यों है? इतना प्यार क्यों है vessel से? वहीं जाके चिपक जाते हैं. Anybody? कभी सोचा है? सोच. बहुत एफिनिटी होती है वेसल्स और टी सेल्स की, और स्किन में मोस्टली टी सेल इन्फिल्ट्रेट होता है, बी सेल बहुत कम होता है, नो रेयरली, ओनली इन रिएक्टिव प्रोलिफरेशंस मिलेगा या बी सेल लिम्फोमास में मिलेगा। सो ये जाके पढ़ना है आज का होमवर्क कि क्यों चिपकते हैं वहीं जाके। सो क्या प्रॉब्लम है, ऑल्टर्ड सा कुछ है ना, इफ यू सी दिस एरिया दिस लुक्स मोर पिंक एंड दिस लुक्स लिटिल हेजी, ब्लड अपीयरेंस है ना, यू कैन नॉट डिलीनिएट द कोलेजन। इफ यू सी दिस एरिया, I would show you this area actually, yeah, this is better. You see this is your normal collagen. So normal collagen will have interstitial space in between. You have bundle of collagen, so again I call them as C waves. In between you have interstitial space. Here the C waves are lost, no, it's like a smudgy kind of thing, सब कुछ blurred out of focus है, ऐसा नहीं लग रहा है? Similarly here, see here, you cannot see any collagen fibers. And at the periphery you can see some infiltrate. Fine. Now we have to go to the high part to see what is the nature of infiltrate and what is this smudgy area looking like. Okay, let's see here. Now if you see this, these are your collagen fibers, the pink ones, right? So what has happened to the collagen? Are they normal? I mean normal in the sense सबकी shape ठीक है, आड़े तिरछे भैंगे हो गए हैं? No? Destruction नहीं बोलते, altered collagen, right? Or necrotic collagen, right? Because if you see, this is essentially a normal collagen fiber at the edge, but if you see this area, this is all smudgy altered collagen with collagen necrosis. And you have occasional, what is this? Multinucleated giant cell and lots of histiocytes, and if we go at the periphery, they are like palisading, no? सारे सेनानी तैनात हैं collagen के आसपास, right? So it is called as palisading, no? So they are guarding that collagen. So if you get this palisading necrosis of the collagen surrounded by or palisaded by histiocytes and multinucleated giant cells, what's the differential? So it's a palisaded granuloma. So palisaded granulomas के differential मैंने 3 बताए थे, कौन कौन से? Granuloma annulare, rheumatoid nodule and necrobiosis lipoidica. So अब ये blue है कि pink है, means red है या blue है? इसका look कैसा है? It's bluish. So it's a blue palisaded granulomatous reaction. So blue means GA, ring-like lesion. I gave you the history. So the name itself is granuloma annulare-like lesion. So clinically आपने एक बार देखा है lesion again, those who are dermatologists here, if there is any, आप जिंदगी भर नहीं भूल सकते. So it's like a fungal infection like lesion, ring shape, but it is much more red. It's non-itchy, unlike fungus. Fungus will itch. So this was a case of granuloma annulare. And there was another, and you see this lot of lymphocytic infiltrate, again perivascular, and this is another focus. There were 2 foci, no, of altered collagen. This is actually rare finding to see. ऐसे multiple बड़े बड़े कभी कभी नहीं दिखता है, तो कभी कभी you encounter interstitial GA. That's very difficult to diagnose because एक छोटा collagen necrosis normal, and that will be very difficult. So you have to take help of your clinical colleagues. So what next you will do? So obviously foam cells नहीं है, well formed granulomas नहीं है, diagnosis is confirmed. So next क्या करोगे? क्या करना चाहोगे? अब तुमने बोल दिया blue granuloma है, तो करूँ क्या? Blue granuloma तो मान लिया मैंने, कैसे confirm करोगे? Blue है, मैंने बताया शुरू में, देखो सब भूल गए. PA Salcian blue करना है ना, तो फिर बोल नहीं रहे हो ना, PA Salcian blue करो and it will be all mucin positive. There was a slide, I don't know, I can't find it, but anyway, if I find it, I'll show it again. So let's go to the next one. Fine. Right. एक स्लाइड में और दिखाना चाहती हूँ, दिस इज वेरी इंपॉर्टेंट. ये थोड़ी गूगली है पर मैं दिखाती हूँ बिकॉज आई वॉन्ट टू सी कि आपने क्या सीखा. से नेक्स्ट कौन बैठा है? सुरभि, चलो सुरभि फटाफट विद इन 2 minutes, टक टक टक, बैठ के. फ्लैटेंड डेटाबेस, एपिडर्मिस ठीक है, बिल्कुल ही पतली हो गई है. या तो एब्डोमेन की स्किन है विच इज वेरी थिन, बट इवन एब्डोमेन की स्किन भी इतनी थिन नहीं होती, ठीक है. सो बिल्कुल एट्रोफिक है, नो, सी हियर, और तुमको इस मैग्निफिकेशन पे भी लग रहा है कि इसमें तो कुछ नहीं है, ये पक्का तुम नॉन स्पेसिफिक चेंजेस रिपोर्ट करोगे, आई एम श्योर, एंड मोस्ट ऑफ द टाइम्स ये होता है, और ये हुआ भी था इस केस में, ठीक है. देन इट केम बैक टू मी फॉर रिव्यू. दैट्स व्हाट हैपेंस व्हेन यू आर स्पेशलाइजिंग इन वन पर्टिकुलर फील्ड. सो इट वाज रिपोर्टेड एज नॉन स्पेसिफिक इन्फ्लेमेशन, रिपोर्ट वेंट ऑफ, द क्लिनिशियंस कॉल्ड मी बैक, मैम प्लीज रिव्यू द केस, we are not happy with the report. I said okay, I reviewed it and I revised the report. So now this is re-review. So okay, epidermis is flattened and you hardly see any adnexa. दिख रहे? नहीं दिख रहे ना? Depends skin कहाँ की है, अगर abdomen की है तो नहीं दिखेंगे ज़्यादा. But what you see? Carefully, क्या देखना है? But trophic skin के DDs बोलो फटफट. अभी बताए थे मैंने. Atrophic skin, commonest DD. Leprosy, no. तो क्या देखना है अब? ग्रैनुलोमा देखना है और फोम सेल्स देखने हैं. ग्रैनुलोमा दिख नहीं रहे. But here you are. Occasional collection of foam cells were there. And this was missed in the routine report. This happens. When you have too many cases to report, 100 cases in a day you are reporting, you are bound to miss this. And there were more collections also. I'll show you. This was a treated case of leprosy. But it still had these collections. See here? Right? And the fights was positive, interestingly. So nobody thought about it during the routine reporting. It was reported as consistent with leprosy on treatment. Because leprosy on treatment will also show you similar changes. But it should not show you foam cells. If it is showing you foam cells, you should do fights and should look for fights. Lepra bacilli. Okay? That's the googly here. So ऐसे cases भी आएंगे, ऐसा नहीं है कि ऐसे नहीं आएंगे. तो इनमें ध्यान देना होता है स्पेशल. इसमें हाँ बोलो. Revised report, leprosy. Lepromatous leprosy, foam cells. Foam cells थोड़े हैं पर हैं तो. यार अब पग बांधी है तो बांधी है ना. ऐसा थोड़ी आधी बांधी है, थोड़ी बांधी है, पूरी बांधी है. ठीक है? Okay. Let's go to the next case. This was, I thought, was an easy case, but इसमें भी we had lot of discussions. ये biopsy adequate है कि inadequate है? पहली बात. Actually, I was not happy with the biopsy. It was very superficial biopsy. But next, yes, Namita, yes, tell me, what do you see? And this biopsy is from face. Let me tell you that. So face के लिए skin normal है, abnormal है? मुझे तो बाय हार्ट याद है सारे स्लाइड्स, मुझे देखने की भी जरूरत नहीं इधर. नॉर्मल और एबनॉर्मल स्किन, एपिडर्मिस. पहला तो एपिडर्मिस, नो? एबनॉर्मल. सो व्हाट इज एबनॉर्मेलिटी? तो ही तो एबनॉर्मेलिटी होंगी स्किन में, या तो फ्लैट हो जाएगी या मोटी हो जाएगी. सो इज इट फ्लैट और इज इट एक्यांथोटिक? Acanthotic, no. So there is lot of acanthosis for face. Face की skin is not so thick. Okay, and then if you see there is kind of, I would say, pandermal infiltrate abutting the epidermis. वो जहाँ thinning दिख रही है वो, that is because there is infiltrate which is abutting the epidermis. But otherwise it's an acanthotic epidermis. Okay. Now what kind of infiltrate? Next thing, no, you want to see what are the cell type and what kind of infiltrate it is. Right. Tell me. So are there well-formed granulomas? Are there well-formed granulomas? Yes or no? इतना मुश्किल का सवाल तो नहीं है ये. Yes or no? How many yes and how many no? Okay, let me ask like this. How many no? एक ही no है. अब मैं इस बार no के साथ जाती हूँ. Ill-formed granulomas हैं. Like here, you have histiocytic collection. Here also you have histiocytic collection. So they are not well-formed. When you say well-formed granulomas, they are either tuberculoid or sarcoid or BT. Remember that. Well-formed granulomas इन्हीं तीन में दिखते हैं. Suppurative granulomas are seen in fungus. Remember that. अगर ये याद रहेगा तो essentially 60-70% cases में ठीक होंगे. So these are not well-formed granulomas. Where is the collar of blue cells? It's not there, no? What are the blue cells? Lymphocytes. नहीं है ना? So histiocytes and lots of histiocytes are there which are intermixed with lymphoid cells. So they are not well, these are again vague granulomas. Okay. And they are involving the adnexa, of course, perifollicular bhi hai. They are partly kind of destroying, But what differential you will think now? Epidermal involvement hai. You see the infiltrate is reaching up to the epidermis here, kind of causing interface, no, kind of. And if you see, uske baad to oily hai. There are scattered plasma cells as well. There are. So जब histiocytes दिखे, infiltrate दिखा तो कीड़ा ढूंढना है. So what type of कीड़ा you want to into this one? What will you suspect? बोलो. अभी तो सिखा है. Suppurative नहीं है ना, तो fungus less likely. So non-suppurative ill-formed granulomas face पे abutting the epidermis. Rule out leishmania. Look for them. And there were quite plenty of it, I think. यहाँ पे oil नहीं है, otherwise I would have shown you. So there were lots and lots of them. Now the DD for leishmania is histoplasma, right? Many a times you may have problems. So then what do? क्या करोगे? Differentiate कैसे करोगे दोनों में? Next one, कैसे करोगे? Confusion है. Clinician कहता है कि leishmania है, मैं बोल रही हूँ histo है. अब लड़ाई हो जाएगी. तो confirm तो करना पड़ेगा. कैसे करोगे? मैं उससे पूछ रही थी. Anyway, जिम्जा नेगेटिव आ गया. अब पीएस फंगस है ना, पीएस तो करना ही है. देखो रामबाण है पीएस. इन्फेक्टिव कंडीशंस में पीएस, ग्राम्स, एफबी एंड जिम्जा व्हेन यू आर having lesions especially on the face, and if it is involving that belt, you know, Himachal belt, Bihar belt, very common. आप तो बहुत ज़्यादा देखते हो हमसे leishmania, no? बहुत ज़्यादा देखते हो. PKDL कम हो गया. What is PKDL? वो कम हो गया है, काफ़ी कम हो गया है because of the health programs. Otherwise PKDL पहले बहुत आता था, but अभी leprosy में reaction बढ़ गया है because of leprosy में reactions बहुत दिखते हैं आजकल. क्यों? MDR, drug resistance, okay, right? So this was a case of leishmania. ये oil नहीं था तो मैं नहीं दिखा रही हूँ. Okay. How much time do we have? We have 15 more minutes. Okay. Let's see the next one. गर्मी मुझे ही लग रही है कि बाकियों को भी लग रही है? Okay, 1, 6. चलो, who's next exam going? इधर था कोई? अच्छा, good. चलो, बताओ. तो बड़े बड़े बायोप्सी है. इतना बड़ा पंच बायोप्सी तो हो नहीं सकता. So this is an incisional biopsy. Okay. आप बायोप्सी देख के भी बता सकते हो. शेव है, incisional है, excision है, wedge है, punch है. Okay. So this is an incisional biopsy. Now tell me, how is the epidermis looking like? So this is again from the extremities. Epidermis normal, abnormal? Leg के लिए? यार दो ही तो वर्ड है, कोई बोल दो गलत हो जाएगा तो क्या एग्जाम थोड़ी हो रहा है? नॉर्मल. ओके, ठीक है. मैं पर बोलूंगी थोड़ा एकंथोटिक है लेग के लिए. ठीक है. शिन की स्किन पतली होती है. अगेन shin is another area, but it will be very vascular because it's a dependent area. So if you see lots of capillaries in a biopsy with thin skin, without adnexa, without much sebaceous glands, it is likely to be from the extremities, that is legs, or maybe hand. हाथ की स्किन भी पतली होती है. ठीक है. Okay. So it's little abnormal. So where, and then उसके बाद you have a clear zone, है ना? ये पूरा clear zone है. Problem यहाँ हो रही है ना? So this is what you have to identify on the low power magnification, that is the scanner view. Where is the pathology? So when I was showing you the last slide, पहली बात epidermis normal or normal, granulomas there or not there, where are they located, what is the accompaniment, paniculitis there or not, and then lastly vessels. Vessels जरूर देखने हैं. ठीक है. So अब यहाँ पे problem हो रही है mid dermis till the fat. इसमें fat भी involved है और साथ में the fat is getting necrotic. स्क्लेरोसिस भी हो रहा है फैट का. ठीक है. सो जब ऐसा हो रहा है तो क्या सोचते हैं हम? सो क्या सोचोगे? व्हाट इज योर लाइन ऑफ थिंकिंग? मैडम सब ग्रैनुलोमेटस इन्फ्लेमेशन के केसेस लेके आए तो ग्रैनुलोमा ही होगा. ऐसा नहीं है ना. ग्रैनुलोमास नॉन नियोप्लास्टिक, नॉन इन्फेक्टिव में भी दिख सकते हैं, नियोप्लास्टिक में भी दिख सकते हैं और वैस्कुलाइटिस में भी दिख सकते हैं. So which is that vasculitis where you can see giant cells or granulomas? कौन सा वैस्कुलाइटिस? वेजिनस का नया नाम क्या है? GPA. क्यों चेंज हुआ ये नाम? Yeah, so Wegener was a Nazi follower. So almost 1 decade back, this name was changed to GPA. Okay. So इधर the important point I want to highlight is कि fat का necrosis हो रहा है. See here, and it is getting healed also. So there is liposclerosis. This is liposclerosis, and upper dermis also has sclerosis. So that is because there is short of vascular supply. जब भी necrosis होगा, उसके बाद sclerosis होगा healing के बाद, तो infarction हुआ उस area के बाद, इसीलिए sclerosis होगा, healing तो होना है ना? So then you look at this. So this is a nodular area, no? ये nodule जैसा है ना? And you have lot of vascular proliferation as I was trying to tell you because it is leg. So ये vascular proliferation is not only limited to upper dermis. See here, you have lot of vascular proliferation. It is also extending around this nodular area. So what is this nodular area? Let's see on high part. Okay. So here you see. Now this is like a well-formed granuloma. No, this is like a granuloma and it is centered around something. यहाँ पे ये क्या दिख रहा है? Smooth muscle दिख रही है? Yes. So it is in the wall of the vessels. So there is vasculitis, giant cells, granuloma. So it's a case of GPA. Now you want to confirm vasculitis. So what next you will do? How will you confirm that this is a vessel only and it's not infective? One clue is that there is a lot of infarction happening here. There is fat necrosis, healed by sclerosis. Definitely there is ischemic necrosis of the skin. So it has to be some vascular related problem. So what will you do? कौन सा स्पेशल स्टेन करोगे? जोर से बोलो. ठीक बोल रहे हो. Von Giesen, elastic von Giesen. That's the full name. And it will show you, what will it show you? Damage to the elastic fibers, right? So I'll show you that. So you have to see breakage in the internal elastic lamina, okay? Not external, internal. So वो breakage दिखती है, तो that confirms your diagnosis of. See, deeper biopsy में कितना सारा fat आया? हमने deep cut किया, EVG किया और उसमें इतना सारा fat आया, and this is your nodular area which I was trying to show you, and you look at the vessels. So this looks essentially normal, no breakage, but the next one shows you incomplete elastic lamina here. Okay, so that means there has been some damage. This is of another case. I'm sorry about that. So ये उस case का नहीं है because उसमें EVG was faint, so I did not bring it. But there was another good vessel. I'll show you. There was complete loss of elastic tissue. Yeah, here. See. So complete loss of elastic tissue in this area. So this was a case of GPA. Okay. Now vasculitis also presents with nodular lesions and ulcerations, and sometimes the clinical dermatologist may say livido reticularis. आता है ना कभी कभी फॉर्म पे लिख के. So livido reticularis can happen in two situations. One, it is vasculopathy or it is vasculitis. So if it is alternate light and dark areas, that means it's healing also, and healing with pigmentation. So light areas will lose the pigmentation and it will be more sclerotic, fresh later on. And so clinicians, if you're saying livido reticularis, rule out these two things, whether it is pathy or it is itis, always. Okay, right. One more case and then, okay. Chromo I showed you. So chromo का slide में दिखा देती हूँ, but you know that was another googly for us. Yeah, here. I'll show you the PS only of the chromo slide, just to see the pattern. Okay. So you see, this is how the biopsy looked like. So you have acanthotic epidermis,
This is what happens in deep cutaneous fungal infection, not superficial. If you have deep cutaneous fungal infection, that means it's been there for some time and it's producing lot of epidermal changes. It is so much so, sometimes so horrid looking that there is a differential diagnosis of squamous cell carcinoma. It's long standing, you know, people are not coming to you. So, and as I said in the first go, if patient is coming to you for a biopsy, that means patient is having this lesion for some time, at least more than 6 months, especially in skin, okay, unless and until it is increasing in size rapidly. And this is how granulomas look like. So, nice suppurative granuloma. See here, dikh raha suppuration? Thank you. And when you go into the high magnification of suppuration, there you go. So, you see lots of neutrophils here surrounded by histiocytes and some giant cells at the periphery, and you have this, kya hai ye? Copper penny bodies. So, this is the PS section, right? So, ये हमें 10th 12th section पे जाके मिला था, उसके पहले मिला नहीं था. तो don't give up, don't get frustrated. Sometimes you get frustrated, कुछ तो मिल नहीं रहा है, दे दो, पर देना नहीं है. Keep on doing it till such time, because it will help the patient. Immediately, the patient is given treatment, within 2 months the lesions respond very well. And I have seen lesions clearing absolutely fine. I remember one case, one female, she presented with a sinus here, sinus discharge. She was reported to have tuberculosis outside somewhere. Sorry to say, Ambersar में हुआ था, पर वापस आई वो घूमते घुमाते, and then the lesion progressed to the opposite side. There was destruction of the nasal septum, and this went on for 1.5 years, and she landed up in PGI. And with the history that whether we are dealing with tuberculosis or we are dealing with any fungal infection or whatever. And to my surprise, we found occasional giant cells sitting with those fungi, and it was aspergillus. She got treatment, and within 4 months, everything cleared. She came to thank me कि आपने मेरा diagnosis बनाया नहीं, मैं ATT खा चुकी थी 1 साल. So that's the importance of a pathologist. Especially when you have the slide to look at it, no, you can, and that's a feeling of satisfaction, contentment when you can make a diagnosis. Okay, right. So the last case, this I had not shown earlier, so ये मैं एक और दिखाती हूँ, उसके बाद we'll say bye. Dr. Biman is waiting, so I have to clear the stage for him. It seems he is not interested in giving a talk. It looks like that. इसकी एक HN ही नहीं मिल रही है मुझे. FB तो है, चलो मैं FB दिखाती हूँ. Anyway, maybe it's jumbled up. So this I wanted to show you. This is another spectrum of the granuloma. AFB is a much more transparent stain, you know that? So like, okay, who is going to describe it? So epidermis, this is again, I would say, from the hair bearing area, not face, not head, but it was from the, no, back की skin इतनी मोटी नहीं होती, बहुत ज़्यादा मोटी है ये, इतनी मोटी होती है पर इतनी नहीं होती. This is from the axilla, ठीक है? So you have little acanthosis and a pandermal infiltrate. Fine. Fat is also included, but it's not involved. Fat is free. So you have these well-formed granulomas. इसमें तो कोई problem नहीं है ना? And they are surrounded by lot of lymphoid infiltrate, but not many foam cells. So epidermal changes are usually a feature of tuberculosis, not leprosy. Even if it is tubercular leprosy, you will not find this degree of acanthosis. Okay. Then you have to look for necrosis. You may not find, the commonest type of tuberculosis of skin is lupus vulgaris, followed by scrophaloderma or TBVC. What is TBVC? So the name itself says tuberculosis verrucosa cutaneous. So there is lot of verrucous hyperplasia in TBVC. So that's another type. And then tuberculate. Tuberculate is not actually a type of tuberculosis, it's a reaction to the tubercle antigen. So you have pandermal involvement, well-formed granulomas, and one of the granulomas showed necrosis, not all, just below here. So we suggested a possibility of TB in this because I was sure that this is not leprosy. This is not fungus, no necrotizing granulomas. Leishmania, usually axillary lesion, very rare. So we suggested TB and then we did PCR and we found positivity for PCR. That also you can do. And I'll tell you another thing, you can even do gene expert from formalin fixed tissues. Previously, the dictum used to be that you can use only fluid samples, but now you can use even paraffin embedded formalin fixed tissues for gene expert. It's quite sensitive but not specific because it will detect the dead bacilli also, but if it detects, that means it is TB, right? Okay. So I hope now you have an overview of granulomatous infectious dermatitis, plus if you, I have not brought the granulomatous slack skin because I didn't want to add confusion to your whatever you have gained today. Any questions? Any questions? All clear? Nobody has a question. हम तो अभी भी फंसे रहते granulomatous dermatitis में कि ये है कि ये है. And I'll tell you the story of granulomatous slack skin. I reported it, suggested it, but my head of the department from dermatology was not happy. He says, no madam, clinically the patient is not having that kind of skin involvement. I said, from my side it is T-cell lymphoma with granulomas. I'll suggest a possibility of this. It could be an early stage. So the slides and blocks were sent to UK. They did all the markers because you have to do TCR. That's the definitive. You know, cutaneous T-cell lymphomas, IHC suggests, but the definitive diagnosis comes from the TCR gene rearrangement. So it was sent, it came back after 2 months with the, after similar diagnosis, same diagnosis. I was happy कि मैं ठीक थी. That was also, you just should know कि ये होता है, बस. You should be aware because your eyes won't see if your mind doesn't know. Okay. So anything? Any queries, any comments, any questions? Dr. Asitwa? Anything?
I just would like to share one of my experiences.
Sure, sure.
Regarding this, one of my cases during, when I was doing my PG,
Mhm.
there was a case where it was diagnosed as a squamous cell carcinoma of the leg.
Yes.
And the clinicians were very confident that it was a squamous
Yes.
cell carcinoma of the leg.
Yes.
And when it came to us, it was suspected as a fungal lesion, and then my teacher, professor, she said that you look into it, and like we submitted serial sections of it. We were like very enthusiastic to find out copper penny bodies, since we had a suspicion. And then after a lot of serial sections, we could find out a copper penny body, and that was in my second year of PGT, and we were really excited to find out that
So that's the lesson. I also said that clinically they will present as such horrifying looking lesions.
Yes,
it looks like squamous cell carcinomas. So if you are not sure, obviously you will know squamous cell carcinoma, but sometimes there can be problem there also because there is so much of epidermal hyperplasia. And it also depends how the section has been cut. Sometimes it is tangentially cut. आपको लगता नहीं ये तो invasion है. There also PS stain helps. How? How will it help in PS stain in squamous cell carcinoma? Anybody? Very good. Breach in basement membrane. So if you see breach, you say it's invasion. If there's no breach, even otherwise, I find it very useful. You know, oral cavity, the lesion is end on embedding, tangentially cut, biopsy is inadequate. You do serials with 1 PS. If you see intact basement membrane, it's only in situ or just hypoplastic lesion or just could be a verrucous lesion. So very nicely shared by Dr. Asitwa that chromoblastomycosis is a very commonly mistaken lesion clinically as squamous cell carcinoma.
And the thing was, ma'am, even after we diagnosed it at chromoblastomycosis,
The clinicians were not ready.
they
Yes,
did
I
not
know.
agree.
That happens. But then you have to call them and show them.
Yeah.
That's what I do.
So finally, when we wanted it to publish, then they wanted their names to be included in the...
So for that, I would say suggest biopsy rounds. So conduct biopsy rounds in your department. So include the clinicians. You learn from them, they learn from you. So it's a bilateral learning. And worldwide, most of the places, the dermatopathology is 50% times practiced by dermatologists.
Yeah.
हम नहीं दिया उनको, हम इंटरेस्ट नहीं शो कर रहे थे, उन्होंने पकड़ लिया. अब काइट को वहाँ करोगे तो कोई तो काटेगा, ले जाएगा. उन्होंने मलक ली, हमने दे दी, but we want it back in our domain, okay? But very rightly said कि वो agree नहीं होते. एक और experience नहीं, I will just suggest If you get subcutaneous soft swellings, cystic, very soft, non-tender, if it's not a sebaceous cyst or something like that, think of pheohyphomycosis. Subcutaneous, non-tender, fluctuant, soft swelling, pheohyphomycosis. 90% times you'll be right. Okay. Thank you. Thank you for your time and patient hearing.
Thank you so much, ma'am.
I don't know how much it has helped you, but I feel you'll be able to approach them in a more organized manner. That was my aim. Sarcoidosis की एक स्लाइड थी, वो मिली नहीं मुझे, बीच में गुम गई. I showed the picture though. वो इतने सारे कल इन्होंने बच्चों ने देखे हैं ना, आगे पीछे कर दिए.
Thank you, ma'am, for a wonderful and informative session. I would like to invite on stage Professor Dr. Nivedita Haldar to felicitate our speaker. I would request Dr. Uma Nahar Sakia ma'am to be...
पहले साइकिया बोलो. ये ठीक करवा के जाऊंगी मैं.
साइकिया.
नहीं, बस हो गया. ये तो ठीक करा के जाऊंगी. Thank you.
I would request Dr. Uma Nahar Sakia ma'am to stay on stage for felicitation. Ma'am, be in center. Thank you, ma'am.
Thank you very much, ma'am.
Thank you for providing this
ये सारा पहले ओपन करके स्केच के लिए रिपोर्ट लगाना पड़ेगा. Thank you so much, ma'am. So the next topic for today's discussion is setting up of an immunofluorescence laboratory, which will be presented by Dr. Viman Saikia, sir, Professor Immunopathology, PGI Chandigarh. I would request, sir, to please come on the stage. Next, I would also request Dr. Atnu Roy, sir, HOD Microbiology, and Professor Dr. Babai Haldar, sir, for chairing this session. Thank you. presentation already.
Good morning, everyone. It is my privilege to introduce Dr. Biman Saikia sir, who is presently working as Professor, Department of Immunopathology and Head Department of Telemedicine in PGI, Chandigarh. He is Professor in charge in Medical Education and Research Cells, Nodal Officer, Regional Research Center, and Nodal Officer, Center of Excellence for Artificial Intelligence, PGI MER, Chandigarh. He graduated MBBS from Assam Medical College, Dibrugarh, and completed MD Pathology from PGI, Chandigarh. He has numerous publications, more than 90 publications in national and international journals, and contributed chapters in various books. Thank you, sir.
Okay. Thank you and good afternoon. It's just past 12. And so the topic initially given to me by Sitava was immunofluorescence laboratory, establishing an immunofluorescence laboratory. And then I said that will be too focused and rather talk on a wider aspect and talk about immunopathology as a whole rather than only immunofluorescence. And that's what I'm going to do today. So when you talk of immunopathology, it's basically a subject which studies the immune response and the pathology of it, of the response or its absence. You know, the immune response can be deficient also in the various immunodeficiency diseases that I'll talk about in a while, and it can be both infectious and non-infectious. So these are. So now, basically, as we know more and more about immunology, we have realizing that majority of the clinical entities that we encounter in clinical practice has some or the other immunological basis. But you had this very exciting talk by Dr. Uma because because this is something which you see under the microscope, right? And it's always interesting. But immunopathology is a subject where, you don't see. A lot of things in immunopathology are largely invisible. And hence, that's the reason why what we're looking at is an evidence of a disease, indirect evidence of a disease in immunopathology. So whenever there is an evidence of disease, it needs extensive proof that what you're seeing is correct, what you're seeing is real disease and not a false positive kind of a test. And immunological techniques are not new to the histopathology or the pathologist as a whole, because immunological techniques like the immunohistochemistry is an integral part of, and the immunofluorescence microscopy is an integral part of the morphological pathology, and hence these techniques has been used. But as a newer understanding of the immune response and the immune etiologies of disease are coming up, so newer morphologies are also being described now. I'll take a few examples. For example, membranous glomerulonephritis, which was when we were students, it was largely an idiopathic disease. But the number of antigens that cause membranous glomerulonephritis has been evolving so rapidly, and now we can easily call it an autoimmune disease, right? Membranous glomerulonephritis is an autoimmune disease. And similarly, the IgG4 disease and the host of other diseases which has a very strong immunological basis, like all the glomerulonephritis, the pulmonary diseases like Goodpasture's, the APPA, the allergic bronchopulmonary aspergillosis, all the vasculitis and the host of autoimmune diseases all has a immunological basis. And the last aspect is a neurotherapeutic strategies continue to evolve as we understand immunology better. So there are a lot of programs on immunology that are happening in our country, and a lot of institutes give these immunological trainings. All these institutes have. So we have a lot of clinical immunologists and their training programs of. So the country is producing a lot of immunologists, but the pathological counterpart is lacking. So we need to, immunology, even for our students, they try to keep away from immunology. वो हमेशा ये कहते हैं कि वो सर के ऊपर से निकल जाता है, समझ नहीं आता है, that kind of an attitude. But you have to change that attitude, because without immunology, now it's very difficult to understand medicine. As we understand medicine, we realize that immunology, the response, immunological responses, plays a very major role. Now, when we talk of doing immunopathology or setting up a laboratory to look at these aspects of disease, the first step is to talk to the clinicians. You cannot start off randomly. If you want to set up a laboratory, you have to talk to your clinicians, what they want. If you have a very strong rheumatology team, so you have to start with the tests where the rheumatology people need help. So if you have a transplant team, then you have to provide all aspects of transplant immunology. You have, if you have good pediatricians who are diagnosing immunodeficiency states, then you have to give a very efficient immunological workup for diagnosis of primary immunodeficiency diseases. So first step is to talk to the clinical team and understand what services you need to provide, and then you. So basically you have to clearly establish the cost expectations within the context of the budgets. And you have to realize the labs need greater, in every aspect, whether it's space or electrical capacity or other, engineering things, the labs need more of these capacities than other clinical facilities. And you have to give importance to a lot of other aspects like the storage, and you will need a lot of refrigerators, deep freezers, and potentially even liquid nitrogen freezers, because storage of samples is also very important. And if the lab collects specimens on their own, you have to you will need a area for sample collection as well. So these are things that you have to think in advance before you start immunopathology setup. Now the broad areas, now I'll be talking about what we do, our institute, what our immunopathology department does, and what setups we have. So that is a kind of idea that I'm going to give to you, but you will have to think on your own depending on what kind of a setup you want in your hospital. So the basic divisions that are likely to come up if you are thinking of an immunopathology setup is you have to provide facilities for the basic immunological techniques, where you need to do techniques like serum protein electrophoresis or urinary protein electrophoresis, immunofixation electrophoresis, CSF oligoclonal bands, cryoglobulins, serum immunoglobulins. So these are the tests that you have to provide as part of the basic immunology. So that is one aspect. Then workup for autoimmunity will be one major bulk, where you have to provide tests for working up patients with autoimmunity. Yeah. And ELISA, immunoblots, these are techniques which are very familiar to many of you, and these are the techniques that you have to keep in mind when you are
trying to give a facility for autoimmune diagnostics. Immunodeficiency, if you have a transplant program, then transplant immunology. And if you have a good oncology setup and you need, you are using more immunomodulation and immunosuppression, then you have to monitor that immunosuppression, so that even for transplant immunology. So monitoring immunosuppression and immunomodulation, and other branches like infectious diseases or cancer immunology. So these are the broad divisions that you are likely to try to establish when you are thinking of immunopathology setup. The second step comes equipments. You need equipments to provide all this. So you have to think very strategically about what you want your lab to be, and because your aim should be, minimum equipments with maximum coverage. So that should be the principle. And these are the very basic points that whenever you are trying to buy a piece of equipment, you have to, ask your vendors to demonstrate the equipment. And once you have narrowed down on your vendor options, then you have to negotiate well. You have to, get competitive pricing, longer warranties. And so those are things that you have to take care. These are very general things. And one thing that we practice in our institute is that whenever you are buying an instrument, the consumables that come with the equipment, you should freeze the rates for at least 5 or 7 years. That ये 5 साल के मुझे आप ये रेट दो, तो 5 साल के लिए वो एक रेट फिक्स हो जाता है. And the companies will really do it because they are selling a piece of equipment to you. They are earning is from consumables. So हमेशा ये कोशिश करना चाहिए कि at least 5 साल या 7 साल के लिए रेट फिक्स करके दो हमें. So that is one thing that we do. And insist on AMC and CMC. And another thing is, even in my institute, I have seen that I buy a piece of equipment, and initial years we are very cautious कि खराब हो जाएगा इसको, ऐसे मत करो, वैसे मत करो, ठीक से रखो, सबको use करने मत दो, there should be one user. No, you should use your equipment maximum in the first year itself. अरे guarantee की बात है, खराब हो जाएगा at least ठीक तो कर देगा company. So you should try to use the equipment maximum possible in the initial few years. Don't keep it idle. Okay, so use the equipment to the maximum during the warranty period. So I'll just quickly go through the basic equipments that we need, that you are likely to, okay. So these are pathologists. As pathologists, we're very fond of microscopes. And can you tell me what is this? Iska lighting upar se hai, right? This is a phase contrast microscope that we use for the cross match, looking the cross match assay. Okay. ये immunofluorescence microscope है, Olympus का that we use one. This is another immunofluorescence microscope, an automated one. So this is from Leica. So we have two in the laboratory. We have two fluorescence microscopes. So general equipments like a cold centrifuge is very important. Okay. And general centrifuges, vortex mixture, the pipettes, and a good what do you call? क्या बोलते हैं इसको? What is this hood? This hood में काम करते हो ना? Biological hood. Okay. Laminar flow. So these are basic equipments that you need in when you are trying to establish a laboratory. This is the equipment we use for conducting electrophoresis, serum protein electrophoresis and urinary electrophoresis, and these are the gels that you see here. Okay. ये देखा किसी ने ये gels? Have you seen electrophoresis? Serum electrophoresis? No. So this is basically, you can see this electrophoresis here. This is albumin, this is alpha 1, alpha 2, beta, and the gamma globulins here. These are the M bands. Gamma globulins normally ऐसा दिखना चाहिए, है ना? So these are M bands. These are very prominent bands. These are M bands in, let's say, in multiple myeloma. Okay. So, and this is the immunofixation electrophoresis. So you try to type the M band by seeing what is IgG or IgM or whatever. So you can see that the band here is IgG kappa, right? and here it is IgM kappa. So that's how you type the bioimmunofixation electrophoresis. So this is the equipment we use for the electrophoresis. For measuring nephelometers, for measuring serum immunoglobulins and a lot of other like CRP and all, the rheumatoid factor and all those stuff, you can use the nephelometer. You can use a very small tabletop nephelometer like the mini-neph. Initially we used to use this, the mini-neph, but now we have a fully automated nephelometer. This is from the binding site, the OptiLight. This is a fully automated nephelometer. Okay. So these are equipments that you have to think of. This is an automated immunoassay analyzer from Phadia. This is Phadia 250. In fact, we have two Phadia equipments. Here you do almost all the immunoassays that you can do for autoimmune workup and everything. So you will need this is another automated system from Beckman Coulter that we have. So automated systems, immunoassay systems makes your life a lot easy, you know. So these are equipments. If you are doing, if you have a good transplant program, we have a very strong transplant program in PGI. So you need to do, HLA typing. If you have to do HLA typing by sequence specific primers, SSP techniques that we do, you need a gel apparatus and a gel dock system. If you are using SSOP or sequence specific oligonucleotide priming, that you need such an equipment. This is the Mr. Spot, the SSOP technique that you use for HLA typing. A flow cytometer for doing the flow cytometric cross, and a lot of other techniques, techniques that where you use a flow cytometer. This is the BD, and this is the Immucore system for multiplexing. Okay, so these are things that you can think of when you are doing immunopathology workup. Real-time PCR machines, nucleic acid, automated nucleic acid systems here, or thermal cyclers. So these are equipments. You'll need a lot of -80 refreezers, a cold room, -20 freezers, and these equipments. So these are some equipments that you will need when you are trying to, establish an immunopathology laboratory. Now, as I said, autoimmunity will in most hospitals, autoimmunity will take bulk of your time when you are doing immunology or immunopathology. So let's start with. We had a talk yesterday on ANA screening and all this. So ELISA is one technique which will be broadly used in immunopathology. Okay, so getting familiarized with ELISA technique and having an ELISA reader is one, and most of the laboratories will have an ELISA reader. So ANA screening by ELISA is one technique that you are likely to be doing very frequently if you are trying to put up an autoimmune laboratory. So when you do a screening by ANA screening by ELISA, so the basic thing is that the ELISA kit that you use for ANA screening will have kits today have around 17 antigens that are quoted here. These are the antigens that you can see that are quoted in the ELISA. So you can detect antibodies to these antigens when you're using a ELISA kit for ELISA ANA screen. Okay. Now ANA is a test where at a dilation of 1 in 40, up to 30% of the normal individuals can be ANA positive. Okay, which means they can be ANA positive without disease. So the positive predictive value of the ANA test is very low, right? ANA negative means the patient doesn't have disease, but if it is ANA positive, does not necessarily mean that the patient has disease. So the positive predictive value of the ANA test is very low. Okay, so that is one thing you have to keep in mind, and also keep in mind that ANA is one test which is most overused. I mean, most over-ordered test. Okay, so as I said, the sensitivity of ANA is low, but the specificity is very high. When you are using ANA IIF, I can do ANA by immunofluorescence or by ELISA also. And the more techniques are more or less comparable, but the specificity of the ANA IF is more. Okay, when you are doing ANA by immunofluorescence, it's the specificity is more. So these are immunoblot assays that you can, when there is an ANA positive, then you have to characterize that antigen by the using the immunoblots or other immunoassays. So these are examples of the immunoblot assays. And then let's talk about immunofluorescence a little bit, because this was the primary topic that was given, but let's talk of indirect immunofluorescence. Now when you are doing ANA by indirect immunofluorescence or any other test by indirect immunofluorescence, basically you are using this antibodies, you are looking at antibodies that are present in the serum, okay, and autoantibodies that are present in the serum. So you need a substrate to incubate the serum with. So you can have substrates like HEP2, HEP2000, and you can have rat liver. So these are the different, depending on what you are trying to do. If you are trying to look at ANA, you use a HEP2 or a HEP2000 cell line. If you are looking at C-ANCA or P-ANCA, or you are looking at trying to look at the ANCAs, then you use neutrophils, O negative neutrophils as a substrate. If you are looking at doing antibody screen for bullous diseases, you can use the monkey esophagus or human skin to look at antibodies to antidesmosome or hemidesmosomes. If you're doing a autoimmune neurological workup, then you can have mouse brain or transfected cell with, like for the aquaporin 4, you can use a transfected cell. So depending on what test you are trying to do, you'll have the substrates. Okay, so these are the substrates that you can use. These are a panel of photographs. Are you familiar with no, I don't think you'll be. But yeah, these are immunofluorescence photographs in the HEP2 cell line. You know, anybody can say what is this? This is ANA positive. What pattern is this? Homogeneous, yes. This is homogeneous pattern. Diffuse or homogeneous. You can see the entire nucleus is stained very homogeneously. So this is the homogeneous pattern, and homogeneous pattern will be seen in any ANA that is present. Obviously, the antibodies are directed to an antigen which is present in the entire nucleus homogeneously. So DNA is one. DNA and the histones are proteins which are homogeneously present in the entire nucleus. So if you have an antibody against the dsDNA or antihistone, it will give you a homogeneous pattern. So this is a homogeneous pattern, and this is the speckled pattern you see. Okay, see the difference between homogeneous and this. This is a speckled pattern. This is the anticentromeric pattern, because each chromosome has a centromere. You know that. So there are 46 chromosomes. There will be 46 dots. So these are the centromeres that are getting stained. This is the anticentromeric pattern. This is the oligonuclear dots. This is the oligonuclear dot pattern, and this is the nucleolar pattern. You can see the nucleus, and you have the nucleoli here. So this is a nucleolar pattern. So these are the different patterns that you see in immunofluorescence when you are looking at the HEP2 cells. Okay. Again, another panel of photographs. You can see the homogeneous pattern. If you look at the mitotic figures here, the mitotic figures are also positive, because what's happening when the cell is dividing, the DNA is also getting separated. So it stains the DNA, so the mitotic figures will also be positive. So you can see that the homogeneous pattern, the metaphase plate, the mitotic figures will also be positive. This is again the centromeric pattern. The centromere is in the DNA, in the chromosome. So even here in the centromeric pattern, the mitotic figures are positive. So you can see the zippers here. This is called the zippers in the anticentromeric pattern that we see. This is the speckled pattern. Okay. Here you see that the mitotic figures are negative. So here you see that this mitotic figure, the metaphase plate is not positive, which means the antibodies are not directed against an antigen which is there in the DNA. it's somewhere else in the nucleoplasm, but not the DNA. So this is the speckle pattern. This is the again the MND. This is the nucleolar pattern, and this is something. This is the this is the ribonucleoprotein RNB. Okay, so you can see the ribosomes that are shining. The nucleus is negative. Okay, but the ribosomes, so anti-ribosomal pattern, which is again seen in SLE, and this is something which is there in the cytoplasm and not nucleus. Remember, so this is a cytoplasmic antigen here. So in the ribo-P, and this is the anti-mitochondrial. So these are the mitochondria that are getting highlighted here. So this is the anti-mitochondrial AMA positive in a heptocell. Now it's very important to differentiate few patterns. Okay, this is the homogeneous pattern you see. This is because of anti-DSDN or anti-histone antibodies, and this is one pattern which is called a dense fine speckle. Now in a diffuse pattern, the nuclei will be positive and the metaphase plate will also be positive, whereas in a speckle pattern the metaphase plate is negative. But this is one pattern where it is dense fine speckled, but the metaphase plate is also positive. If you see this pattern, this is called a dense fine speckle pattern. It's important to recognize this pattern because DFS pattern is not associated with disease. Okay, this is seen in normal population. So if you start reporting this as ANA 3+, and without saying that this is DFS, then you are actually giving a false kind of message to the clinician, because this is not associated with disease. So it's important to recognize this DFS pattern. It's not, and this is the centromeric that again said. So these are patterns that you should be familiar with, and this is the consensus classification. Now we don't call it ANA, we call it anti-cell antibodies, okay? Because the antibodies are not only against the nuclear antigens, it's also the cytoplasmic antigens. So this you have to be familiar with. Now you call it AC1, AC2, AC3. That's how we report the ANAs, and we call it the anti-cell 1, anti-cell 2, that kind of a thing. So this is one slide that this is available online, and you should know what the AC patterns are. Then come to the ANCAs. For the ANCA, you would obviously it's anti-neutrophil antibodies, so you need the neutrophils as substrate. There are two patterns. One is the P ANCA and the other is C ANCA. You know that. I'll just show you. This is what you call as the P ANCA. You can see the peripheral staining with intranuclear extensions. So this is the P ANCA pattern. These are neutrophils. Okay, this is the nucleus of the neutrophil, multi-lobe nucleus you can see here. So this is the P ANCA pattern, and this is the C ANCA pattern. Okay, this is now the the C ANCA pattern is the positivity is more intense in between the lobules. So this is called the intralobular accentuation. So cytoplasmic positivity with intralobular accentuation. This is what is C ANCA. Now you should not call this as C ANCA, because here you see that the entire cytoplasm of the neutrophil is stained without this internuclear extension. So this is atypical ANCA. You should not call this as C ANCA. This is C ANCA. We will have to have this intralobular accentuation to call it C ANCA. Okay. So then you can the composite testing you can have sections the rat liver, stomach and kidneys to test for a host of antibodies by doing composite staining. This is the stomach, rat stomach. Then you can see the fluorescence in the smooth muscles here. This is the muscularis propria. This is the muscularis mucosae here. So smooth muscle antibodies, anti-SMA antibodies will get highlighted in the rat stomach. If you see a combination of this is the section of the kidney. You can see the glomerulus here. It's a negative staining. So if you see the proximal tubules of the kidney lighting up along with the stomach parietal cells, so this is a combination. This is the anti-mitochondrial antibody pattern, because the proximal convoluted tubules and the parietal cells are very rich in mitochondria. So this is anti-mitochondrial antibody. This is anti-parietal cell antibody, and similarly this is the LKM, liver kidney microsomal. You can see positive in liver and the kidney proximal convoluted tubules. So depending on the positivity of where you are seeing the positivity, you can characterize whether it's AMA, PCA, smooth muscle, or LKM kind of an antibody. So you can do also neurology panels. There's a commercially available neurology panels. You can have anti-Purkinje cell antibodies or anti-MA and the anti-PCA2 and ATR. So you can have the neurology panels for doing immunofluorescence. And you can also do direct immunofluorescence, obviously, that you're familiar with. This is what is this? This is skin. This is the basket weave pattern. What is this? Pemphigus vulgaris. And this one, this against the epidermis, and you can see the staining, linear staining here. In a bullous disease, what is this? Bullous pemphigoid, because of this linear IgG. Okay, here. So pemphigus versus bullous pemphigoid. This is IgA positivity in the papillary dermis. This is dermatitis herpetiformis. Okay. And this is vasculitis. You can see the vessels here and with a band test positive. So this is IgG. This is in case of lupus. So you can do direct immunofluorescence. You can also do use substrates like the HEC2 293 cells that are transfected with these proteins. So we can do indirect immunofluorescence for these DSG1 and DSG3 by doing indirect immunofluorescence. And you have the host of, for all the bullous diseases, you have the host of line blot assays also available. So that is about autoimmunity and a little bit of immunofluorescence. And I'll quickly now go through a diagnosis of immunodeficiency and the transplant immunology. Okay, when you talk of inborn errors of immunity, that's what we call the primary immunodeficiency diseases now, because the inborn errors of immunity, many of us are not aware of these diseases because we think that they are very rare disorders. But we need to know about these diseases because they are not very uncommon, and the prevalence can be as high as 1 in 1,200. So, and these diseases are much more common than hemophilia and cystic fibrosis that we are all familiar with. So these are not uncommon disorders, and we should know how to diagnose the primary immunodeficiency disorders as well. So this is the IUIS classification of the primary immunodeficiency disorders. It's quite exhaustive, and it actually looks very fearsome, but if you know the basics of how to pick up these diseases, you will be able to diagnose the primary immunodeficiency diseases also. So there are some warning signs if you see in a patient very rare or avirulent infections in a patient like pneumocystis jirovecii pneumonia or environmental mycobacterial infections that can, or if very atypical localizations of infections or unusual course or unusually severe infections and unusually higher number of infections. So these are certain signs which are indicative of primary immunodeficiency diseases. And we should, so how do you diagnose these PIDs? So if a patient presents with a lot of infections, very atypical infections, so you suspect a PID and try to diagnose them. So first step is to think of a PID, and unless you think of PID, you will not be able to diagnose. So think loudly of PIDs, and you have to have this back in the back of the mind that why is this child having so many infections with so many atypical kind of pathogens. So that's when you think of PIDs. Okay. And in the field of PIDs, this slogan called Think Zebra. Think Zebra basically means when you think of hear horse, the hoof beats, you think of horses, but it's not always horses. It can be a zebra also. So think zebra. You have to think of rare things to diagnose the primary immunodeficiency diseases. So think zebra, and there are basically three basic techniques that you need to diagnose the primary immunodeficiency disorders. As a very simple CBC, I'll come to a few examples. A very simple CBC, the differential count and the total count, very important for diagnosing the primary immunodeficiency diseases. Nephelometry for doing the serum immunoglobulins, and then a flow cytometry to look at these different cell populations. So these are three basic techniques that you need to set up if you are trying to diagnose primary immunodeficiency diseases. Okay, and so if you diagnose primary immunodeficiency diseases out of these three techniques, then you can go ahead and do a genetic analysis, okay, and establish a diagnosis. Okay. When you talk of the primary immunodeficiency diseases, we have to basically think of three components: the innate immune response and the adaptive immune response in context of the T cell and the B cell. So these have for example, if you look at the immunology, the macrophages or the phagocytes, they are very important for handling the catalyst positive bacteria and fungi. The T cells are very important in handling bacteria, fungi and viruses, and the B cells are very important because they produce antibodies, they're very important for handling extracellular pyogenic bacteria. So when you have a deficient system, any of these components is deficient, we'll have infections. For example, if there are phagocytic defects, then the patient will have a lot of infection with catalyst positive bacteria, because that's what they handle, okay, and fungi. If it is a T cell defect, because the T cells are very important in handling everything almost, so the patients will have a lot of infections with pyogenic bacteria, viruses, fungi, everything, okay. And if you have a B cell defect, the patients are susceptible to pyogenic bacteria and enteroviruses. So depending on what kind of infections the patient is getting, this is the information that we'll get from the microbiology lab. Then you have to work up the patient accordingly to diagnose which arm of the immune system is defective. So what do you do? The first step is a very careful look at the complete blood counts, the TLC and the differential count. If you find absolute lymphocyte, it's very important to look at the absolute counts, not only the differential count, the absolute lymphocyte count and the absolute neutrophil counts are very important. So if an absolute lymphocyte count in a child is less than 3,000, this is very abnormal. These are magic figures. If you find an absolute lymphocyte count of less than 3,000, you have to suspect severe combined immunodeficiency in that child. Okay. If you have a neutrophil count of less than 15,000, this patient has neutropenia. You have to think of congenital neutropenias. So a very careful look at the CBC is very important. Very careful look at the total count is not only the total count and the differential, but the absolute counts is very important. Then you have to do a look at the serum immunoglobulins to diagnose all the B cell disorders. So you have to look at the IgG, IgA and IgM serum levels by nephelometry. Then you have to do a flow cytometry. This is what you need, basic T, B, NK panel to look at the number of T cells, number of B cells and the NK cells. So these are very important to work up a patient with suspected primary immunodeficiency. Okay. And DHR is a very simple test that you can establish in any laboratory, very inexpensive. All you need is a flow cytometer. So DHR assay is very important. Okay, this is the NBT. This is the NBT dye reduction in patients with chronic granulomatous disease, where there is a defect in the NADPH oxidase system. Okay, the patients here, if you do the NBT dye reduction test, it's a very inexpensive dye. You just take the buffy coat of the patient and the control here. You give the NBT dye, incubate it with the NBT dye. The normal individual will reduce this dye to this black parmesan pigment, whereas a patient with chronic granulomatous CGD, chronic granulomatous disease, because they don't have they cannot produce hydrogen peroxide, they will not be able to reduce the dye, and you have this defective. You can do flow cytometry for DHR to diagnose these patients. Very simple tests. All you need is the DHR dye to do the DHR assay. Very simple flow cytometry based tests. So So I won't go into details of this. So a lot of flow cytometry assays that you can do to diagnose the CGD patients. Okay, and the simple TB and NK panel, if you see in this patient with a 2 months old female child presenting with failure to thrive and pneumonia, you can see that there are no T cells in this patient, no B cells in this patient, only whatever lymphocytes are there, it's all NK cells. So no T cells, no B cells, only NK cells. This is T negative, B negative, severe combined immunodeficiency. So just by looking at the TB and NK cells in a flow cytometer, you can say that this is a patient of severe combined immunodeficiency that needs to be transplanted very urgently, or else the patient will die. This is an example of a X-linked A gamma globulinemia where there are no B cells at all. See, CD19, no B cells here, only the T cells. So flow cytometry to diagnose the X-linked A gamma globulinemia. So these are the comprehensive laboratory evaluation for T deficiency. For T cell deficiency, you will need to do the CD4, CD8, and CD16, and you can do other tests like production of cytokines and all. But simply a TB NK panel in flow cytometry gives you a good armamentarium to diagnose the severe combined immunodeficiency. For example, for B cell deficiencies, you need to do the serum immunoglobulins and the IgG subclass and the B cell numbers. That will give you the patients with B cell deficiency. And for the phagocytosis, you need the absolute neutrophil count will give you a clue. And you can also do other assays like the NBT slide reduction or the DHA flow cytometry that I said. So these are some basic tests that you can do to diagnose patients with PID or primary immunodeficiency diseases. So some basic take-home messages for primary immunodeficiency and what you can do in the lab is you can get very big clues from very small tests. Like the CBC is going to give you a lot of information if you are doing the absolute counts very regularly. And if you have the serum immunoglobulins and lymphocyte subset analysis, this is enough to diagnose majority of your primary immunodeficiency patients. So flow cytometer is a very versatile tool for PID diagnostics. You need a flow cytometer to diagnose many of these diseases. And only problem is to do flow cytometry, you need viable cells. Obviously, you need a fresh sample, and cannot do flow cytometry in a stored sample. And healthy control samples are very important. Whenever you run an assay for flow cytometry, you have to run healthy control samples together with them. Okay. Very brief about the HLA typing and antibody screening. There are very many techniques which are now there for HLA typing. If you have a transplant setting, I'll just give you a brief of this because you may not be having a transplant setting here, but you need to know what goes behind workup for a transplant patients. Serology was one technique which was done very regularly for doing HLA typing, but now this is obsolete. The techniques that are used for HLA typing are now the sequence-specific priming and sequence-specific oligonucleotide probing, the SSP and SSOP techniques. Then you can also have, for high-resolution typing, you can have the sequencing or the SBT-based or bead-based techniques. And lately, this is the epitope mapping that is actually coming up for HLA typing. For cross-matching, obviously, you need a flow cytometer and bead-based techniques, and now what we call as a virtual cross-match techniques. Okay, so these are some techniques that you require. I'll not go through details of these. Okay, this is the sequence-specific SSP technique for doing the HLA typing. This is SSP gel, and you give a typing of the patient depending on looking at the gel. This is SSP and this is SSOP. Okay, I won't go into details of this. So lastly, but not the least, when you are doing all these techniques, you also need to look at the quality of tests that you are doing. So quality control programs to whatever you are doing, whether it's autoantibody screening or HLA typing or cross-matching or primary immunodeficiency disease, whatever you're trying to do, whatever you're trying to establish in a laboratory, is very important to have a good quality control program. And that's part of all laboratory techniques. And internal quality control, you have to be systematic and continuous monitoring of proficiency testing. You have for validity of testing, the reliability of your results, and the accuracy of your results. Okay, so quality control programs are very important. The categories of controls, you can have internal controls, or every kit, for example, if you're doing the ELISA, you'll have the kit controls along with the kits. Those are internal controls, but you can also, should also try to get external controls from outside. Okay, that is also another. For example, the external controls, you can have controls from EPICS and national reference laboratories, or you can have commercial control panels or in-house controls from routine testing. So if you have a positive sample, you can run that again as an internal control the next day. Okay, you can have samples from another lab to recharacterize, or pool test kit controls or freeze-dried controls. So these are external controls which you always try to incorporate into your testing. And in quality control in ELISA, one very good thing to do is you're keeping positive controls and negative controls. You know these are positive is positive, negative is negative. But you know what you need to actually look at is something which is intermediate. So it's including borderline reactive samples as control is a very good practice that you need to adopt. So thank you, and this is just a very basic kind of overview of what you need to do if you are trying to establish immunopathology testing setup. Thank you so much.
Thank you so much, sir, for such an informative session. From audience, if you have any question, you can ask. Actually, sir, we are planning to set up not complete immunopathology setup, immunofluorescence rather than we are planning, because derma many cases are they are giving to us. So it will be helpful for us how to set up this immunofluorescence. Thank you, sir.
It's okay. Is similar. Any questions? So I basically showed you what we are doing in the entire country. We don't have many institutes with an immunopathology setup. I think PGI is the only institute which have a dedicated immunopathology department. And but this is a very, among the pathologists and the students, immunology is one thing, as I've already said, you always try to run away from. As a resident, even I used to run away from immunopathology, but since we thought that, but this is a time where you cannot avoid immunology. You have to train yourself on immunology. You have to know the principles behind immunology and how you, and if you are trying to run a private lab, you cannot do without ELISA. You cannot do without the testings that immunological base, which involves basic immunology. So you have to change your mindset a little bit and also read not only morphological pathology. Obviously, histopathology and cytopathology are very promising kind of, as pathologists, we always love to be on those areas. But these are also areas that you should be very aware of. So that was the message. And I just try to give a very broad overview of what you do in immunopathology. Thank you so much.
Thank you, sir, for such an informative and wonderful session. Now I would like to invite Dr. Babai Haldar, sir, and Dr. Atnu Roy, sir, to felicitate our speaker. I would like to request Dr. Biman Sakia, sir, to come on stage for felicitation. स्क्रीन छोटा होने नहीं रहा ना
लोगोटा दिए दे Investicon
नहीं हो रहा मैं से प्रेजेंटेशन भी हो रही है Sakia, sir, to come on the stage to felicitate our chairpersons.
Thank you very much, sir. So next topic for today is interpretation of atypical laboratory result where clinician need your help by Dr. Shushruth Sen, Lab Director, BM Birla Hospital. But due to some engagement, sir is not with us here, so this session will be recorded session. The chairperson for this session would be Professor Dr. Swapan Kundu sir, Department of Obstetrics and Gynecology, and Dr. Arindam Ghosh sir for Department of Biochemistry.
So I'll just slightly modify the announcement. Sir is not being able to join us because suddenly his mother-in-law went into coma. So, and that is why he is joining us online. And after the session, for any question answers, he'll be there with us online to answer the questions. And our chairpersons for today are Professor Swapan Kundu sir. He's the Professor of Obstetrics and Gynecology in our college itself. And Dr. Arindam Ghosh, he is coming from IIT Kharagpur. So he is the Assistant Professor of Biochemistry in IIT Kharagpur. So we welcome you, Dr. Arindam. He was our ex-faculty in MGM Medical College and a very dear friend of ours. So welcome back, Arindam. Please be here.
Good afternoon, everybody. Patients come to clinicians for cure of their problems. With a history and clinical examination, they do some differential diagnosis. They are like medical detectives. So they have some differential diagnosis in the lowest tier of the pyramid. To reach the apex of the pyramid, they need some inputs like laboratory investigations, like imaging techniques, and some special tests. Now, sometimes we clinicians cannot correlate our clinical findings with laboratory investigation reports. And we are in a dilemma. To remove that dilemma, here we present Dr. Sushruta Sen to guide us to the right track, who couldn't come here as already spoke. And he will guide us through the journey. He is presently working as Laboratory Director, Department of Lab Medicine in C.K. Birla Group of Hospitals and B.M. Birla Hospitals. He graduated MBBS from Kolkata Medical College, completed MD Biochemistry from Bardwan Medical College. After that, he had done DNB Biochemistry, Diploma in Diabetology, and Postgraduate Diploma in Hospital and Health Management from Symbiosis Pune. He has numerous publications, national and international, organized various conferences and CMEs, and delivered guest lectures in national and international forums. Over to you, sir, Dr. Sushruta Sen.
And today's my topic of discussion is interpretation of atypical lab results where clinicians need you. So to go with this topic, actually, I would like to give some cases and case studies. Through that, I would like to establish the fact that there are conditions where a lab medicine practitioner comes to help of a clinician very often, particularly when the results are very difficult to interpret clinically. The interpretation capacity of the lab medicine lab physicians are very important on that end. So let's start with this this scenario that you have actually come across so many times, that when the patient comes to you and doesn't believe the report, or the clinician comes to you and don't want to believe the report, but you know you have done a right report and you have to explain it. So you need to have this capacity to explain your reports or the interpretation, clinical interpretation of your report, so that the patient gets the right treatment on the basis of the report. So that lies the conditions where I should say your knowledge on both on clinics and lab medicine helps you a lot. So first we talk about something, because this particular one is very common, is disharmony of hormonal assay. So when there are lots of hormonal assay, when it's difficult to interpret and difficult to go through. So first we start with one, case study one. This is very common. I always call that prolactin to be the nightmare of the lab medicine practitioners. So during routine investigation, you have found a young woman with having a prolactin value just above the expected level, about 32, and therefore you ask for a cross check. But the result of the repeat analysis came to be 18 nanogram per DL, which absolutely within normal limit. Now it is your role to defend your results, as both of the results were supposed to be right, and you have to understand what are the factors that can transiently affect the results in this condition. So prolactin is one of the very I should say very common parameter where actually we feel this kind of problems, because this prolactin can be varied. Prolactin concentration varies particularly in various conditions like minimum excitement, stress, trauma, and even a breast stimulation event also. So these are the things are very typical things which can happen to anybody anytime, and therefore with certain conditions suddenly there will be a rise of prolactin secretion, and these things can occur because of it. And even more difficult, certain drugs which is even over-the-counter drugs like domperidone or ranitidine, how many of you actually purchase it on over-the-counter like Pan-D or something, that these things also affect prolactin secretion very closely. So there are several factors which can transiently cause a rise in prolactin secretion, and therefore whenever you are releasing a prolactin report, be very cautious on these interpretations, where are the factors when these results can vary very widely. Second case study as a very important one, that a patient has done a thyroid testing and come to be slightly above normal, about 5.9. Now the patient was not happy, as more of the patients having an abnormal report never becomes happy. So you decided to go for a retest in the evening, whenever the patient came for a testing. So report delivery of the report time, you have decided to have a retesting, and now it has come 4.3, which is below normal range. So patient wants to believe the second report. Now you are in a very bad situation that you have given a patient to be hypothyroid, and immediately after that retesting, you supposedly giving it to be a normal. But you have to understand that in these conditions, you should keep in mind that TSH is one of the hormone which has got a heavy circadian variation, particularly actually having maximum secretion from 2 to 4 hours and minimum at around 6 p.m. So whenever you are actually in the morning, you were rightly pointed out the patient concentration, but when you have asked for retesting, that time the patient is having a secretion at its nadir. So therefore, you should be very cautious about whenever you are asking for retesting, and these particular parameters which has got a circadian rhythm or circadian variation, where the highest in the morning, lowest in the evening, can do have this kind of effects, and never recheck on an odd time. So if want to recheck, you do in the same time where you have repeated the first, checked in the first instance. So now next, the case study 3. This is a very common one, and I had actually this is happened to one of the very reputed minister of our state, and this happened to be my patient, and he was very angry on me actually. The patient has come initially with a sore throat, and that time the tests were done, and patient was grossly found to be hyperthyroid. They undergone some kind of treatment, and therefore after 1 month, when again our retesting was done, he was found to be a normal euthyroid patient. It was a euthyroid condition, and therefore nothing problematic. But problem happens when after 2 to 3 months, when the patient has gone for a regular health checkup and done a battery of tests when TSH is also there, and there he found to be a grossly hypothyroid with a high TSH. Now he came to me and saying that how come you give 3 different reports to a single patient who is never treated with the thyroid drugs. So this is a very common thing and is a very interesting also. This is typical of a post-thyroiditis event. During the phase of acute thyroiditis, you know there is an inflammation and the bursting of the thyroid cells releasing good number of T3, T4 in blood, and therefore there is a definitely TSH will have a negative feedback and will reduce its secretion. So therefore you will find a typical feature of thyroid, hyperthyroid, where high T3, T4, low TSH, something like that. And therefore the major problem lies there. Then after that inflammation was treated with antibiotics and others, the patient settles down and the patient goes to euthyroid status. But there is problem depending on how much of the cells were destroyed during the thyroiditis. 30% of the patient may go to the hypothyroid status because a loss of or damage of good number of cells. 70% remains in the euthyroid status, no problem with that. But those who actually goes down to hypothyroid state due to loss of the glands or cells, therefore this even can happen when you are diagnosing a patient to be hyperthyroid, then euthyroid, and followed by a hypothyroid status. So you should have a proper explanation whenever you are facing such a problem. This is another very interesting case. The patient was done patient on Cushing's syndrome. Now the doctor wants, the clinician wants to differentiate between a Cushing's disease or a primary adrenal tumor or ectopic ACTH. So the CT and all these things were done. Everything was going at par, but the result of ACTH came to be very low and cortisol came to be very high, which is very much suggestive of a primary adrenal tumor. But nothing found in MRI, nothing found in CT. So there lies the problem. So what to believe as per this report? If ACTH is very low and cortisol is very high, this goes more in favor of a primary adrenal tumor, but without any evidence of a tumor, what to do? Actually, what happened? ACTH, majority of the cases we do in-house testing, yeah, right? And ACTH mostly we send on the outside. So what happens, ACTH is one of the very, very fragile parameters which actually can be oxidized, can be absorbed to glass surface, or can be degraded by plasma proteases. So and extremely heat sensitive. So by the time it reaches to Mumbai or Delhi to the referral lab, so actually how many of them are properly collected? Not. So what happens when that reaches that Mumbai or Delhi, that almost destroyed, and you are getting almost very low ACTH value and entirely changing the diagnosis. So therefore, that is very important. The item with calculation of ACTH, so no prior administration of steroid drugs, no stress, and it should be collected in a polystyrene tube containing EDTA and protease inhibitor aprotinine with some antioxidant like markup to ethanol, and obviously it should be taken in aliquoting plastic tube and frozen at minus 20 degrees centigrade. I'm afraid how many of you actually do that. So whenever you send for testing, by the time it reaches lab, there is nothing left in ACTH. So this kind of typical problem can arise. And this is nothing was there clinically, it's just only one thing. The ACTH fragility and ACTH heat sensitivity here is the major problem that actually changed the. So now if we come to the case study of 5, a patient report of prolactin was normal. The patient, a 25-year-old lady, and there is CT scan showing an adenoma of prolactin, pituitary gland adenoma. And patient having a clear signs of hyperprolactinemia like milky discharge or amenorrhea, but your result has come normal. So what happens? This condition is, now you have diluted the case, and patient with the sample was run in 1 in 100 dilution, and the result has come to be 156 nanogram per ml. So this is a classic case of a prozone phenomena or hooking effect. Okay, what happens when excess of prolactin saturates the antibody binding sites, and that is why there is no adequate antigen antibody complex formation happens. So this is a very common thing, but how to understand? You cannot dilute all the normal patients. So here a patient and clinician's understanding and interaction is very, very, very vital. So that is whenever the clinician gave the query that it is a clear clinically hyperprolactinemia case, then you took a call and done a 1:100 dilution. So therefore, every case is a suspicious case. Its clinicians also should contact the lab and give their suspicion, because in that, by no means a lab can detect a proson phenomena unless there is a strong clinical history suggesting that the patient normal report may not be normal. Now the case study 6, a patient was admitted for 3 months with a chronic illness, and therefore after discharge somehow, again nowadays you know the one side a battery of tests are done. So some battery of tests are done with the package, and now what happened, patient is found to be hypothyroid. So I was very anxious. Fortunately, the clinician did not advise any treatment for it. So how come a patient becomes hypothyroid all of a sudden? So that happens. This is condition typically called a non-thyroidal illness or CQ thyroid syndrome. This typically happens that during the phase of a chronic illness, what happens, the TSH starts decreasing, and T3 and T4 also starts decreasing, particularly T3 decreases more than T4. Therefore, another hormone actually is released, it's called reverse T3, and the reverse T3 concentration becomes rising. So we don't have majority part, we don't actually have any facility to measure reverse T3. So what happens actually in reverse T3 increase, we don't be able to measure that. So what happens in these conditions, you see that during the phase of illness, that is low TSH, low FT3, FT4 is okay, understandable. But during the initial phase of recovery, the TSH jumps up a bit, slightly above normal range, and T3, T4 is yet to come to normal range. Now, in this phase of recovery, by chance, if you do the testing, then you are in a very difficult situation, because biochemical parameter wise, this is a clinically compensated hypothyroidism state, where you have a high TSH, slightly higher TSH, and lower than normal T3, T4. But this can happen in a chronically ill patient during the phase of recovery, and be very sure with your diagnosis, because otherwise unnecessarily the patient is going to have a unnecessary treatment for hypothyroidism, because after a few days it will be absolutely normal. But by chance, by mistake, if you find this in the recovery phase, you will be very much misled, and the patient will be diagnosed as hypothyroid. Is another one which I have admitted here. A nursing staff was found unconscious, blood sugar was 11 milligram per DL, and was stabilized with dextrose. Now patient non-diabetic, no significant family history, does not take insulin. So they went for a CT scan, nothing found abnormal in that. So what to do with, how to actually find out that the patient is actually having insulinoma or taken insulin from outside? So the best test is not insulin, because in patient who takes insulin from outside, body insulin concentration rises, or also in case of insulinoma, you will get a high insulin. The best thing is to detect C-peptide, not insulin. So here when the clinician asked me which test to do, I asked him to do C-peptide, because with C-peptide is released with each single insulin release inside body. From pro-insulin to insulin, there is a cleavage. One C-peptide and one insulin is released. So in-house insulin secretion, one insulin equivalents to one C-peptide. And C-peptide does not come with an external insulin. So whenever you want to detect a case where whether insulin was external or internal, is a C-peptide is your choice, not anything else. So finally, when C-peptide came to normal, we I interrogated and found that the patient has actually, with suicidal intent, has taken insulin from outside. Since she was nurse, she was available having insulin in her kitty. So that is the thing. So these are all about hormones. Now, how hormones are different from other analytes? Because in case of hormone concentration or analysis of hormone, you have to think of so many things because they are affected by so many things like posture, circadian rhythm, brisk exercise, pulsatile release. Yeah, there are certain hormones who have a pulsatile release. For them, we actually prefer a half an hour interval, 3 samples and to a pool sampling. Lifestyle and drugs, as I already told you, and storage and transport, I told you about TSH, ACTH. So these things are very, very important when you interpret a hormone result. So therefore, just a keynote. For insulin, you keep a note on meal timing, sample draw timing, medication, growth hormone, lifestyle, circadian rhythm, TSH, timing of sample draw because of the circadian rhythm, medication, cortisol. Obviously, you have to think of circadian rhythm and medication. ACTH and PRA, your specimen collection and storage has to be very, very important because these two parameters are very, very fragile. And obviously, prolactin, body stress stimulation or drugs are very, very important factors for particular interpretation of the results. Now, there are certain common things like clinical chemistry. So now I'm going for certain things where clinical chemistry confuses clinicians. So this is the first case. A patient, non-diabetic, with a sudden loss of consciousness, we assume it to be hypoglycemia. Patient was initially treated and blood sent for investigation. These are the lab results. Urea, creatinine, all the nadis, sodium almost half, RBS 675. What can be the thing? So what could be the thing? This is what? Nothing but a sample drawing from a line. So the patient was taking dextrose and from the same line, same channel, the blood was taken and all the samples actually being diluted to half except random blood sugar. So this is a clear case of a sampling error because the same line from the channel line the blood was drawn. That should never be done and the blood should not be taken from the same hand where the channel is on, the active, the IVV infusion is going on. Second case, a patient suffering from multiple myeloma. So you have found all the tests more or less normal, but phosphate is exorbitantly high. So now the test was sent to me because I was using the dry chemistry platform where I tested and found phosphorus to be 5.5. This is a very typical thing. Patients of multiple myeloma very often has an erroneous results in phosphorus, and you have to do in certain systems where this effect of paraproteins is not given on phosphate. So you have to keep in mind when you get a very high phosphate reports, particularly in case of paraproteinemias. Next, another is very important, a very favorite case of mine. A patient was admitted in CCU, was on TPN, and morning 8 a.m. blood sent for electrolytes and lipid profiles. So these are the results. So thyroid is a TG triglyceride was exorbitantly high, and the patient was found to be hyponatremia and hypokalemic. So the clinician called me up and was very confused, saying that this cannot happen because the day before you have given a normal result to the patient for electrolytes. Then I inquired and found the patient was on TPN. Now there lies the problem. As a common phenomena, you always find that overnight fasting or morning report is always the fasting sample. But here you know that total parenteral nutrition, that is patient was having Vitamix, and it is usually given at night, throughout night. So for a patient of TPN, a fasting sample is never morning 8 a.m. It should be 8 p.m. when there is at least a big gap between the last feed. So here a morning 8 a.m. containing full of Vitamix in the blood, and that is why showing a huge chylous serum with a TG3590. Now you know when there is a hypertriglyceridemia or chylomicronemia, because of this chylous nature of the serum, it actually affects test of electrolytes, and you may get a pseudo hyponatremia or pseudo hypokalemia on that. So these are the conditions you have to keep in mind when you are reporting that this patient was actually reported as pseudo hypokalemia and pseudo hyponatremia because of this vitrinics was flowing in his blood at the morning. So when the this is you need to know when you actually need to send the sample. Now it is another very, very important one which I consider myself as Sherlock Holmes when I actually found this one. So patient sample down from OPD by our phlebotomist only. The sodium was very high, 170. This unusual, but very unusual things of sodium. But one thing which actually led me give all the explanations is that see how low is the urea, 2.2. So I immediately had a call in my mind and called up the phlebotomist and said, no, just tell me what has happened. Because I am finding something very foul. I don't want to call up the patient because I don't think there is any problem with the patient. So then he described that he actually forgot that the serum sample is also to be taken. So blood taken initially in the fluoride vial for glucose, and from fluoride vial he has poured some of the blood in the serum vial to make up that. Okay. So the problem lies here that the sodium fluoride actually raises the sodium concentrations. Not only that, since fluoride is an inhibitor of urease enzyme, it dropped down to urea to 2.2. Now, that particular urea value actually gave us the main clue that there is something happened with the blood draw. So these are the things also you should keep in mind when you are interpreting certain cases. Don't jump on a conclusion immediately. This is the condition, as you know, I should say that medical checkup, superintendent of police, that usually we do check up all the police reports. So always, every time, you're hale and hearty with everything is normal, except a high CPK value. And the patient was denied to be fit, and they were very, he was very, very pissed off with that. And again, the person comes to me immediately that saying that I'm absolutely a healthy person and I cannot actually tolerate that this my heart condition is poor. I said, no, your heart condition is not poor, but let me tell you, let me take all the history of your daily routine. Then he said that it's actually wake up early, go for running, and then a heavy bout of exercise in gym, and then the person comes here to give the blood. Then I said this, for God's sake, on the day of when you are giving blood, don't do any vigorous exercise, because with everyday exercise, there 1 or 2 bouts of muscle tear may happen, which actually transiently raises CPK for the time being. So that is where the healthy person with nothing is there, just after exercise the person was coming and every time the CPK was coming as raised. The day he did not do such thing, taken good amount of water after running and then came out and got a normal report. So this is what also a patient preparation is also very, very important, and patient education is also a very important thing to save a lab person, professionals to save or to stand by its report. Another one, this is one of the example where a clinician should take a note. A patient has A1C 6.2, fasting 102, 1, PPBS 287. So absolutely you can understand this PPBS report is wrong. So it cannot happen. Why it happened? Because the patient is given blood at fasting condition, immediately taken a good amount of food, and after 2 hours given postprandial. So this is not an idea for a patient when you are asking for a follow-up. Because when you are asking for a follow-up, you just want to know how your patient is doing with the medication. So suppose you have given a glimepiride in the morning. So at 10 o'clock, you have asked the patient to take the glimepiride with the idea that it goes to blood around 1 hour, and then on the postprandial rise, it will give you enough support with insulin secretion so that get a postprandial getting controlled. So on the test, on the day of the testing, if the patient does not take a normal course food and does not take medication, so what happens? The PP comes to be absurdly very high. But when we are reporting, we are signing the report. When it reaches you, the clinician would definitely interpret a PPBS to be 287. Not absolutely wrong. But you should get an idea that this is a patient learns from its clinicians more than us. So the ideal thing is that take the medicine, take the fasting, then take the medicine, take the breakfast, normal breakfast, then take all the medications as per normal routine, do a proper lunch at lunchtime, and take PP 2 hours after normal lunchtime. That should be the idea. And if it is taught by the clinician, patient actually obeys that. So it's a dual responsibility. Patient should also be taught by the lab. They should have a policy of giving a proper PP, and also clinicians should also ask the patient to do exactly what he is expecting the patient to do. Otherwise, this kind of thing is always going to happen. This is what I've just given how it is works. Every time there is a glucose surge, there is an insulin secretion. So insulin always secretes like a basal and a bolus. With every bout of food, there is a bolus secretion. So the medications are actually helps to maintain this bolus secretion, and some of the medication takes care of the basal as well. But when you are not taking medicine as per regular routine, you are missing those kicks in the bolus secretion, and therefore patient is bound to have a non-report. This is another very interesting case. An elderly couple came for sugar testing. Husband diabetic but wife non-diabetic. So both have done the fasting PP, and the oral glucose tolerance test was done by wife because she was not diabetic. She wants to have a testing of the diabetes. So result came to me of the husband was fasting 122, PP 156, A1C 6.1, and of wife fasting 118, PP 42, A1C 6.2. I immediately thought it was a sample swapping. So that because husband takes insulin, so it is possible. So immediately thought it's a sample swapping. I called them up. The husband took the phone and said, I'm fine, I have no problem, but my wife is very dizzy after coming from your clinic. So then I understood this is a case, it's called dumping syndrome. So very thing, whenever you give a very high load of glucose, the body erratically responds with a very sharp rise of insulin, and there is a sudden hypoglycemia. So this is a typical case of dumping syndrome, when the patient, when dumped with oral glucose tolerance of 75 grams of glucose, responded very erratically and they had a sudden hypoglycemia. So mind it that in these kind of conditions, this sudden glucose load should not be given to the patient. Patient should be given very small dose of food, not a huge carbohydrate load at one point of time. So that is very, very important, and you should keep it in mind also. The case, this was also another case where a young boy, this is a very, very typical thing, young boy complaining of severe weakness and myalgia, came from overseas, very reputed nephrologist's son. So the nephrologist came to me immediately that I don't know what happened to him. He does not have alcohol, no other things. So why this is happening? Should I do hepatitis, all profiles and all? I said, fine, okay, you can do. The all serology came negative. Then she was very, very anxious, and I said, stop, I'm having some suspicion. So it's not a chronic illness, right? So no, he was hell and hearty. He came here, joined, then went for a gym, and after then 2 days, he is absolutely in bed, and he is having myalgia and total lethargy. I said, let me do two things. I am just doing CPK and LDH and urine myoglobin, and I am coming back to you. So this, I immediately found a very high CPK, very high LDH, and urine myoglobin positive. I said that ask your son to take water and obviously absolute bed rest, because this is a typical case of exercise-induced rhabdomyolysis. So here my confusion started that for an acute hepatitis, you cannot have an AST-ALT altered ratio. So this is where your clinician's clinical suspicion can lead to a very vital diagnosis. So the guy got saved because of the right time diagnosis of an exercise-induced rhabdomyolysis, and somehow we could give that diagnosis and save that son. So these are the things which is sometimes we do contribute very vitally to our clinicians. So last cases, obviously I'm finding this is very frequently we get the TROP-T negative, NT-proBNP marginally high, CPK 107, CKMB 106. Never ever take it as an MI because you see he is also suggested normal, no ST elevation found. Never ever take it as MI because his MI is called when CKMB is 4 to 25% of total CPK. CKMB, like heart, also present in cardiac muscles, only differ in skeletal muscle. Only thing is that in skeletal muscle it is 2% of total CPK, and in cardiac muscle it is 4 to 25%. So why not above 25%? Above 25% usually are not normal. So it happens when there is some macro CK effect happens. So CKMB molecules, if they are very big, very difficult to give an immunoinhibition. So it wrongly interferes the report and gives a very falsely high report. So therefore, whenever it is more than 50% of total CPK, it cannot be of cardiac origin. So you can forget it and you can give it as a macro CK. So these are one of the things you have to keep it in mind, that alone CPKMB should never be asked for because alone CPKMB is meaningless unless until you do it with CPK and quantitate against CPK. So these are the conditions you have to be very cautious whenever you are releasing the reports, and the reports must be helpful to the clinicians and should be properly correlable. So all about, and the last one I'm just going to give that one is suddenly I got it, and I delivered this in AACB Australia, and one of the best presenter award I also got from it, but it is came all of a sudden, just how I'm explaining that one of our clinician called me up and saying that you guys are giving potassium results abnormally high because in ABG the results which is coming around 4.8 to 5 is coming in your lab is giving it around 6. So there is some bias. I said, is there anything abnormal you are finding other than this? The samples are not hemolyzed at all. Then he said that, there once a thing I noticed, you may check it or not, that most of them are having thrombocytosis. That means high platelet counts. Usually those having high platelet counts, I am finding the difference in them. Then I walked on to 75 people on that because I'm fortunate that we have worked in a cardiac hospital also. I work in a cardiac hospital. I get very frequent cases like that. So that we have found that the patients with a high platelet count having concomitant hyperkalemia, because you always think the RBC is the source of potassium if there is any hemolysis. We never think that the high platelets can also contribute because platelet also a very rich source of potassium. So I established that there is a definite correlation between the high platelet count and concomitant hyperkalemia. So this has to be taken as a pseudo hyperkalemia, not as a hyperkalemia. If you find to be a very high patient platelet count is found to be very high. And that is why the ABG and in serum, the differences are coming. Because during the serum is tested on the lab reports are tested on serum, when during coagulation, probably platelet is releasing a good amount of potassium to the serum. So this is a very unique finding, I got it. And I also ask all of you, before raising an abnormal potassium report, you may cross-check once with a CBC and find whether it is a thrombocytosis or not. If it is, be very cautious calling it a hyperkalemia. So this ends my lecture. I think I've taken 5-10 minutes more. So I would like to take questions, if any. I would love to take. So thanks for your listening, and I'm very sorry that I could not make it physically there to present this thing. So I had some unavoidable situations which I could not avoid. And thanks for listening, and I would hope that sometimes I can go physically and give these lectures in front of you. Thank you.
So, Dr. Sushruta Sen is online, so any questions from the audience, you would like to address them, you would be addressing them. Dr. Sushruta, can you, are we audible? Am I audible to you?
Yeah, okay.
All right. So, sir is online, so please feel free to ask any question, any query from any slide if you had during the presentation. So, do I see any hands in the air? Anybody?
Sir, sometimes we get advertisements from different labs. So many testings which would cost you 12,000 rupees. We'll do it at a very cheap cost. Battery of investigation within 3,500. Are those reliable reports?
See, sir, the tests are reliable, obviously. I'm not saying that the tests are not done. The tests are done, tests are quite reliable. But the problem is that why to do unnecessary tests, that's the question. Sometimes you take some unnecessary botheration on you by doing this battery of test. I have shown a few instances there that during the test battery of investigations, you have also done TSH the time where you should not do. So certainly there are some conditions where actually you take the burden unnecessary by doing excess tests. So suppose in a person, health and hearty person, are doing full battery of tests and they're coming some LPA is coming high or some LDL is coming borderline high, and you get already to move towards a physician and start taking some atorvastatin. So I don't think these are necessary things, particularly by doing all the series of tests where it is not clinically indicated that much. So that much, but that does not mean that the tests are not done. The tests are done. Usually when they do in package, they consider the economics in the way that they can provide you that much test with minimum of revenue. So nothing to actually say about the test, whether it is done properly or not. That happily that is done.
Thank you.
I cannot vouch on every lab, but usually these packages and tests are done.
Okay. Sir, about prolactin, if we cannot correlate the prolactin levels, how much should I wait before doing another testing?
See, sir, the very next day you can do the testing. That's not an issue. Because I told you already, I have shown you that the prolactin is one of the parameters which fluctuates very easily with a minimum of provocations. So, and the major problem is that patient orientation or restriction to the patient is very difficult. Suppose prolactin in an overnight sexual intercourse at the night or late at night can also rise sharp prolactin in the morning. But particularly when a couple is trying for a baby and they are doing all infertility testing, you cannot say no to all these things. So that is, there are problems with prolactin, that there are certain conditions you cannot impose on the patients. You have to take the patient on a normal routine and then you have to interpret accordingly. And the best thing is that whenever you're actually reporting a prolactin, you should disclaim, as a disclaimer under your report, you should give all the possible causes which may affect your prolactin.
Thank you.
So otherwise, this is a very, I started with that, a nightmare of a lab physician.
And about AMH, any special instruction? AMH.
No, nothing as such. AMH actually, I have not seen to be getting interfered with such factors.
All right, thank you, Dr. Sushruto. In follow-up of reply to what Sir has asked regarding the reliability of a report from a specific laboratory, I would say it is more reliable if that laboratory follows certain accreditation standards. So if they are accredited by NABL and if they are following ISO 15189, no matter if they are offering a very cheap package, we can actually say legally that we can rely on those labs. So I hope.
No, actually, it doesn't depend on how cheap or how costly it is. Actually, it varies upon the load-to-load cases. Suppose a pan-India lab are gathering a test from all over India and performing the test, then they can do the test at a much cheaper rate, what a small standalone lab cannot afford. So it is. It depends on the workload and everything of yours. So we cannot actually vouch on anybody's quality just on the basis of the price.
Good afternoon, Dr. Sushruto.
Hi.
Hi. I wanted to know about this. Sometimes we get very high CK levels in neonates. What is the cause for that? There's no myocardial infarction or anything.
Yeah, the only thing is just think how you draw the blood of the neonates. So you just prick it and then you keep on pressing is the tiny muscles so that drop by drop blood comes. And do you think that much of pressure does not tear the muscles? So that is one of the reason it goes on a local tear of the muscles and you get a transient high CP. So you just think how you draw the blood. Just by any means a prick and then keep on pressing so that drop by drop blood comes. You see, you just imagine the scenario, you can understand how much a tiny small muscle tissue damage can occur which can raise CPK very transient. So there is nothing to do with the cardiac person.
Is there any like relation between the CK mass and the CK activity? It's the total mass of the.
No, the fact is that what you measure is an activity, and mass is what you measure as in a nanogram. Okay. So, but the fact is that when some muscles are getting torn, and the CPK is from the muscle is coming out to your blood, then its activity also increases, the mass also increases. The advantage by doing CK mass. Yes, you can do some advantage by doing CK mass when this macro CK effect comes. Because in that case, all these inhibitions and other methods that we do actually for measuring the activity. So if there is no inhibition of the enzyme active part of that particular CPKMB, that shows its enzymic activity, and that is why wrongly calculated in a very high value. So for those cases, CK mass can be of some effect, can be of some benefit.
Okay. Thank you, Dr. Sushruto.
But conditions where CPK is poured from the muscle to blood, the CK mass and activity are almost the same.
All right. Any more questions from the audience? So I think that wraps up this session. Thank you, Dr. Sushruto, for the wonderful presentation.
Thanks a lot.
And clearing the doubts in the live session. Thank you so much.
Sorry I could not be there, I just missed it.
Yeah,
I was thinking of going there, was looking forward to it, but unfortunately, anyway, thanks for it. Thanks for your listen.
Thank you so much.
Thank you, sir, for such an informative and wonderful session. Now I would like to invite the chairpersons for this session, Dr. Swapan Kundu, sir, and Dr. Arindam Ghosh, sir, on the stage. Next, I would like to invite Dr. Tapar Mukhopadhyay, sir, to come on the stage to felicitate our chairpersons. Thank you, sir. Next, we shall break for the lunch, which will be followed by the postgraduate quiz competitions. Thank you, everybody.
I think this is the most awaited, anticipated session for the PGTs because you had put in a lot of efforts for your paper and poster presentation, and I don't know how much attention you had paid to the presentations and the scientific sessions, but you were more interested in presenting papers and posters for your NMC criteria to be met and for the awards that were announced for this paper and poster presentations. So I take this privilege of announcing the awards for poster presentations first. So the third prize in, before that I would like to invite our Honorable Vice Chancellor, Professor Sudipta Bose sir, and our guest speakers, Professor Biman Saikia sir and Professor Uma Nahar Saikia ma'am, onto the dais to give away the prizes to the postgraduate students. So the third prize in poster presentation goes to Dr. Rachna Kumari from Obstetrics and Gynecology, MGM Medical College. Topics are... Can we have a mic extra so that...
The topic for my poster presentation is cryptomenorrhea, a case of imperforate hymen. Thanks to all of you.
The second prize in poster presentation goes to Dr. Sweeti Kumari from Katihar Medical College, Radio Diagnosis. You would like to say about your topic?
My topic of poster presentation is xanthoma tendinosum in familial hypercholesterolemia, a comprehensive review.
And the first prize in poster presentation goes to, any guesses? Yes, it's Gurpreet Kaur from my department. Although I didn't listen to her presentation. Yes, your topic.
Good afternoon, everybody. My topic was gonadal dysgenesis on Sware syndrome. Thank you, ma'am.
So we now move on to the distribution of awards for paper presentation, and the third prize is a tie, and the prizes go to Dr. Himanshu Verma from Radio Diagnosis, MGM Medical College. Is he not here? Okay, since it's a tie, I think the friend can take that, and the friend who is on tie is Dr. Arushi from pathology. Topic bata do, Arushi.
Good afternoon, everyone. My topic was cutaneous
Appendigeal tumors.
clinicopathological study of cutaneous appendigeal tumors. And special thanks to HOD sir, Babai sir, and Nirvana ma'am.
The second prize goes to Dr. Anmol Ghuman, ENT, MGM Medical College.
Good afternoon all. My topic was foreign body impaction in esophagus.
Any guesses for the first prize in oral paper? No guesses? Huh? Yes, it's Dr. Shubham Shankar Upadhyay from Orthopedics, MGM Medical College. He is not here. It was actually a marvelous presentation. I was myself present, and I actually had commented on, on that paper. Marvelously prepared slides, very well presented. I had told that all PGTs should learn how to make a PPT from him. It was really well presented, really well presented. Anybody from orthopedics? Biprojit can come and collect. He had presented something on back pain, I remember. So that's all with the award ceremony. Yeah, and other participants who had presented their papers and posters are requested to collect their certificates from the registration counter. Thank you, sir and ma'am, for your kind.
Thank you so much for having us.
So now, at the fag end of the conference, we have a quiz session for the postgraduates. All of you who are interested to attend the quiz, postgraduates quiz session, kindly stay back. It is going to be a really interesting quiz session. So kindly stay back and attend the quiz. It won't be more than a half an hour session. So kindly stay back.
In humans. And liver में primary मिलता है, but it can be found in all parts of the body. UG question है. Question 4. What is the most sensitive and specific test for detection of HIV infection? Question 5. Which test is best for detecting ANA, anti-nuclear antibody? अभी कुछ देर पहले विमान साइकिया सर ने which test is the best for detecting ANA? Sensitivity, specificity सब मिलाकर मैं बोल रहा हूँ. I'm not saying most sensitive, most specific. Best कौन सा है? Question 6. Name a condition other than sarcoidosis where asteroid body is seen. Asteroid bodies. Sarcoidosis is the most common cause. Name any other cause of finding sarcoidosis. Asteroid bodies. Asteroid bodies. Sarcoidosis को छोड़कर. This was not specifically mentioned by Uma madam, but उनके lecture के अंडर ये टॉपिक आता है. Granulomatous skin condition. Question 7, related to yesterday's workshop on core-needle biopsy. What is the size G? कौन सा नंबर के साथ G आता है ना? Of the coaxial needle used in core-needle biopsy. Coaxial needle का use अनुबोलर सर ने बताया सबको. So उसका क्या G है? Like for FNAC 22G, 24G है. So ये कितना G का ये needle है? ये you can more or less थोड़ा सा guess करके निकाल सकते हो. Question 8, which is the most common abnormality in females suffering from lung adenocarcinoma? This is related to Indranil Chakravarti sir's talk on personalized medicine or precision medicine. Which is the most common abnormality in females suffering from lung adenocarcinoma? Question 9, which instrument is used to take FNAC for convenience? वैसे तो needle और और सिरिंज से लेते हैं, लेकिन एक और डिवाइस उसके साथ अगर जोड़ा जाता है तो उससे और सहूलियत होती है. इट्स बिकम्स मोर कन्वीनियंट टू टेक द FNAC. What is the name of that device? ये शायद पैथो के अलावा PGDs को थोड़ा सा डिफिकल्ट होगा. और लास्ट क्वेश्चन, क्वेश्चन 10, which type of IHC or immunohistochemistry can be done to locate multiple antigens in the same tumor cell? एक ही ट्यूमर सेल में एक न्यूक्लियर एंटीजन है, एक साइटोप्लाज्मिक एंटीजन है, एक मेम्ब्रेन एंटीजन है, तो अलग अलग एंटीजन एक ही सेल में लोकेट करने के लिए एक खास टाइप का IHC यूज किया जाता है. इसको क्या बोलते हैं? डैश IHC. हो गया? प्लीज सबमिट योर पेपर्स. हाँ, अपना नाम, कोई एक का नाम भी लिखा तो चलेगा. ये आयुषी, विक्रम एंड अमिताभ एंड टीम, तीनों तुम तीन लोग एक टीम में हो या दो अलग टीम? ये तुम लोग रखो अलग अलग से टाइप करना है. यहाँ पर बता रहा हूँ, टाइप करो. शुभन, रोहन, प्लीज हेल्प. आंसर बोलছি আমি. You can give it to another team. जिसका पेपर नहीं है उसको दूसरे टीम को अगर दे दिया वो क्वाइट करके. ठीक है. क्वेश्चन 1, आंसर इज हेपेटाइटिस C virus. Question 2, answer is March 2020. Month and year, March 20. Question 3, hydrated disease. Question 4, RT-PCR. Question 5, immunofluorescence. Question 6, sporotrichosis. Question 7, 17G. 17 is the most common one. 18 ठीक है, चलेगा 18 16 to 18. Okay. Which is the question 8, EGFR. Question 9, Franzen device. Which is the most common abnormality in females suffering from lung adenocarcinoma? EGFR mutation. ठीक है, अगर सब लोग अगर गलत अगर होते हैं तो एक नंबर दे देना. किसी ने एक ने अगर दे दिया तो फिर नहीं दे सकते. Question 10, multiplex IHC. हाँ हाँ. बाकी लोगों ने क्या आर्टिफिशियल लिखा है? पीसीआर लिखा है. सर 18 to 20 से देख लेके करो. 18 to 20, 16 to 18. Anything between 16. हाँ. सर लॉकडाउन है तो दे 1 year में 1 का शुरू लिखा था. Half. Give them half. मिलना चाहिए सबको. 2020 या T20 का एकदम.
তোমার এই পিপিটিটা একবার খোলো যেটাতে ফাইনাল আছে.
ওটা তোমারটার মধ্যেই সবগুলো আমি করে দিচ্ছি. We have got the top 5 teams. First, topmost 7 out of 10, Dr. Deepak Kumar and Dr. Reshi Sinha. Wonderful. 7 out of 10 is really creditable. Next, we have tied on 5. We have, I think, three teams tied on 5. Dr. Bikram and Dr. Amitabh, big hand. Then there's Dr. Varsha. Okay. And Dr. Sonalika and Dr. Sadaf. 3 teams on 5, and the 5th team on 4.5 is Dr. Arushi and Dr. Tejinder. So, teams who are in the finals,
the teams who are in the finals just occupy the first 2 rows, and those who are yet to qualify for the finals, आप लोग do also participate because audience पे ही skip होगा, majority tough है. So please, those first 5 teams just occupy the first ये row, बस. Maintaining safe distance. হ্যাঁ আমি বলবো সেটা স্কোর কিপ করতে লাগবে তো Yes, we would be needing a scorekeeper for scorekeeper with a pen and paper should ideally sit in the front row because real time में will be updating with him or her किसका कितना हुआ 2, 3, 4 and 5 right so the scorekeeper should first enroll the name of the 5 teams so what should we call your team आपका टीम का नाम बताओ we should call you A, B, C, D, E. Okay. आप अपना नंबर याद रखो आप A, आप B, आप C, आप D, you are E. Fine? Okay. আমি বলো হ্যাঁ 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 হবে এবার এটা লাগবে হ্যাঁ
So 10 marks for a direct answer and 5 marks for pass.
हाँ हाँ ठीक है As we go on things will spice up a bit बाद में एक राउंड ऐसा भी है डायरेक्ट क्वेश्चन पे 10 अगर पास होके बोला तो 20 राइट सो बी विजिलेंट एंड नो प्रॉम्प्टिंग अगर आपको पता है तो बेटर आपको ही पता हो क्योंकि आपका नंबर भी आएगा सो वी नीड द डिस्प्ले ऑन द लैपटॉप प्लीज
Just for your information, Dr. Ashok Prasad has kindly agreed to sponsor the prizes. First prize is rupees 4,000 for the first place team. Rupees 2,000 for the second.
HDMI केबल ही खोला
1,000 for the third team.
बोलना है हाथ उठा के यू शुड नॉट स्पीक अप ठीक है ना जा
माइक एक लगेगा
पैरेलल आएगा सब आएगा ठीक है वो देख के ही बोल देंगे फिर अगर एक पे आता है तो नॉट एन इशू डुप्लीकेट ठीक You can ask me. So hello everyone. For this round, I will be your quiz master. We will be running back and forth between me and Dr. Barnik. So I am Dr. Arindam. I was a faculty here until 2 years back, and now it's a great privilege to be back here. So the first round I will be starting with direct question. Direct hit का मतलब है आपसे जो पूछा जाएगा आप बोलोगे, right? If you cannot, then the thing will pass. 10 seconds for answering direct, पासिंग में देयर विल बी नो टाइम. अगर आपके पास है, आप सोच रहे हो, तो ऑटोमेटिकली इट विल पास टू द नेक्स्ट राउंड. सो क्वेश्चन फॉर टीम ए. I'll be seeing the time. Which enzyme catalyze the steps of covalent cross-linking that will strengthen collagen? Interdiscipline है boss. Everything. It will consist of every discipline. आएगा. Enzyme strengthening collagen. Team A, your time is up. It passes to team B. No negative.
Collagenase नहीं.
Collagenase नहीं. Collagenase breaks down. ये during bonding. Team C.
Collagen synthesis.
No. D. You just wait with the mic. If they know, they will.
Elastase?
No. It will go to the audience, yeah. एक minute.
NADPH?
No. Okay, I see one hand. So audience prize, बोलिए. Yes. You are close. It's either lysyl or prolyl. So yes, I give it to you.
Thank you.
It's lysyl oxidase or prolyl oxidase. Fine. Oh, then I leave it to the discretion of the observers. Fine. Question for team B. Team A तो नहीं हुआ ना उनका. आपका ये direct question है. Precursor protein of ACTH. What is the precursor protein of adrenocorticotrophic hormone? ACTH किससे बनता है? बस. Half answer is given. Okay, time up. Pass. Team C. If you know, then only ask the mic. If you don't know, just हाथ घुमा दो. Pass. Team D, would you like to try?
Sir, TPP?
No,
or
not
vinyl?
No, नहीं. Audience? Okay, right. Team A. It's not audible. Actually, it was. सबको सुनना चाहिए.
Pro-opiomelanocortin.
Absolutely right. It's pro-opiomelanocortin. 5 marks to team A. POMC. Right? So direct question for team C. Name a trisaccharide where all 3 monosaccharide are present. Very easy. I mean MBBS level का question है. एक ट्राइसैकेराइड बोलो जिसमें तीनों मोनोसैकेराइड है. मान लो ग्लूकोज एक मोनोसैकेराइड. इफ यू जस्ट फॉरगॉट व्हाट इज मोनोसैकेराइड, सो वो ट्राइसैकेराइड का नाम बोलो.
Galactose?
No, galactose is itself a monosaccharide. Okay, so next question passes to team D.
Is it fructose?
No ma'am, fructose is also a monosaccharide. हमको ट्राइसैकेराइड चाहिए. गैलेक्टोज भी मोनोसैकेराइड ही है. टीम ए, उसके बाद टीम बी. पहले टीम ए. नो? हाँ, उनका नंबर गया. उन्होंने हाथ उठा दिया. Okay, fine. Anybody would like to try?
Sucrose.
Sucrose is a disaccharide. हमको एक और स्टेप अप चाहिए. ट्राइसैकेराइड. सो ये जान लो, दिस इज अ वेरी कॉमन क्वेश्चन. द आंसर इज रैफिनोज. ठीक है ना? रैफिनोज इज अ ट्राइसैकेराइड जिसमें तीनों मोनोसैकेराइड है. ग्लूकोज, गैलेक्टोज एंड फ्रुक्टोज. सो तीनों कंटेंट का आंसर हमको सबसे मिल गया, बट अल्टीमेटली पेरेंट कंपाउंड इज रैफिनोज. डायरेक्ट क्वेश्चन फॉर टीम D. Name a non-protein amino acid that is found in vitamins. एक अमाइनो एसिड जो विटामिन में मिलता है, that is not itself a protein. In this round only team A has scored 5 till now. Okay, no? Okay, fine. They pass. Team E, any guess?
Tryptophan.
Tryptophan? No. Right. Anybody? Audience?
Arginine?
No. Okay, I open up a clue for all the teams. जो पहले हाथ उठाएगा उसका नंबर, ठीक है ना? It is an acid. What acid?
Niacin.
Aspartate,
Niacin.
niacin नहीं है. नहीं है. सब तो प्रोटीन है ना? Aspartic acid is a protein. Glutamic acid is a protein. Answer is pantothenic acid. ठीक है ना? सोचा था तो बोल दो. Okay, so now the last and direct question for team E. एक ऐसा essential and stable biomolecule, all right, जिसमें कार्बन मेटल बॉन्ड है. An essential known and stable biomolecule that has got a carbon metal bond present. नाम तो सुना है बहुत. When I say, you will think, oh, ये था. नंबर आएगा. पहले ask. Okay, so it passes from team E to team A. No? Team B?
Still go with Teflon.
Teflon?
I don't think so.
कार्बन मेटल, उसमें टेफ्लॉन में कौन सा कार्बन और कौन सा मेटल है? बायोमोलिक्यूल ना. टेफ्लॉन वी डोंट गेट इन द बॉडी, है ना? वो बायोमोलिक्यूल नहीं है. एनी गेस? ऑडियंस एनी? मेटल कौन सा है कार्बन डाइऑक्साइड में? हाँ, राइट. सो मिथाइल कोबालामीन का नाम हम लोग सुने हैं ना, तो वहां पे कोबाल्ट रहता है, राइट? फाइन. So after this, so I think there is one more question for the audience. This will be a direct question. No, ठीक है, fine. We'll go break down the audience question last. So after the first direct round, we have got team A who has scored 5 marks, right? So now the next round will be conducted by Dr. Barnik.
Team A, nobody has scored. Okay. Okay, we'll go anti-clockwise. So starting with team E. This round is on microbiology. Okay. A virus belonging to the family Paramyxoviridae caused a severe outbreak a few years back in Kozhikode and Malappuram districts, claiming 17 lives. A movie was made on this event called Virus. In which year did this outbreak take place?
Sir,
Unknown virus, it was called.
2018, sir, Nipah virus.
I think you have got it correct. I'll just, yeah. So, plus 10 for team E. The next question for team D. A 45-year-old male patient presents to the emergency department with a 1-week history of severe headaches, nausea and confusion. He mentions eating undercooked pork during his visit to Goa a year ago. MRI of the brain reveals multiple cystic lesions with ring-enhancing characteristics. lumbar puncture with CSF analysis shows evidence of inflammation or pleocytosis and increased protein levels. What is the likely causative organism?
सर न्यूरोसिस्टी मतलब क्रिप्टोकोकस की वजह से न्यूरोसिस्टिस.
Those are two different organisms.
Sir,
name only one.
न्यूरोसिस्टिसर्कोसिस है सर एंड ऑर्गेनिक.
एक ही नाम बोलना है. या Taenia solium causing neurocysticercosis. The one you were mentioning later was of fungus, opportunistic infection in HIV patients. Okay, so this is a high scoring round. Both teams have got 10 each. Question to team C. A 50-year-old male patient from a village in India presents to the clinic with complaints of progressive swelling and pain in his right leg. Over the past several years, he reports that the swelling worsens during the night. He also mentions recurrent episodes of fever and chills. His right leg is grossly swollen with thickened and hyperpigmented skin. Blood was drawn at night and microscopic examination of a thick blood smear revealed the following. As per NVB DCP, what are the current drugs used as prophylaxis to control the spread of this condition? I think the full form of NVDPC is National Vector-Borne Disease Control.
That may be a part of the question.
No. I think they can identify the organism by the picture.
Albendazole.
की सर ठीक
नहीं ये पास हो
गया.
बोल दिया है. पास होना है कि
पास.
ये किस पे जाएगा? डाइथाइल कार्बामेजिन DC.
Actually, it's a combination. It's not just one drug. So combined is the
Ivermectin, DC, and
plus albendazole.
DC with albendazole. So
Are they getting 5 marks?
5 marks.
Although the patient will not be cured.
5 and 2.5.
5 or 2.5. आधा बोले हो यार. 5 का हाफ.
5 का हाफ.
5 का हाफ.
भाई है ना. Out of 5 you are getting 2.5. Out of 10 you are getting 5. Question to team D, to team B. One fine day, a farmer Joe notices something odd about his favorite cows, Bessie and Daisy. They seem restless and are mooing louder than usual. Concerned, he calls Dr. Felton to investigate, who observes Bessie and Daisy closely, noting their unusual behavior. They are agitated and seem to be staggering a bit. After a thorough examination, the doctor suspects something serious, a case of mad cow disease. What are these infectious proteins called that cause neurodegenerative diseases in animals and humans? Brian. इसमें already PG activity हो चुका है. So answer is pretty easy for. It's a very, very high scoring round. Question 5 to team A. A 65-year-old woman presents with complaints of persistent cough for the past few months. She has no history of fever, weight loss, or night sweats. She mentions that she has a passion for gardening and recalls experiencing occasional episodes of mild asthma-like symptoms during springtime. Chest X-ray and subsequent CT scan of the chest reveal a well-defined rounded opacity within a cavity in the upper lobe of the left lung. Sputum culture revealed growth of mold. Below is the teased LPCB mount of the growth. What is your diagnosis?
Sir, ABP, aspergillosis.
Correct. 10 marks for team A. Aspergilloma. Okay, next round again we start with team A. So these are on ultrasonography. So these questions have been provided mostly by Dr. Ashok. Thank you, sir. When do we do antenatal screening for neural tube defects? So gestational age का एक range बताना है. कौन से week तक से कौन से week तक?
11 weeks.
Range बताना है.
11 to 14 weeks.
No.
16.
Team B. एक माइक पे बोलना है. कोई सुन नहीं पा रहा है.
16 to 18 weeks.
16 to 18. We'll come back to you. Anybody who would like to improve on this, if nobody gets to the exact answer, we'll give the marks to team B, but let the other teams try.
12 to 18 weeks.
Team D.
16 to 20.
16 to?
20.
16 to, correct. So 5 marks for team B and 2.5 to team D. Actually 16 to 22 है, 20 को. Okay, question. See, MTP. Correct. That's why I gave when.
How can you diagnose spinal cord defect at 10 weeks? There is no calcification.
नहीं 10 weeks नहीं sir.
Before 20 comes 10 weeks.
Anyway, I think they have got the closest 16 to 20 weeks is acceptable. Question to team B. नहीं. Team B को 2.5 मिलेगा. 5 नहीं. 5, 2.5. Team B, double bubble sign is seen in which condition? Team B.
Sir, pregnancy, dichorionic diamniotic pregnancy.
Duodenal obstruction.
Can you be a bit more specific? Duodenal obstruction is more wider answer.
Sir. Duodenal atresia.
Duodenal atresia. I'll give the marks to two and a half. Oh, no, 5. 2.5. Sorry, 5 marks to team. See, duodenal obstruction can be in any age. Primary acquired, congenital acquired, whatever. This is a congenital condition. So you have to be more specific. Question to team C. Elephant trunk sign is seen in which condition? Team D.
Sir, neural tube defect.
Neural tube defect. Sir? नहीं. Team E. Team A. Team B.
नहीं.
Cloacal extrophy. I'm going by Dr. Ashok's set of questions. मुझे इसके बारे में आइडिया नहीं है. जो आपने दिए थे उनमें से जो वो ट्रू फॉल्स थे उसको छोड़ के बाकी जो थे उसको मैंने इंक्लूड किए हैं. ट्रू फॉल्स तो इसमें नहीं दे पाएंगे. Question to team D. What is the condition when the spinal cord of the fetus is exposed at the dorsal surface of the fetus? Question to team D.
It's a spinal cord of the fetus.
You're jumping the gun. I think you have already answered wrong, so you have to go to the next team. I don't want to elaborate on this question because it's quite obvious. If you read it carefully, this has to be some congenital condition, not an neoplastic condition like the answer. Team A.
Spina bifida neural tube defect.
This is part of that particular big spectrum of disease.
Quadra
Plastic or specific. अगर बता पाओ तो ठीक है, नहीं तो you get the marks. No other team gets to the most because it is quite an uncommon condition. What to the broad category of the Podicina is part of the normal anatomy. Podicina is not a lymph disease.
Spina bifida occulta, sir.
I think I'll give the audience में आएगा, लेकिन हम 2.5 मार्क्स टीम एक को देंगे. आप बता सकते हैं? Meningomyelocele is covered. ये एकदम open रहता है. This is an open condition. Rachis 2.52 T में. This is part of that big group of conditions called neural tube defects. Okay, I'll call upon Dr. Arindam. No, there is one last question. I'll be ready. For team E, which condition causes snowstorm appearance on uterine ultrasound? ये
H mole. Hereditary form mole.
I'll give you the answer. Yes. 10 marks to team AE. It's actually second term gestational trophoblastic disease, but I'll give you the marks. 10 marks to team E.
Thank you, Dr. Varnik. So may you have the score, please?
Yes.
Team A 20, big hand. 12.5 for team B. 5 marks, all right. अरे big hand 5 के लिए क्या है? They have hard work. Team D.
Team D 17.5.
17.5, excellent. Team E.
20.
20, very nice. A and E are leading, very nice. Fine. So we will start with the leading team, that is team E. ठीक है? इधर से उधर चलते हैं. So this round is known as a snapshot showdown. मतलब बहुत सारा फोटो पिक्चर आएगा. तो पिक्चर पे आंसर है, so you need to answer. So first is direct question to team E. Okay? अब यहाँ पे there is a trick. आपका direct question है तो you get 10 marks. अगर पास होता है and तभी correct answer मिलता है तो they get 20. अगर कुछ prompt etc होता है तो immediately cancel, 20 नहीं मिलेगा. ठीक है ना? So आपका question पहले देखो अच्छे से. Identify the incorrect gene. APP, amyloid precursor protein, presenilin 1, alpha synuclein, presenilin 2. Identify the incorrect gene. You get 10 seconds from now. A, no. It passes to team A. B marks. Negative nahi hai, yeah. No, they answered A and it is not the right answer. I will take only one more answer. Just please stop. ठीक है ना, आप बोलते मत रहो because ultimately तो diagnosis exclusion हो जाएगा ना. आप directly मुझे बोलना. I need the hand mic right now. ना कुछ नहीं है, आप मुझे बोलो. Why do you say so? They have answered alpha synuclein. The answer is actually alpha synuclein. 20 marks for them. Why? Guess किया कि पता है? I mean, just be honest. Guess किया ना? So देखो, this are from the movie what? Black. उसमें क्या disease था? Alzheimer's disease. So all of these genes, amyloid precursor protein, presenilin 1, presenilin 2, they all implicate Alzheimer's disease. Alpha synuclein है Parkinson's disease का. ठीक है? So excellent guess. Next question for team D. Right. Identify the common link. पता है आपको तो आपके पास हैंड माइक भेजते हैं. ये चारों इमेज आपके पास है.
दिस इज अ केस मतलब ये तो सर फैगट सेल्स दिख रहे हैं. इन ल्यूकीमिया का केस है एंड
चारों अलग अलग है ना? ओके, टाइम अप. टीम सी गेस करेंगे. क्या है? हाँ, इमेजेस ऑफ पेशेंट है, वो कॉमन तो है. हम सब साइंस की तरफ से वो और भी कॉमन है, लेकिन आंसर चाहिए. नो. एनी गेस फ्रॉम ऑडियंस? हाँ. हार्पिस सिम्प्लेक्स वायरस नहीं है. सो शैंकर तो ठीक है. तो द कॉमन लिंक इज आर्सेनिक. ओके व्हाई? बिकॉज देखो ये रेन ड्रॉप पिगमेंटेशन होता है आर्सेनिक में, एफएमटी में पढ़ के आया था एकदम फर्स्ट सेकेंड ईयर में, राइट? एंड वो तो प्रोमाइलोसाइट यू शुड हैव गेस्ड, राइट? एंड H2O3 पहले होता था, rodent ulcer, basal cell carcinoma is also associated with arsenic. Fine. Question to team C. This fictional pedigree represents which rare disorder? Second clue होता laminin A gene, लेकिन I have already revealed it because मान लो 10 marks, if it passes then 20. क्या बीमारी है? पास. It passes to team B. Guess? क्यों बोला प्रोजेरिया? क्यों बोला? हाँ, I mean, let them answer.
सर पा मूवी याद आया.
पा मूवी याद आया?
नहीं सर, देखने से ऐसा
सही याद आया. ऑलराइट, गिव देम अ बिग हैंड. राइट, तो यहाँ इस मूवी में सब लोग यंग बन जाते हैं, इसीलिए द क्वेश्चन हैज बीन सेट. सबका एकदम जवानी का पिक्चर है, राइट? सो आंसर इज एब्सोल्युटली राइट. दे अगेन गेट +20. अरे यार, लीड वेरी डिफिकल्ट टू कैच यू अप. ओके, एक्सीलेंट, एब्सोल्युटली. सो नेक्स्ट क्वेश्चन टू टीम C. ये तो जानना चाहिए. यूजी लेवल का है, एब्सोल्युटली. फॉर एस्टिमेशन ऑफ ब्लड ग्लूकोज लेवल, द कलेक्शन बॉटल्स आर कोटेड विथ समथिंग विच इज एन इनहिबिटर ऑफ ग्लाइकोलाइटिक एंजाइम समथिंग. क्या रहता है वो वायल में, एंड वो क्यों रहता है? What color vial do you use for blood glucose estimation? Gray, absolutely. So basically gray vial में क्या रहता है, क्यों रहता है? Okay, it passes to team B. Sir is absolutely right. DMLT लोग बोल देंगे. Team A, trisodium citrate, wrong answer. And ठीक है, okay, it passes to team E first, उसके बाद team D. E, will you attempt? आप ट्राई करेंगे कुछ भी, कोई भी कंपाउंड केमिकल? गया आपका नंबर, आपसे होते हुए गया ना. ओके, टीम डी.
सर फ्रक्टोज एंड वो इनोलेस एंजाइम को इनहिबिट करता है. वो ऊपर वाला सर, ऊपर वाला फॉस्फो ग्लूको इनोलेस. फ्रक्टोज मैंने बताया. उसके साथ वो होता है ना सर.
फ्रक्टोज के साथ क्या होता है?
समथिंग.
Okay, since it was a 20 marks pass, they get 10 marks for answering inolase. All right, it is fluoride, sodium fluoride. हाँ, F से fructose भी होता है. So अभी question 2 किसको? Please help me, I am very forgetful. B है ना? Okay, fine. अच्छे से पढ़ो. This protein was first identified when a routine pre-operative sample of a 37-year-old brakeman, steam engine होता था पहले, इंजन कोई चलाता था, ब्रेक कोई और लगाता था पीछे से, तब की जमाने का बात है. John Dash was found to have a prolonged clotting time in test tubes, even though the patient had no hemorrhagic symptoms. बस उसके incidentally सैंपल में रूटीन सीटी ज्यादा आया. He was then examined by hematologist Oscar Rentnoff who found that he lacked a previously unidentified clotting factor, जिसका deficiency AR, autosomal recessive inheritance है. So name the protein. It was named after that person, John Dash. सीना नहीं है. Yes, but you can see this.
Protein, Glangeman.
ना, pass. Answer दे दिया. 20 marks. Team A.
Stuart fact.
Stuart. No.
Sir, factor 12.
एक ही टीम से दो, इनका 20 मार्क्स काटो यार.
Sir, Hageman.
Plus 20. Question to team A, ठीक है? Direct question for 10 marks. ठीक है, so I'm giving it to you only. Identify the common link. पहले तो अरे दीवानो मुझे पहचानो, पहचानने में ही प्रॉब्लम, राइट? Yeah, I will name them. That is an excellent suggestion. देखो ये आइजक असीमोव है, रोबोट बनाया था. Arthur is a famous tennis player. Freddie Mercury is a rock band singer, and Rock Hudson is a very famous American actor. इनमें कॉमन क्या है? If you know, you know, or you can guess.
Just a wild guess, sir. Mercury poisoning से death हो गया इनका.
Absolutely right. Chocolate for them. Audience question. Identify the common link. ये मरकरी पॉइजनिंग है. क्यों? Yeah, one direct guess is swordfish that has the highest concentration of mercury. Yeah. Mad Hatter, right. Tialism. Okay, after this round, can we have the score, please? एक बार आप score बोल दीजिए. আমি খুলেছি. अच्छा ओके कैन यू आप माइक पे आके कैन यू प्लीज डिक्लेयर द स्कोर्स अच्छा एटार पावर केबल लागবে बैटरी इज रनिंग लो নেই মানে হ্যাঁ লাগিয়ে দিতে হবে তাহলে ডেল So now Dr. Varnik will be continuing.
This will be easy. This will be easy for you. Again, pathology.
Okay, তুমি স্কোরগুলো একবার বলে দাও।
Okay. So team A is leading with 60 points. Team D second with 47.5 points. Team E third with 20 points. Team B fourth with 12.5 and Team C with 5 points. Backup team C. Okay. Okay. So, pattern analysis, Madam was talking about pattern analysis today. What you see is what you get under the microscope. So, you look at a particular pattern under the microscope, it reminds you of certain thing. So, I'll show you the thing, but what it reminds you of, you have to tell me which disease that condition कौन सा डिजीज के साथ वो पैटर्न एसोसिएटेड है सो
Sir, adenocarcinoma of stomach. Gastritis plastica. Sir, gastritis plastica, like.
Hello.
Sir. मिलेगा भी ओके कार्सिनोमा तो है कुछ तो प्लास्टिक है सर
I'm really shocked. कौन सा टाइप ऑफ that cancer? Gastric cancer type.
Lintis plastica, sir.
You've already lost your chance. Anyway, you'll be getting 5 points, but other teams you have deprived them of a chance to get some bonus marks. Yes, it is the leather bottle that you saw, and it is seen in the diffuse type of gastric adenocarcinoma, also known as Lintis plastica. Gastric plastica नहीं. नहीं पास तो होना था लेकिन वो टाइप ऑफ कैंसर वो लोग नहीं बता पाए नहीं उन्होंने बोल दिया ना उन्होंने तो ऑलरेडी आंसर वो बाद में उन्होंने बोल भी दिया इसके बाद अगर ऐसे 2 आंसर अगर दिए तो नेगेटिव माइनस इसके पहले भी फैक्टर 12 ऑलरेडी हो चुका है वी रिमेंबर दैट विविडली सो इसके बाद और वी वोंट टॉलरेट दैट सॉर्ट ऑफ डबल आंसर्स team B. ये क्या है सबको पता है, लेकिन ये जो टर्म जो है इसके साथ एसोसिएटेड एंड द अपीयरेंस ऑफ the discharge from those spots, that is the key. Huh? Comedone.
Open comedone.
So
Acne.
कौन सा डिजीज के साथ एसोसिएटेड है?
Acne.
अरे यार तुम लोग कौन सा डिजीज के साथ एसोसिएटेड है? Comedo is associated, that term associated with which disease? कौन सा डिजीज? वो भी बता दिया, डिजीज का नाम तो बताओ. कौन सा कैंसर? अभी ऐसे कितना फ्रॉम
सर
melanoma.
Sir.
They have got to the closest. I think they deserve the bonus for that 2.5. Comedonecrosis. ब्रेस्ट कैंसर बोलने में क्या दिक्कत है? नमिता, आई थॉट यार इसको भी मिलना चाहिए. ठीक है, 5 ढाई इसको. ये सच में इतना इजी तुम लोग चीज को तुम लोग सामने आ जाओ ना. क्वेश्चन 3 to टीम सी. हाँ,
Salt and pepper.
डिजीज कौन सा डिजीज?
Neuroendocrine tumors.
Correct. At least you have got full answer up till now. First team to have got 10 marks. Question to team D.
सर ये स्टेनोसिस गैस्ट्रिक स्टेनोसिस एक्लेजिया सर एक्लेजिया कार्डिया नहीं या सर रेक्टल
इन
सर
क्रॉस बोल रहे हैं
सर
जल्दी
Stricture in ulcerative colitis.
तुम सब हो गए ऑडियंस
Atresia.
क्या बोला? पाइलोरिक स्टेनोसिस.
Atresia.
हाँ, इसे अंकिता को ऑडियंस प्राइज दे दो. नैपकिन नहीं बोला उसके लिए. दो ले लो अंकिता. दो मिलना चाहिए. डिजीज, आई हैड आस्क्ड फॉर द डिजीज. यू कैन 2.5 नहीं, आई थिंक 1.5 দরদাম করে question for you. Zinc? Ring sign क्या होता है? What is ring sign?
Signet ring sign.
Signet ring कौन सा डिजीज में मिलता है? Signet ring? ये तो कुछ महीने में तुम फाइनल एग्जाम देने जा रही हो सिग्नेट रिंग पे कोई नहीं 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 यही हालत है
Adenocarcinoma. Adenocarcinoma.
Which type? Which type?
Adenocarcinoma of colon.
Type. Type बोलो यार.
Clear.
क्या?
Sir, signet ring sign seen in ये सर gastric carcinoma में.
Which type?
Adenocarcinoma.
Which type?
Just नहीं सर adenocarcinoma.
कौन सा gastric adenocarcinoma कौन सा type? Mucinous or diffuse type at least वो तो बोलना था. The type of adenocarcinoma is called signet ring adenocarcinoma or diffuse type. बोला था इन्होंने? Clear cell बोला ना? I heard clear cell from them. Adenocarcinoma नहीं, signet ring carcinoma या diffuse carcinoma of the stomach. Either. फिर आधा डायग्नोसिस ऐसे आधा लिखोगी तो पेशेंट का ट्रीटमेंट आधा ही होगा. ओके. Signet ring cell adenocarcinoma is seen in a lot of other organs other than GI. So स्टमक के अलावा बहुत अलग अलग जगह पे signet ring adenocarcinoma मिलता है. No, not always. हाँ, correct. Intracellular means correct, exactly. Ashtava has hit the nail on the head. It is intracellular mucin and it's not called mucinous adenocarcinoma. You have to mention signet ring cell adenocarcinoma. क्या? हाँ चलता.
होगा scores please. 2 more बस. Team A 60, Team B 50, Team C 50, 15, right? Right, 47.5, 22.5. Fine. Now this round again will start from Team E. ठीक है. एक क्वेश्चन साइंटिस्ट का फोटो दिखाएंगे, नाम बोलना पड़ेगा. सिंपल. इफ यू नो बेटर, इफ यू डोंट नो इट विल ओनली गो टू द ऑडियंस. ये पास नहीं होगा. दिस राउंड विल नॉट पास. यू कैन गेस बट यू विल नॉट गेट एनी मार्क्स. फाइन. Direct question without any passing. कौन है? अगर नाम नहीं याद है तो भी एटलीस्ट यू कैन से क्यों फेमस है. टीम E, right? Question for team E. Direct question, 10 marks, it will not pass. बोलिए.
Rudolph.
No. Why do you think this scientist is famous? नाम तो छोड़ ही दीजिए. If you can say why he is famous, we will give you marks because it's tough. ये tough round है. क्या डिस्कवर किया इन्होंने? DNA नहीं. Anybody? Freely raise your hand. I am not passing sequence wise.
Carbon bonds.
What molecule, what biomolecule इन्होंने डिस्कवर किया? जो भी बोलेंगे सही बोले तो चीख के बोलो. माइक वाइक पास करने का भी टाइम गया. चीख के बोलो. सही आंसर चॉकलेट खत्म. हाँ, हीमोग्लोबिन. हाँ, प्रोटीन ही है लेकिन प्रोटीन तो बहुत पहले डिस्कवर हो गया था, राइट? डायरेक्ट क्वेश्चन फॉर टीम बी. नो प्रॉम्प्टिंग प्लीज. यू मे नो हिम, यू और मे नॉट. इन्होंने क्या डिस्कवर किया था? नाम छोड़ दो. नाम में क्या रखा है? नाम इज टू टफ एक्चुअली. व्हाट डिड दिस साइंटिस्ट डिस्कवर और व्हाई इज ही नोन फॉर? No negative marking. Fine. Time up. Anybody? क्यों फेमस है ये? नोबेल प्राइज. सबको नोबेल प्राइज मिला. नोबेल लॉरिएट से ज्यादा हम लोग ये प्लेटफॉर्म में नहीं लाते हैं.
RNA.
Anything else? और क्या क्या? Anyway, मतलब आंसर केम आफ्टर DNA. He did not discover DNA. He discovered DNA polymerase. DNA replication कैसे होता है? He is Dr. Arthur Kornberg. Okay, direct question for team C. ठीक है ना? 10 marks. हंसते हुए दोनों इंसान.
नशे.
बहुत खुशी है लाइफ में, नोबेल प्राइज मिल गया, लेकिन क्यों हंस रहे हैं ये बोलिए. ऐसा क्या डिस्कवर कर दिया कि एकदम पूरा क्लोजअप स्माइल? नो प्रॉम्प्टिंग, नो प्रॉम्प्टिंग प्लीज.
Protein.
नो प्रोटीन. ओके, चॉकलेट वालो बोलो. फिर से चॉकलेट. Yes, Watson and Crick DNA structure. This is supposed to be found in every UG textbook. DNA. ये पिक्चर तो मिलता है. So अभी क्वेश्चन फॉर टीम बी. आपका ना? टेन सेकेंड्स लो और बोलो. मैरी क्यूरी मत बोला. आई एम नॉट टेकिंग दैट आंसर. एक और गेस. नो. टाइम अप. फेल राउंड. ऑडियंस? नो.
टाइफाइड के रिलेटेड है सर.
हाँ, यू ट्राई. क्या है?
टाइफाइड के रिलेटेड.
नो. Yes, jumping genes. Okay, last question to team A. क्या डिस्कवर किया इन्होंने? नाम तो छोड़ दो. नाम में क्या रखा है? You can try. What did they discover or for which they are famous? No? Okay. Anybody in the audience? This actually should have been answered क्योंकि ये अभी बहुत trending topic है ना? So they discovered CRISPR-Cas9. ठीक है ना? And this is the one topic, irrespective of your discipline, you should be well prepared for final exam. MD पूछेंगे ही जो भी है. right? Okay, so one question for the audience. ये कौन है? Who is this famous person? दो पिक्चर है, क्योंकि एक ही इंसान का दो पिक्चर, एक जवानी, he got Nobel Prize twice. Once while he was young, when he discovered something, again 20 साल बाद. No, both in science. Very important. Of course, important तो है, वरना Nobel Prize क्यों देते उन लोग, है ना? So, okay, fine. So, this is Dr. Frederick Sanger, very important. So, in his early life, he was the first person who discovered the sequence of insulin that changed the face of diabetic treatment. And then again, he discovered DNA sequencing, so which we use a lot now, Sanger sequencing, ठीक है ना? So, yes, can we have the scores please after this round? इसके बाद एक और ही round है. Okay, now the game changes altogether. अभी जो दो टीम है, they are qualifying for the final rounds. ठीक है ना? आप इतना लीड हो, इसका मतलब ये नहीं कि आप जीत गए और कोई कैचअप नहीं कर पाएंगे. So team A and who is the second team? बस A and E will now compete for the first prize. ठीक है? आप दोनों आगे आओ, बाकी सब ऑडियंस for this round. ना A and D, A D, अच्छा है, very good. So are you ready? Fine. A come forward. না এরকম করে রাউন্ডটা করা যায়, নাহলে তোরা এত এগিয়ে গেছে কেউ ক্যাচআপ করতে পারবে না.
এই রাউন্ডটা আমি নিচ্ছি।
হ্যাঁ,
এই পরের রাউন্ডটা লাস্ট রাউন্ডটা
না না সেটা ঠিক আছে, তুমি এই রাউন্ডেই মানে এক একজনকে ডবল ডবল করে কোশ্চেনটা করে নাও, বুঝলে তো? টাইম অনেকটা হয়ে গেছে না, ওই জন্য অনেক রাউন্ড হয়ে গেছে। ঠিক আছে, তুমি তোমার অল টোটাল কটা কোশ্চেন আছে এখানে? 5টা কোশ্চেন আছে তো, ঠিক আছে। তুমি 1 2 করো, আর হ্যাঁ থার্ড, হ্যাঁ আর থার্ড প্রাইজ অলরেডি এখন, হ্যাঁ তো থার্ড প্রাইজ অনেক পিছিয়ে আছে অ্যাকচুয়ালি, বুঝলে তো, ধরতেই পারবে না। ঠিক আছে,
कुछ काम था, आ रही है सर, 2 मिनट।
नमिता को दे देना। So all of you will get equal opportunity to score. No negative markings, so 10 marks for right answer, no passing. लिखने के बाद पेपर दे देना, इजी वाले पूछेंगे। ये ये वाला और इसके बाद एक डॉक्टर अरिंदन सर और एक राउंड लेंगे, जल्दी हो जाएगा. युवराज सिंह was diagnosed and treated for which cancer? Don't prompt. Don't prompt. Don't prompt. लिखा है कुछ? हाँ, दे दो. कागज ले लो. आंसर साथ साथ में. एकबार है, ठीक है. हाँ, इसके बाद तो आंसर. আমি ওর জন্য তো বলেছিলাম এটা নর্মাল রাউন্ডের মতো নিয়ে জিনিসটা করতে বলেছিলাম ওর জন্য. এভাবে করতে গিয়ে আরো টাইম আরো লেগে যাবে. क्या हाँ. No, none of them have given the right answer. 0 to everybody. Mediastinal seminoma. Question 2. हाँ. Which Bollywood actress was diagnosed with multiple myeloma, underwent stem cell transplant and wrote a book close to the bone? दे दो लिख के फटाफट. तुम चुप करो ना. सरनेम नहीं है इसका.
Check and then say.
हाँ. Team A, they have got it correct. Team question. Sanjay Dutt diagnosed and treated for. ten. इसमें 10 या 0 कोई पास नहीं है. जल्दी.
फटाफट.
HCC तो तुम लोगों ने दिया है. अच्छा. लंग कैंसर. सो टीम इन दोनों टीम को 10 मार्क्स. दे आर गेटिंग 0. Team question 4. Which Bollywood actress wrote a book titled Healed How Cancer Gave Me a New Life after being treated for ovarian cancer stage 4?
Team E. Link of an item for DSP.
So team A and D have got 10, team E 0. Sonali Bendre was treated with for which cancer? ये लोगों ने एकदम सही पकड़ा है. So all three teams get 10.
No, we give the chance to all three of them for the next 2 rounds. So इस round में भी all three of you will be competing. जिसका score सबसे ज़्यादा होगा उसके basis पे 1-2. ठीक है? Your score from this round will count. So team A has got 30, team B 30, and team E 20. So 30, 30, 20. Yes, last round. The name of the round is A, B, C, X, Y, Z. Yeah, you will get a big question जहाँ पे you need to identify. Simple written answer. Question देखिए समझ में आ जाएगा. ठीक है? क्या A, क्या B, क्या C, क्या X. हेलो. ফাইনাল यहाँ पे ফুল এন্ড ফাইনাল. যে কোনো হ্যাঁ ওরকম লেখা যায় আশেপাশে একটা হয়ে গেলেই হলো. Just you need to write 6-7 words, that's it. Fine. So 2 question है, ठीक है? Only 2 question for all the participants. For the first question, points, each answer has got 5 points, right? For each A to H that you write, there is no negative marking. अच्छे से पढ़ो, बहुत descriptive. So a German physician A, right, gave up his medical practice as he was dissatisfied with the state of medicine in his time. So basically what is written here, he thought that what am I doing? There is a disease that is going on and with my medicine I cannot treat even my colleagues, right? So मुझे जानना है कि ये बीमारी क्या है. So I gave up my practice of medicine. So अपना practice सारा छोड़ दिए and he devoted his next few years in trying to understand the disease. Fine. So अब शुरू होता है क्वेश्चन. A came to read about B. A ने B के बारे में पढ़ा जो कि एक पेड़ है. A plant, the bark of which has some remedial powers to cure the disease C. The plant B was so named by Carl Linnaeus. Carl Linnaeus कौन है? ये second paragraph में. I'm not going to read, you read it. The fourth count of this town was the viceroy of Peru. इतिहास है. And his wife Anna de Osorio suffered from C. ये बीमारी ये इसीलिए important है क्योंकि किसी महान व्यक्ति को हुआ था, right? मुझे होके मर जाता तो who cares? I'm just saying. And was cured after taking the medicine that was prepared from B. Okay, keep thinking, बहुत सारा clue मिलेगा. अब there are few facts of history जो says that the lady, the wife took the drug B to Europe. That has been proved wrong. So ये हुआ ABC. अब D and E are 2 active alkaloids contained in the bark of B used medically. D was once commonly used to treat C. अब this D has many roles. European colonization में role है, white man's grave भी बोलते हैं इसको, and it is also one of the essential medicines in WHO list. I'll come back if you need to revise the question, I will come back to the slide again. अब E, अगर D तक पता चल गया, अब E is a stereoisomer of D, which is also class 1 antiarrhythmic. Dash annua is a common herb found in many parts of the world and has been used by Chinese herbalists to treat C. इसके ऊपर भी एक छोटा सा इतिहास है. This might not be important if you can identify C by now. अब तक जो पता है लिखो. अब इसी बीमारी पे रिसर्च करते करते एक और साइंटिस्ट जिनका नाम है एफ, उन्होंने डिस्कवर किया जी, वो भी एक पेड़ के पत्ते पे, जिनके लिए उनको नोबेल प्राइज मिला. बोला ना, जो भी है नोबेल, हमारा लेवल एकदम टॉप है. अब लास्ट बहुत सारा है. ए बिलीव्ड और भी कुछ है. दिस इज नॉट द एंड. तो उन्होंने क्या किया, अपने आप को ही वो ड्रग दिया. सो इफ द ड्रग कैन इंड्यूस सिम्टम्स इन नॉर्मल इंडिविजुअल, दैट कैन ऑल्सो ट्रीट द सिम्टम्स ऑफ अ डिजीज. सो इतना कुछ. सो आई एम अगेन गोइंग बैक टू two E's from each and two same, सबको same clue. A is a person. Yes. Right. C is a disease, A is a person, B is a plant. Yes, absolutely. D and E are two drugs. Absolutely. F को Nobel Prize मिला तो person. अब जी फिर है और एक और ड्रग. ओके, बस टाइम अप. We will return you this paper. So in this round, team A got 2 right answers. They correctly identified cinchona and malaria. They get 10 points. The rest of the team, you don't get any point. Well done. So one last question left. If this round is a tie, we will calculate the back score and see who is. मिल गया आपको पेपर जिस लिखे थे. So this is the last question. X, the extraordinary story of a wonder drug. This is an article. ये पेपर ही है. So in the book, Jeffries has associated a drug with collapse of Russian Empire. ऐसा क्या हुआ कि रशियन एम्पायर ही गिर गया. सो एलेक्सी द सन एंड हेयर ऑफ द लास्ट जार, रशिया में किंग नहीं होता था, जार होता था, राइट, सफर्ड फ्रॉम द डिजीज वाई. सो एक वाई एक बीमारी, डिजीज जिसके लिए वो जार के बेटे को डॉक्टर्स प्रेस्क्राइब द मेडिसिन एक्स. पॉपुलर ड्रग, तब बहुत पॉपुलर था, नॉट नोइंग दैट एक्स कैन एक्चुअली कॉम्प्लिकेट प्रोसीडियर इन पेशेंट्स ऑफ वाई. सो वाई इज अ बीमारी, एक्स इज अ ड्रग. तभी उनको मालूम नहीं था कि एक्स ड्रग अगर देंगे तो वाई और भी बिगड़ जाएगा. तो उन्होंने क्या किया, देखा कि पेशेंट डॉक्टर्स, लोकल डॉक्टर्स ने हम लोगों का बच्चे को दे गिव सच अ ड्रग जिससे इनका तबीयत और खराब हो जा रहा है. तो इन्होंने लेके आए एक पर्सनालिटी, पर्सन जेड, जो क्या बोले, जो बोले नहीं ये सब दवाई ववाई छोड़ दो, यू बिलीव इन गॉड, सो डू फेथ हीलिंग, भगवान को याद करो, आपका पेशेंट, आपका बच्चा ठीक हो जाएगा. ऑलराइट. सो एक्चुअली व्हाट हैपेंड, द ड्रग एक्स वाज विथड्रॉन, जिसके वजह से द पेशेंट एक्चुअली स्टार्टेड इंप्रूविंग. इट वाज नॉट ड्यू टू फेथ हीलिंग, राइट. एंड ड्यू टू दिस थिंग, दैट जेड पर्सन had a very important influence, historical influence, जिसके वजह से ultimately that led to the downfall of the Russian Empire. Identify X, Y, Z. एक बीमारी है Y, एक ड्रग है X, and एक पेशेंट है, एक पर्सन है Z. X, Y, Z. Last question, decisive. किसी ने कुछ लिखा? नहीं लिखा तो नो नीड टू कलेक्ट द पेपर. You wrote anything? Okay. Team A has answered Y as anthrax. Team D has answered Y as smallpox and steroids X, and team E has answered aspirin and hemophilia. Absolutely right. This is a published article, you can read it, it's about aspirin. So, वो जार के बेटे को था हीमोफीलिया, एंड तभी कुछ भी चीज के लिए लोग एस्पिरिन दे देते थे, सोचा कि इसमें भी दे देंगे तो ठीक हो जाएगा, लेकिन हुआ नहीं, है ना. सो दे गेट 10 points in this round and the other two teams don't get any point. Ten, 5 plus 5. Gaive. Okay, so finally let's have the scores. Team A 40, B 30, E 30. Fine. So at this point of time, we declare Team A as the winner. ठीक है? अब Team D, since we have a tie, I cannot let it go, right? So Team D और Team E, आप Team D और Team E. और क्या करें? Definitely. हाँ, sudden death sort of thing. So no, each of you cannot beat each other till now, ठीक है ना? एक निरापद दूरी बनाए रखे, एक keep safe distance. Okay. Question 2. देखो, it is an open question for both. Listen to me. Open question for both with negative marking. ठीक है? So your score can be negative, but you can still get the second position. ठीक है ना? So this is not an open house audience question. This is a tiebreaker round for them. Team D and team E. Spirochete disease named after US town mimics JRA. No, oh, this is very problematic because if they don't answer, if they skip answer every question, then they will see. So, इसका आंसर कोई दे पाएंगे? हो गया. You don't read the answer, you tell the answer. देखिए, बोलिए. UG level. What is this? What is this hypothesis known as? Raise your hand and then tell. ऐसे मत बोल दीजिए. Brain का pressure बढ़ रहा है and brain is herniating because skull has a fixed volume. This is known as এটা পারা উচিত physiology, yeah, first year. Fill in the blank. ये हैरिसन का एक चैप्टर है. विलियम ऑसलर ने ये कोट किया, ह्यूमैनिटी का 3 दुश्मन है. एक है युद्ध, वॉर, एक है फेमिन. क्या है?
सर वेल्थ है फर्स्ट वन.
वेल्थ.
अच्छा डिजीज.
हाँ. So you get a -5. Yes, we had to decide. So what will be the answer पता है? ऑस्लर ने बोला था हंगर तो फेमिन के साथ ही आता है, फेमिन आएगा तो हंगर आएगा. फीवर. आपसे फिर से चॉकलेट. राइट. So बस ठीक है, ठीक है. Do we have many more question for the audience? So yeah. So we now have the. अब इन लोग आंसर नहीं करेंगे. There are 1 or 2 questions for audience. पता है ये क्या चीज है? ऑस्ट्रेलियन. हाँ बस और 2 ही क्वेश्चन है. बना के लाया तो आप भी आंसर कर ही दो. एक चीज था पहले से प्लास्टिक का, बहुत बहुत बना, फिर एक कैरोलाइट डिवाइस्ड अ सेफर वर्जन. बहुत यूज होता है. नो? एनीबॉडी, एनी गेस? एनी मेडिकल इक्विपमेंट? चॉकलेट, चॉकलेट, चॉकलेट. सिरिंज है. Absolutely right. इंट्रैक्टेबल हिकअप जब होता है ना, लास्ट क्वेश्चन है, दिस इज लास्ट क्वेश्चन. इसके बाद जो भी हो विल बी रैप अप. बंद कर देंगे, केबल खोल देंगे. सो आवर पेरेंट्स, दादी माँ, बहुत लोग बोलते थे कि अगर बहुत सारा मतलब हिचकी आ रहा है तो ये सब करो. कमता है, नहीं कमता है, but what is the only medical, we are not talking about injecting largactil and all that, medical way without any drug. क्या क्या क्या? ना बैक्लोफेन तो हाँ मेडिसिन हो गया. कोई कोई भू ऐसे करके बोलते कि मतलब गया हिचकी, तो ऐसा नहीं है. The actual answer, you can read it in the published literature, it is digital rectal stimulation. Okay? So chalo, that's all. Chalo, thank you all. So Dr. Barnik will come up on stage and he will declare the winners and with the name of team members.
Okay, so I invite the first team A, represented by Dr. Sonalika and Dr. Sadaf, to receive the first prize. Dr. Ashok, आ जाइए. आप ही दीजिए प्राइज.
टीम बी और सी को बुलाइए, पांचों को प्राइज दे रहे हैं.
हाँ, पांचों को देंगे.
टीम बी और सी पहले बुलाइए.
Okay. Just a moment. All out of his magnanimity, Dr. Ashok has agreed to give prizes to all 5 teams. So a big hand to Dr. Ashok for this gesture. Team B and C. Team B and C, आ जाओ. Deepak. And yeah. Dr. Deepak and Dr. Reshu, sorry. I my mistake. And team C, big hand for team B and C.
सर आ जाइए आप लोग भी, मैडम आइए.
आ जाओ.